So for us, as the Globe Fund, we are excited to listen to discussions and look forward to more details coming out from the stakeholders that are gathered here today. And we look forward to more in-depth details of the plan strategies and interventions. And we look forward to new ideas and innovation that will help us move the agenda for HIV and TB treatment in children. I also look forward to, of course, listening to the different presentations that will highlight the challenges and bring new ideas to strengthen the response. So the Globe Fund stands with the government and people of Kenya in the fight against HIV and TB, and we look forward to our continued collaboration in the fight against these diseases. I thank you, and I look forward to a great deliberation. Over.
Thank you, John, for your remarks, and good to hear the commitments from the Global Fund and what you're looking forward to support currently and even in the upcoming grant. So thank you so much. So at this point, we want to welcome Dr. Tamu. Going next, or do we? Are you available?
Yes, sir, I'm here.
All right, thank you so much. So I would like to welcome the next speaker, Dr. Daniel Tamu. Dr. Daniel Tamu serves as the PEPFAR country coordinator in the U.S. mission to Kenya, and as a representative of the Office of the Global AIDS Coordinator at OGAC, she leads the U.S. government interagency team in the design and implementation of HIV/AIDS activities, alongside colleagues in the U.S. implementing agencies as CDC, DOD, Peace Corps, and USAID. TAM has the responsibility of working in strong partnership with the government of Kenya, civil societies, multilateral and bilateral organizations, as well as implementing partners to create a sustainable control response for health and betterment. There's someone, please mute your microphones. Admin, please mute the microphones. Admin, please mute the microphones of the people in the background. Thank you. So Dr. Tam has worked before in a number of countries, including South Africa, Zambia, Uganda, and other countries. She has previously, before joining USG, she had a 25 years experience in HIV research in both
Dr. Lasalas, we cannot hear you.
Oh, sorry. My apologies for that. Sorry for that. Yeah, so I was just in the process of introducing Dr. Tamu. So through the PEPFAR program, the US government has contributed more than $7 billion USD to Kenya to prevent spread of HIV and AIDS since the year 2004. Currently, PEPFAR Kenya stands as the leading donor in the country's HIV response and maintains one of the largest portfolios amongst all PEPFAR countries. So, karibu sana, Dr. Tamu.
Thank you so much, Dr. Mamani. Just confirming that you can hear me well.
Yes, we can hear you.
Perfect, thank you. So of course, to leadership and representatives from national and county governments, colleagues from the UN family, the Global Fund, PEPFAR and other development partners, partners representing civil society and faith-based organizations, guests and ladies and gentlemen, definitely a wonderful good morning to all of you. And I'm very happy and excited that we are actually having this engagement today. Under the leadership of the government of Kenya through the coordination by the National TB Program, NAC and NASCOP, and the PEPFAR Kenya team, we thank you, the multi-sectoral committee who worked over the past few weeks to make certain that the next 2 days were possible. This is the second of the two-phase UNAIDS PEPFAR supported work with the faith and community leadership. So it's a pleasure to be with all of you today to celebrate our combined achievements, but also to acknowledge the strides that we have ahead of us to fully succeed in the service delivery for prevention, care, and treatment for HIV and TB children in the COVID-19 world. I know you'll hear more details on specific data as part of this meeting, but I'll provide some key perspectives in relation to the theme of this consultation, pediatric HIV and TB, optimizing accessibility and accountability. While Kenya has made tremendous gains in pediatric HIV programming, noting that nearly all children identified and tested are on ART, there remains two outstanding gaps in the first and third 95. Unidentified HIV infected children and among children on ART. Scientific evidence, of course, shows that children and adolescents should draw similar benefits from ART regimens as adults do. While Kenya is privileged to be an early adopter of optimal pediatric regimens, with a huge thanks to the Ministry of Health and NASCOP for spearheading a robust optimization strategy for children more than 20 kgs to DTG. As a country, we need to prepare for yet another transition to target and benefit children less than 20 kgs with pediatric DTG. This may significantly increase viral suppression rates amongst CLHIV through better accepted and administered regimens. Recently, PEPFAR program data shows that 10 PEPFAR supported counties have achieved the 90% mark in pediatric viral suppression. This is laudable, and I, of course, commend the healthcare workers, caregivers, and children and adolescents who have made this possible. But to close the remaining gap on the third 95, we need to go back to the first 95 and reimagine pediatric case identification through adoption of cost-effective and highly efficient strategies, such as those that John mentioned, that will find the remaining unidentified children while maintaining a low number needed. We are optimistic that these strategies will be impactful and ensure our children are HIV-free, and for those who are positive, that they'll thrive and remain AIDS-free. In general, TB remains a leading cause of morbidity, virologic failure, and death amongst PLHIV, including children. While the country has a strong, robust, globally recognized TB-HIV program, we remain fully cognizant of the fact that we cannot achieve TB-HIV targets without comprehensively addressing TB among people not infected with HIV. Thus, PEPFAR continues to prioritize and fund integrated TB and HIV case finding strategies at all service delivery points, including MNCH and adolescent and young people's clinics. Broadly, a fishnet approach is adopted in case finding, ensuring that all individuals screened to HIV testing eligibility are also screened for TB, and all presumptive TB cases are tested for HIV. Currently, PEPFAR is focusing on optimizing TB case detection in priority populations, including OVC, as well as enhancing regular and TB contact tracing. Recognizing the challenges faced by clinicians in diagnosis of tuberculosis among children, PEPFAR has invested in implementation studies that determine optimal TB diagnostic algorithms, including use of stool for TB diagnosis in children. Lastly, PEPFAR supports the introduction of shorter, patient-friendly TPT regimens, including 3HP and 3RH, targeting initiation of at least 90% of eligible CLHIV on TPT. To sustain TPT completion rates above 90%, active screening of adverse drug reactions, pharmacovigilance, and patient support will be enhanced to clinical and community settings. PLHIV communities will also be engaged to support patient literacy and program monitoring. In closing, I'm looking forward to fruitful discussions over the next 2 days. And as partners, let us continue to work together towards epidemic control and help Kenya meet its development goals and beyond. The American people through the US government continue to stand along Kenya, the government of Kenya, and all Kenyans as we strive towards maximizing resources in order to reach more lives and experience an HIV-free generation while adapting to the unique challenges that we all face under COVID-19. Sincere thanks for all of your time. Thank you. Dr. Momanyi, back over to you.
Thank you so much, Dr. Tamu, for your kind remarks, and again, reiterating the commitments of PEPFAR to the country and the support that's available even for some of the interventions that we shall be discussing. So allow me now to introduce the next speaker. Who is Medine. Medine is the UNAIDS country director to Kenya since the year 2019. She provides strategic and coordinated support of the 11 UN agencies to the national AIDS response, leveraging partnerships at all levels that are aligned to the national priorities and UNDAF. Besides, she coordinates the UN Health Partnerships, H6, that harnesses the collective strength of UNAIDS, UNFPA, WHO, UNICEF, UN Women, and the World Bank Group to strengthen RMNCH programming towards universal healthcare, one of the big four agenda advancing women, children, and adolescent health in Kenya. She also co-chairs the PHC window of the SDG partnership platform together with the MOH and the Council of Governors. She also represents the multilateral development partners in the Global Fund coordinating mechanisms, partners closely with the PEPFAR in mobilizing resources and planning processes to prioritize high impact intervention to support Kenya's effective AIDS response. Prior to joining UNAIDS, she worked with the Federal Ministry of Health of Ethiopia as the Chief of Staff from 2006 to 2011. During her service, she guided the development of health sector reforms, community-based health extension programs, as well as some flagship programs. Previously, she has worked in the Institute of Biodiversity of Ethiopia as the manager of the conservation and sustainable use of medical plants program that aimed at validating safety and efficiency of traditional medicine, documentation of indigenous knowledge, and promoting conservation of medicinal plants. She has a 29 years experience in public service in various fields and capacities in academia and socioeconomic development work. Welcome, Medine, for your kind remarks.
Thank you so much, moderator, for the generous introduction. Government representative, both national and subnational level, our faith leaders, development partners, communities, dear participants, good morning. I'm pleased to be here virtually and wish to thank the organizers for the foresight and the commitment to move this critical pediatric HIV and TB agenda forward. I extend my warmest thanks to the government of Kenya as our host, represented by Dr. Masha of NAC, Dr. Ngugi of NASCOP, and Dr. Wako Ergesio of the National Leprosy and Tuberculosis Program, and their entire team of technical experts for their strong leadership and unwavering commitment and bringing us together to this important national multi-stakeholder consultation on pediatric HIV and TB. I want to wish you all a happy Madaraka Day. I know it was yesterday. I hope you all had a wonderful celebration. Let me continue. I want to express my special appreciation to community networks of PLHIV, KPs, adolescent young people, faith communities, and the civil society organization whose passion and commitment continue to spur us to work harder, and also for having played a critical role in the organization of this event under the leadership of NASCOP, NAC, NASCOP, and LTD program. Your presence continues to remind us that without putting people at the center, especially children, our work is in vain. Allow me to thank my colleagues who are on the call, Manisa, UNICEF rep, Dr. Rudy, WR, I know they have confirmed, so hopefully they are online. Dr. Adimola of UNFPA, Dr. Anteres, the UNESCO Regional Director, and Ms. Anna Mutavati, UN Women Rep, for their support through their technical focal points, who have played a significant role in the organization of this consultation under the leadership of government. I also recognize and thank my colleagues, Dr. Tamu and Mr. Ochero, who spoke before me, for their support, the commitment, and also the partnership in the overall AIDS response. We commend the United States of America for its steadfast and generous commitment through PEPFAR and for its partnership through the UNAIDS PEPFAR Faith Initiative. Allow me to thank my colleague Jacek and the team in UNAIDS headquarters who have supported us with the planning and finance to facilitate this consultation. Ladies and gentlemen, this is an important meeting that comes at an important time because in the next few days, the world is meeting at the UN high-level, we'll have a UN high-level meeting on HIV and AIDS to review the progress made in reducing the impact of HIV since 2016, when we have had the political declaration, and to adopt a new political declaration to guide the future direction of the response for the coming 5 years. The 2021 high-level meeting will be the springboard for a decade of action to reduce inequalities and root out the social determinants that fuel the HIV epidemic. The good news is that we have reached a stage where we can see that more than 40 years of work on AIDS has delivered results. Today, fewer people are becoming infected with HIV than there were 5 years ago, primarily due to the scaling up of prevention efforts, and fewer are dying of AIDS, partly as a result of increasing access to treatment, which is the case in Kenya, as it was presented by our moderator. However, we know that children are still lagging behind. They need to be tested and linked to care and treatment as a matter of urgency, but we are missing these opportunities. We must come together and act with renewed commitment to children and give them the best chance to survive and thrive. Therefore, this national multi-stakeholder consultation on pediatric HIV and TB is so important, as the previous speakers alluded to it. In the past 40 years, experience has shown us that there is no single way to tackle HIV and AIDS, and that no single organization or sector that can do the job on its own. This principle is now more relevant than ever on the subject matter we will be discussing in the next 2 days. And I'm very happy to see the high level of participation because we have more than 200 participants on this call. I take this opportunity to thank the UN family, specifically, my organization UNAIDS, UNFPA, UNICEF, and UN Women, who responded positively in support of the emergency procurement of pediatric ARV to ensure continuity of treatment services for children. Finally, on behalf of UNAIDS and the entire UN family, I pledge our support in working with the government, the faith communities, PLHIV communities, KPs, AYP, civil society, NGO, multilateral and bilateral partners to take forward the national action plan that will be agreed to at this meeting. We all encourage our partners, all of us, to direct resources where they will have most impact for children. And lastly, let us move forward in bold and new spirit of partnership to overcome the cycle of pediatric HIV and TB and deliver health and well-being for all our children in line with the universal health coverage agenda of Kenya. I thank you very much for your attention. Over to you, moderator.
Thank you so much, Medine, for your kind remarks from the UNAIDS perspective and also just hearing the commitments that UNAIDS is making to this initiative, and we truly appreciate. At this point, I want to welcome my co-moderator, Dr. Lorraine.
Okay, thank you very much, Dr. Momanyi. We'll change gears a little bit, and now we will have Ms. Zaman Maniza, who will be taking us through the UNICEF perspectives. Ms. Zaman is the UNICEF representative currently. Apologies. She's the UNICEF representative in Kenya, and she has been serving in this position since 2019. And prior to this, she was the UNICEF representative in the United Republic of Tanzania. And she has been serving and particularly engaged in developing strategic management initiatives, planning and monitoring, and has also served as the deputy representative in Vietnam. So at this moment, we would like to welcome Ms. Zaman Maniza to this particular forum. Over to you.
Okay, good morning, everybody. Just testing that you can hear me, please.
Yes, we can hear you.
Okay, all right, excellent. Thank you so much. Dear colleagues, participants, just allow me please to adopt the salutations of my sister Medine, and I really want to acknowledge this broad spectrum of colleagues who've come here for this very, very important meeting. Good morning to you all, and it's really a pleasure for me to join you here today. First of all, I just want to say I hope you're all doing well and your families as well in these extraordinary COVID-19 times. So please keep on keeping safe and do everything that you need to keep yourselves and your families safe. So let me say a few things. First of all, I think it's truly motivating to join you here today because we share one common goal, which is to end HIV and TB in children. And these are actually life and death issues. As much as we talk about data and statistics, there are lives behind each of these numbers. And so when we have 1/3 of children living here with HIV in Kenya still not getting the ARV treatment they need and putting them at risk of dying due to AIDS-related illnesses, it is a tragedy. And I think the colleague who spoke from the Global Fund actually said no excuses, if I'm not wrong. So on top of this, we also have children who are dying from TB, which is the most common opportunistic infection among people living with HIV, and to one which adolescents and children are also most susceptible. So ladies and gentlemen, as we begin this time of working together this week, let me draw your attention to some of the most pressing issues in this field, perhaps a little bit of a repetition from earlier speakers, but I do think it's important that we focus on these. So first, and I think very worryingly, children are being left behind in the global efforts to address both HIV and TB. And across the world, we have 1.8 million children up to the age of 14 that are living with HIV. However, only half, 53%, are diagnosed and on treatment, compared to more than 2/3 of adults. And so most of these children also live in sub-Saharan Africa. 90% of young people living with HIV who are under the age of 19 live in this part of the world. TB too remains a serious threat, and approximately globally, we have 1 million children under the age of 15 that are diagnosed with TB in 2018, and over 200,000 have died. So distinguished guests, if we come back now and zoom into Kenya, yes, we've had a lot of progress. But we still have about 106,000 children under the age of 14 living with HIV. And in 2019, more than 6,800 children, again, acquired this virus. That is almost 1 child per hour. And most of these cases can be attributed to mother-to-child transmission during pregnancy, labor, childbirth, or breastfeeding. And in 2019, more than 10% of HIV-positive mothers passed the virus on to the children. In 2019, 8 of our counties accounted for half of the total new infections amongst children. And I think you know which ones they are: Nairobi, Kisumu, Homa Bay, Siaya, Migori, Nakuru, Uasin Gishu, and Mombasa. Moreover, these rates of mother-to-child transmission have been climbing alarmingly in the arid and semi-arid counties over the past 3 years, with rates as high as 28.5% in 2020, which is more than double the national rate of 10.8%. So ladies and gentlemen, the other key concern, of course, is diagnostics. 1/3 of Kenyan children exposed to HIV do not get a diagnostic test within the 2-month time frame that is recommended by WHO. And more than half of children under 14 thought to have TB are not reported to the national TB programs. So poor health care, lack of disaggregated data to help inform the response, the complexity of diagnosing both HIV and TB, and the need for specialized equipment are maybe some of the reasons behind this. But of course, this consultation in the next 2 days will go much deeper into this. And we know that COVID-19 pandemic could actually be making things worse. And there's been new modeling that's happened that shows that it could actually increase new HIV infections amongst children as health workers are diverted to COVID management. Sexual activity, sexual violence, and substance abuse increase perhaps during school closures. And there is stigma around presenting to facilities with respiratory symptoms. So all these are further exacerbated during the COVID-19 situation. So distinguished colleagues, guests, participants, children do have the right to better treatment and care. And this is underlined in so many international instruments. It is also in the Constitution and further expounded in Kenya's Universal Health Coverage Framework. And we must now concentrate on the action we can take, and there is a lot to do, and there's a lot we can do together. And I think from this meeting, yes, we do absolutely need a very clear action plan that will emerge on how to tackle some of these stubborn issues around HIV and TB amongst children. But with the action plan must come accountability, that is monitored. We need the full political leadership and engagement across all sectors. And let us center our response on mothers and their babies. The best way of improving access to HIV treatment is to ensure that children and infants actually are diagnosed early. Children born to HIV positive mothers need to be tested within 2 months of delivery and regularly retested until they stop breastfeeding. However, we're not seeing enough progress in this. In 2012, global coverage for early infant diagnosis was only 43%, and by 2018, it had just edged up to 59%. We also need to see how we can diagnose older children, 5 to 14 years, and that this is prioritized. And it does require awareness raising and provision of HIV testing within health and social services that do not traditionally provide HIV services. We need to see much more innovation and see how we can get some of the best practices brought up to scale. And these kinds of steps will help children to be referred very quickly as possible to treatment. And then, of course, as has been said earlier, let's make sure that the children get the best and latest and most effective therapies. And let us ensure that stocks of pediatric HIV diagnostic kits and ARV medication never fall low. We need to tackle the stigma and discrimination in healthcare and in schools as well for children and women who are living with HIV, as it can actually stop them from accessing and maintaining treatment. Peer support can be maximized, allowing people to improve their knowledge about and adherence to treatment and to be contributors to rather than beneficiaries of the response. And in all this, communities must be engaged. And finally, let us improve the governance and coordination of all healthcare and social services for children. Ladies and gentlemen, as I end, I want to say that as part of the UNAIDS family, UNICEF is committed to supporting the national and county governments in their HIV/AIDS programming, focusing on children and providing data and evidence to inform strategy. And we have been over the years doing so, providing the technical support, bringing in some of the evidence-based advocacy. We've also been supporting the rollout, sustenance, and revival of early infant diagnosis in 3 of the counties, Laikipia, Migori, and Turkana. And finally, we have been advocating and providing technical support for increased funding interventions at both the domestic and international levels to sustain ARV medication and HIV testing materials for children and mothers. So I think, distinguished guests, let's just say that a step change is coming, and together we can deliver. And the UN family, together with UNICEF, of course, will do her part. So our aspiration remains that we do actually have a children that is free, that have a future that is free of HIV and TB. Thank you so much.
Thank you very much, Ms. Maniza, and thank you for that commitment that the UN agencies and UNICEF in particular has committed towards ensuring our children remain HIV and TB free. Ms. Maniza has highlighted several things to this forum, including the fact that we have a climbing maternal to child rate, especially in the arid and semi-arid areas, and that up to half of children under 14 with TB are actually not getting reported. And so thank you for highlighting these gaps, and these are areas we'll be focusing on. Moving on now, we will have the adult and young, the AYP's perspective, that is the adult and young people's perspective. We will have Vivian Faith and Wilson Lore giving us their perspective. Vivian is a health advocate, majorly involved in assisting individuals and communities to adopt healthy behavior. She supports the conduction of outreaches for medical personnel to implement programs in the community to promote, maintain, and improve individual and community health. She's also heavily engaged in HIV, TB, malaria, and cancer. So welcome, Vivian and Wilson. Over to you now.
Good morning, everyone. I hope I'm loud and clear.
Good morning and welcome.
Thank you. My name, as you've all heard, I'm Vivian Faith. I'm a TB HIV advocate, and I'll be sharing some of the challenges probably I had through while I was growing up as taking my HIV drugs. So probably the first thing is disclosure. While I was growing up, my guardians and caregivers did not tell me about my status. So leading to me asking a lot of questions as to why I'm taking the drugs. That led me to poor adherence since I got so relaxed to taking my ARVs. Then later on, I used to shift. I wasn't staying with my biological parents. So I used to shift from different households because I was a burden to them. Storing my drugs was also a big challenge for me because I wouldn't take them while they were there, and I couldn't store them where they would easily access it. So I would take my drugs and I would transfer them into a polythene bag and store them in a charcoal sack for easier access for me, so that when it's my time for taking my ARVs, I would take them easily without any disturbance. But also that became a challenge since my time would reach and they will be there at that particular time. So I would skip taking my medication for quite some time. I will even change my positioning for storing my drugs. I will take them to my mattress. I would pinch some part of the mattress behind. So I would just store there. When I want to sleep, I would take it and I would take my medication. And also while I was in school, it was quite a different challenge for me because I had to lie about my status. I wouldn't tell them I'm positive and the reason I'm taking my medication. So, hello?
Mwambie mama asiwe na anachukulia vitu tu kimzaha.
If we could ask all participants to mute, please.
So while I was in school, I would lie that I had a heart problem. So the packaging of my bottles, I will rename them. So apparently one day I fainted and they rushed to bring my medication since they all knew I was taking them for the heart. So apparently one of the students knew those were ARVs, and so she announced to everyone those were not heart medication. So like everyone, I was the talk of the school by that time. So on me waking up, while I got my conscience, everyone was talking about me. I was not comfortable in school, so I had to leave school and stay home. The only time I came back to school was to do my Form 4 actually, because I wasn't comfortable at school, so I wouldn't manage the shame of me being talked about, me taking my ARVs. So I left for home and only came to do my Form 4 exams. I think another challenge for young persons is always lack of support. For those people who are not staying with their biological parents, it's also quite a challenge for them. As you all know, a young child, as young children, we tend to forget things so easily. And at least we prefer someone to remind us of what we're supposed to be doing. And for me, it was a different case since everyone was minding their own businesses and they forgot about me and my drugs. So when it reached my PCA date, at times I would just pause into the latrine because I wasn't taking my medication. So there were a lot of them. I wasn't taking them, so I would just put them and throw them in the latrine and go for my TCA to pick other medications, which I knew very well they would be a challenge for me. And also, I think peer pressure. As a young person, I think I mingle a lot with different people, and I tend to live their lifestyle, not knowing that my life depends on that. So peers are quite another challenge. And I remember there's a time I was prayed for in church. So churches, particularly when I'd go to church, I would hear pastors say HIV is evil, and my other guardians will believe it. I'd be prayed for, and after some time they said I am healed. So being they were strong believers, I was afraid, and they asked me not to be taking my medication. I stopped taking my drugs, and they will not assist with transport to go for my medication. So I quit taking my medication, and my health really deteriorated for quite some time. And I think lack of information as well is also another challenge, because you find I'm staying with a guardian or someone is staying with a guardian and they're not telling them about their status. So that can be quite a challenge. So it's good for the parent and the caregiver to tell the child as to why they are doing that, so that the person do not relax at all while taking their medication. And there was a time I used to stay with my aunt, actually, and it happened that I felt alone. For the first time, I felt so alone. Like everyone was.
Hello, Vivian. If you could just try again to speak. We cannot hear you. And then a request to all of us to mute our devices. Vivian, are you still with us?
Yes, am I clear?
Yes, now we can hear you. Please go ahead, Vivian.
So should I just go ahead or?
Yes, please, go ahead.
Okay, so I'll start from the church level. In churches, particularly when I'd go to churches, I would hear the pastors say that HIV is evil. And my other guardian, whom I was staying with at that time, was a believer. And that he prayed for me. So they were strong believers, they were afraid of being subjected within the church. So we'd agree, I was healed. And that was when I stopped taking my medications. And they will not assist me with any transport to go for my medications. So at the end, I end up being a defaulter, because you find maybe probability is my viral load is so high because I'm not taking my medication. And another challenge was, there was this particular day when we were all seated at the table we are supposed to have our supper. And it so happened that they were distributing the forks, but when it reached to my part, I was given the plastic fork just to keep me off. I shouldn't be mixing my utensils with them. From that day, I just moved out, and I couldn't stand the pain, because that thing happened for quite some time, and I had to move out of that house. So I stayed out for quite some time before coming back, or before getting a friend who could support me. Thank you.
All right, thank you, Vivian. Wilson, do we have Wilson on board? Do we have Wilson on board? All right. In the absence of Wilson, I would just like to highlight, yes. Wilson?
Yeah.
Karibu sana. Welcome, Wilson Lore.
Okay, thank you a lot. I'm Wilson Lore, age 50. And I was born 42. And
Wilson, if you could kindly increase your volume a little bit, we are struggling to hear you.
Okay, I'm Lore Wilson. You hear me? Do you hear me?
Yes, we can hear you now. Go ahead, please. A little louder.
I'm Lore Wilson, and I'm age 50. I'm 25 years old and I was born positive. Okay, for I, it was a big challenge because I didn't know what was going on to me. And I started my viral drugs in year 2003, is the year which I started medication. And it has been a long journey. Hello, you hear me? Hello?
Yes, we can hear you, Lore. Not very clear. Again, if you could raise your voice a lot more, it would really help. Yes, maybe
Okay,
move closer to your mic.
Okay, what I can just tell you is that I have problem with the audible, being audible.
Got it.
I have a problem with audio, so I think I can continue.
Please do.
Okay, I'm age 25, and I'm a resident in Mombasa, Kenya. For me, I was born in a family of seven children, and in this family of ours, who was under the medication and virus. So it has been a long journey for me from 2003, the year which I started the medication, up to I think 2008, where I was in adolescent stage. So I just wanted to know what was going on with me. And I was taken to the facility where I used to take my medication. And I got a nurse who assisted me and gave me the whole issue, what's going on with me. And it wasn't easy for me to accept what was going on. Because in a family of seven, I was already the person under medication. So I settled, I took my own decision, and the nurse was there for me, assisting me and giving me hope. She told me that age is not the end of the world. So you still have to have your own family, your wife and the children. So I accepted that what was going on with me. So I was taking to support group, support group in our facility, whereby we're given the information and what's going on, the life goes on. So slowly by slowly, I started accepting what's going on. And beside that, I started going through those support groups, which gave me enough energy and accepting myself. Because I knew that I came up and I knew that I have a big family, not just me only, who is under the medication process. So it was going on from 2008. I was taken as a champion from the group where I'm coming from, the Mombasa, and I was representing Mombasa under the group which we were known as Southeast Africa. And 2 hours we are going through, and I'm a peer mentor in the facility where I work, the CGS. And I usually appreciate a lot because earlier, when we are going through what's going on now in the world, things have changed. We have come across a lot of diseases, things like corona, and things like cancer. So for me, it has been a big challenge that there is nothing else I can do. It's all about accepting myself, and the life must go on. So the key thing that I'm doing nowadays is coming across the PLHIVs, giving them information, empowering them, and besides that, I've been given opportunities as a multi-level volunteer. So I do my issues related to the PLHIVs, support groups, coming together, talking about what we're going through, the challenges we face, and the people who are under medication. And I think that is not so hard for us. So it's really good news. Thank you. Hello.
Dr.
Hello?
Lorraine, are you there?
Yeah,
Yes,
there.
good.
Yes. Thank
Yeah,
you.
yeah.
Thank you. Thank you very much, Lore. Thank you very much for thank you very much for taking us through and highlighting some of the challenges that young people who are affected are actually going through. Just to recap a little bit, both Vivian and Lore have highlighted the issues of one, disclosure, the issues of adherence to treatment in light of stigma and discrimination, particularly in schools, and also among caregivers and those who are supporting them in this process. So thank you very much, team, for those perspectives. And we will now move on to our next presenter, who will be Maureen Murenga, who is the current Executive Director of the Lean On Me Foundation. Maureen Murenga is very passionate about health, development, and human rights, particularly in terms of HIV. And so she'll be taking us through a mom's perspective, particularly for children living with HIV. Over to you, Maureen.
Thank you very much. I hope you can hear me. I'm not very well. So
yes, we can hear you.
And apologies if I keep coughing when I talk. So yes, I've been introduced as a passionate advocate, and this is because of a life I've experienced. I'm a mother to a HIV positive child. And my journey began in the early 2000s, before we had treatment available or accessible treatment available. We had a few people selling stuff here and there. We had Palomega. We had expensive drugs that the common person could not access. And so when I had my baby, I was diagnosed during pregnancy. And that time we were given a single dose of nevirapine in a syringe. We would walk around with it so that when you finally have the baby, you can administer. So I administered my medicine as I was told before 72 hours elapsed. And of course, like any other mother, I was expecting good results. Then we didn't have early infant diagnosis at 6 weeks. We had to wait for the normal rapid test at 9 months. So for the 9 months, my child looked okay. He was healthy. His graph was okay. He added weight. He was just okay. And every time we went to the postnatal clinic, we were given positive results. It's at 9 months when he was tested that he tested positive for HIV. I was more broken than I was when I tested my own. Actually, what I'll tell you is that no woman wishes that their children could have this fatal, stigmatized health condition. It breaks you more than your own. There is always a feeling of guilt, a feeling of shame, a feeling of despair, and a lot of hope is lost. That joy of motherhood is halted for a moment because you're not sure what next for this child. And it was at a time when we were struggling with a lot of stigma. So I was telling myself, I've brought a child to a stigmatized world. So as we moved on, of course, we didn't have treatment for children. So we gave first of all, treatment started being rolled out. I went and my priority was to enroll my child. We would wake up as early as 4 a.m. because they were being rolled out in study sites. And a study site would only take maybe 50 or 100. So if you're late, then you would not get enrolled. So we would wake up as early as 3 a.m. with our children, queue in those study sites so as we are enrolled. And finally, when we got into one, we were told that they are only giving adult formulation. So I opted to take it for my child first and break it into 2. So I just used to break it into 2. We didn't care about the weight, all these things that they look at before they administer the dosage of the medication. All we wanted was that the children stayed alive. And this helped because for about 2 years, we broke the medication. And it was that bad one that was stavudine-based for our children until we had some better tablets for them as they grew older. During that time, that is what actually pushed me into advocacy for children and pediatrics, because everything about adults was moving very fast. And those of us with children were getting really frustrated, especially if now in the process they got TB. It was difficult to diagnose, and we lost so many children. And we were hoping that when we come to maybe 2021, we would not have the same challenges. We would not have the same issues repeating themselves. But that is not the case. I'm sure we all know that children cannot be around this table. And therefore, those who are around the table sometimes forget to think about children. Everyone is struggling. If the women are on the table, they're looking for women-led responses, women-led prevention, whatever's. When youth are there, they're looking for youth-friendly services. The men are also saying men are left behind, looking for male services. KPs are looking for key population-friendly and safe services, but we have no one around the table. We don't have children around the table saying, hey, wait a minute, we don't even have drugs. And so time has changed from when we waited for 9 months for diagnosis, but unfortunately, even up to now, mothers have to wait for long. When I went for my 6 week, I have a second child. He's not HIV positive. But when I went for his first PCR, or the test they do, the HIV test they do at 6 weeks, in that facility, I'm still waiting for the results up to now. He's 6 years old, almost 7. So the results haven't come up to now. And sometimes I joke with them, I call and ask, did my results ever come? And they tell me, by now you should have gone elsewhere to find. So what about mothers who do not have elsewhere? That is the only facility within the location they live in, or are not courageous enough or empowered enough to go disclosing their status in other health facilities. So point of care diagnosis is still a very essential commodity. It helps us with dealing with the that waiting period is usually very panicky. It's very, very panicky. And so if it can be shortened, it's both good for the mother and the child, because the results will determine how quickly we give access to treatment if they are positive, or how intensively we increase prevention services if they are negative. So I know we have a court case that is against task shifting and point of care, but I don't think, and when I read the case, I was disappointed because they talked about, sorry, they talked about their jobs being taken by the nurses, but I don't think it's about jobs being taken. I think it's about widening access for people who really, really need it, especially the children. And then when we come to treatment, oh my God, it's usually a battle. You know, when we were breaking the tablets for our children, we used to have these group therapies. And someone would say, now when you break and one side is small and the other one is big, which one do you give in the morning and which one do you give in the evening? And someone would say, because they are playful, let's give them the big one in the morning. And because they are sleeping, let's give the small one in the evening. But we used to know that science will relieve us from this burden one time, and that we will have child-friendly formulations where we are giving the right dosage to the child. But even now, the formulations that are commonly available, the Caletra syrup, it has to be refrigerated. How many mothers have refrigerators? So there are mothers who are giving, and it smells very bad, and it tastes horribly. So there are mothers who are giving children medication that is not helping them because of the storage. So the strength of the medication has gone down, and it's bitter, and it's breaking the relationship between mothers and children. There's a client of Lean On Me who says the child no longer wants to see her. Every time she comes, the child runs away. And so she's feeling very heartbroken because that's her first child. She was hoping to bond, but the bad tasting medication has actually broken their relationship, because the child thinks she's a very horrible person to be giving him that that formula. And then when we talk about prophylaxis are very, very important. It is very, very important that women have this prophylaxis. When we talk about U is equals to U, we were told that for PMTCT, it hasn't been tested, so we don't know if it works. So regardless of a mother's viral load, they should have the prophylaxis. We have had shortages in the past, and this was very bad. And sometimes I equate the increasing infection on children to that kind of shortages. We also are told we are a breastfeeding country, which is good. When I had my baby, we were not breastfeeding. And it really breaks the heart. You have not breastfed, you have followed all the instruction, but the baby still turned negative. Anyway, we were not breastfeeding, but science gave a relief that we can breastfeed and give prophylaxis. But it's not all mothers that are comfortable breastfeeding, because one, they just tested in the last trimester and the viral load is very high. And secondly, they're still coping with stigma and shame and other things that come with having HIV, and therefore are not adhering to their treatment. So the viral load hasn't gone down even when they're having their babies. So making breastfeeding the only option kind of becomes tricky. And especially when these children seroconvert, the mother usually says, I knew my viral load was high. I was struggling with adherence and stuff like that. So I think we need to give a client-focused intervention around this, so that we are looking at how feasible is it for a mother to breastfeed. And if it is not, some of them have wounds and sores on their breast. If it is not, we don't tell them, lazima unyonyeshe, and kick them out of facilities. We give them options, we support them. We used to have formula milk. We can even give periodic support after assessment and thorough checkup of the mother. So with that, the challenges grow bigger as they grow older. And I was just talking to Dr. Catherine Ngugi of NASCOP the other day, telling her the way I cry so much when my son blames me for his condition. He really sometimes doesn't like me when he thinks about his status. He sometimes refuses to take medication and his viral load goes very high. And when you go to the hospital, they say, even you who is an activist, you can't take care of your son. But he's a big boy. I can't force the drugs into his throat. When he was younger, I was able to. Now he's 16 going 17, or he's 17 actually. There's no way I'm gonna pin him down. He's bigger than me. I'm gonna pin him down and force the drugs down his throat. We just have to negotiate. And sometimes the negotiations are very painful and leading to very tense moments in the house where all of us break down. And I think we haven't had enough support for mothers. And I always tell people I'm a very strong woman, but if this is how I get broken, then how many other women who do not have other support systems? Like I said, I called Dr. Kate. Others do not even know where Dr. Kate is. How do they get that kind of support to deal with the challenges of adolescence and taking treatment and that kind of of blame? So I think our programs should also focus in terms of the caregivers of these children. Let's support those who are taking care of them mentally, psychosocially, as well as we support the children, because that transition to adolescent and to youth is usually very painful sometimes. And then we also need to ensure that we strengthen community level interventions, because it is difficult for a nurse to work in the facility and then later in the evening start working in homes, checking out on mothers. It is easier if we do the task shifting and support communities to do that. And then finally, in terms of resources, I'm sure people are always talking about resources being insufficient, but I also, I'm glad that we have PEPFAR, we have Global Fund, and we have other actors, UNAIDS on board, and Ministry of Health. If it's possible, then all these resources can be pulled together and we use existing data from NASCOP to roll out the activities, because you find that the interventions are so parallel. You have all these women in your office needing help. You are told that there are people doing that work in that region. You're looking for them and you can't find them. It is not really very well coordinated. So I think we need to coordinate the efforts. And that I mean that you could have data at NASCOP saying one thing, and the investment from Kenya Red Cross doing work in another region that is not presented as a high risk in the data NASCOP. And these inconsistencies are not really helping us to reach the people that needs help. So I think I can talk for 3 days about this, but because of time, I will end here. Thank you very much.
Thank you very much, Maureen, for the work that you continue to do every day. And we appreciate you for bringing to the fore some of the issues that face our mothers as they support their children. You've highlighted issues of access to commodities, access to drugs that are child-friendly, that have a good taste, that actually can be stored appropriately. You've mentioned issues to do with options for those mothers who cannot breastfeed, issues to do with transitioning and support for children who are transitioning into adolescence and young adulthood, and also the issues of the need for psychosocial support for mothers and other caregivers. So thank you very much, Maureen. We truly appreciate your work as well as the inputs that you have shared with us. So moving on, we will now have Bishop Robert Langat, who will be coming to share with us the engagement, the current engagement with faith-based organizations in promoting access to testing and treatment of children living with HIV and TB. Dr. Langat is a bishop in the Africa Gospel Church of Kenya and a lifelong member of the Africa Gospel Church. Karibu sana, Bishop. Over to you.
Thank you. Thank you so much, Lorraine. I hope you can hear me.
Yes, we can hear you very well.
Good morning to everyone. And on top of being the Bishop of the Africa Gospel Church, I serve as the chairman of the Christian Health Association of Kenya, actually doing my final months before I hand over. And also it's the chairman of the board of Tenok Hospital in Bomet. I will be talking on the faith engagement in promoting access to testing and treatment of children living with HIV and TB. As we all know, in Kenya, about 40%, well, we probably know, about 40% of health services in the country are provided by faith-based organizations, FBOs. Also, over 95% of the population is ascribed to a religious affiliation, according to the 2014 Kenya Demographic Health Survey. Over the years, the FBOs have developed extensive and strong social networks and physical infrastructure that serves the needs of the poor, marginalized, and vulnerable communities. And truly, most of these have demonstrated long-term sustainable commitment and hence achieved trust by the various communities that they serve across the country. The faith sector not only provides spiritual and moral guidance to their followers, but they are also often the primary providers for a variety of local health, education, and social services. You'll actually find that in a number of places, especially the remote parts of our country, you may find that a faith-based facility is the only one that is available in that community. And even in the more developed parts of the country, you still find that a whole host of our villages and communities are primarily served by health facilities that are run by the faith communities. Enhanced engagement with faith-based then communities therefore presents a very, very pivotal opportunity to accelerate the uptake of the optimized HIV test control. I would say a word about the Christian Health Association of Kenya, that it is a leading national faith-based organization of Protestant churches, health facilities and programs from all over Kenya. Through the funding from the Centers for Disease Control, the organization implements what we call the CHAP USIMA HIV testing in 78 faith-based and affiliated health facilities and 3 orphans and vulnerable children, OVC local implementing partners across 19 counties in the country. These facilities provide services across the entire continuum of care, from HIV diagnosis to achieving and maintaining viral load suppression. As of April 2021, the program was supporting over 2,000 children in the 0 to 14 age category, and over 5,000 OVC age below 17 years. In 2019, the program received funding to implement the Faith and Community Initiative, FCI, which among other goals was aimed at rapidly increasing the promotion of men and children living with HIV who know their status, are linked to care, and have viral load suppression. This goal would be achieved through various strategies, including dissemination of messages of hope among congregants. That is to achieve transformation in perceptions about HIV by replacing the old messages of fear and death with new messages of hope and life, emphasizing the benefits of early treatment with a focus on undetectable and transmissible, increasing targeted case finding, linkage and retention of men and children living with HIV by leveraging the specific and intimate social and organizational networks with faith communities, and also decreasing loss to follow up by decreasing stigma and non-adherence associated with faith healing. I think we've already had that faith communities are both an opportunity in terms of the health facilities and programs they run, but they can also be a source of a challenge in terms of the non-adherence due to a testimony we've just had a while ago about how sometimes it leads to non-adherence. The program placed 14 wellness clinics in various churches and mosques in five high and medium burden HIV counties, which are manned by HIV testing services personnel to provide HIV testing and linkage to nearby Chap Uzima supported health facilities for care and treatment services for clients identified as HIV positive or pre-exposure prophylaxis for negative clients who are at continuous high risk of contracting HIV. To date, the initiative has been able to sensitize 1,210 interfaith leaders on the new messages of hope. The messages of hope have been disseminated to over 10 million congregants through various channels, through radio, church services, and social media platforms. Over 9 million congregants have been reached with messages to reduce stigma and non-adherence. 5,208 clients have been tested through HIV self-testing within the wellness clinics, with 228, that is 4.3%, identified as positive, and 226, that is 99% of the positive clients linked to treatment. A total of 90 community antiretroviral therapy groups have been supported through places of worship, where clients are to pick their medication refills from the nearby churches or mosques instead of traveling for a longer distance to do the same at their facility, thereby strengthening the patient retention with reduced default rates to clinic appointments. My last point is on the challenge of HIV, the challenge of COVID-19. The COVID-19 pandemic containment measures continue to pose a challenge supporting identification of men and children living with HIV due to the periodic restrictions on religious gatherings within places of worship. And as a result, many places of worship have resorted to use of virtual platforms for worship activities, hence reducing the pool of eligible clients for HIV testing. Availability of HIV self-test kits has also been erratic and inadequate, thus hampering testing activities. Despite these challenges, the initiative continues to show a lot of promise towards identifying adults and children living with HIV and linking them to treatment who would otherwise not have been identified through the existing health system or would have been reached too late. In conclusion, the faith-based actors remain very key and are committed to as partners as we work towards achieving Kenya's and UNAIDS goal of 95, 95, 95 by 2030. Thank you so much.
All right. Thank you very much, Bishop Langat, for that very encouraging session you have taken us through. We truly appreciate the work that the faith-based organizations and the churches are doing in the war against TB and HIV. And of importance, I want to highlight what you're doing as far as diagnosis and testing is concerned, as well as linkage to care and treatment and PrEP. Also, I think of importance is the work that you're doing through the message of hope in ensuring that we use churches and mosques in our communities to actually bring services closer to the community members. So thank you very much. And at this point, I would like to hand over this session, the next session, to my co-moderator, Dr. Momanyi. Over to you, Dr. Ari.
Thank you, Dr. Lorraine, for moderating that very touching section where we really heard direct from the beneficiaries, from some of the speakers, and even from what Bishop Langat is doing with his team. Very interesting interventions, and I know that we are taking good notes on some of those promising interventions and how we can be able to support and implement to scale. So at this point, we are going to have a 3-minute video, which is a call to action from one of our, a child. And therefore, please, admin, play the video.
Leaders of the world, I am a Kenyan boy aged 13 years. I take this opportunity to address the leaders of the world. First and foremost, I would like you to support in improving the health systems in most hospitals. I will first point out the early infants diagnosis, which tests the infants while they are still young. If the virus is noted in the child, the treatment and the medication will start earlier and be better enough. You can also help to fund the TB diagnosis machines to help reduce the time so that the treatment can begin early. I also suggest you can help the doctors and nurses by giving them refresher courses and paying them well. Most children today have no access to medical care. This increases the chances of getting opportunistic diseases, thus increasing children's deaths. Please help get the right medications for children that they can swallow easily. Last but not least, I would like to thank you for your great step of improving the health of our world. Finally, children also need to go to school so that they may be able to live normal lives. But they also need to be comfortable in school. School should be their home away from home. They should not go to school and get bullied and discriminated or traumatized. They need people who will help them to get through it. Support in kicking out of stigma in schools. Looking forward for your continued support. Thank you.
Thank you so much. And that was a call to action from a child. And as you can hear from the video, it's been able to highlight some of the issues, including the challenges of children and adolescents who are in school. So as much as we talk about the interventions at the facilities and in the communities, we really need to focus on how to support our learners who are living with HIV, who are in school, to be able to adhere to the medications, to reduce the stigma that they face, and as well as even ensure that they're able to access the medications without interrupting their learning process. So thank you so much. And so we are moving on to the last leg of the remarks. And now I would like to invite Shannon Heder, who is Deputy Executive Director of UNAIDS, and she's going to give us remarks from the UNAIDS perspective in relation to the agenda we are discussing today. So welcome, Shannon, for your remarks.
Friends and partners from Kenya, I congratulate you on this important consultation, which is going to identify concrete solutions and actions for greater access to HIV and TB services for children. We have come a long way together in the HIV response. We have more tools, knowledge, interventions at hand than ever before, which makes the vast divide among who is and isn't benefiting from those science and resources, the inequalities in our response, truly unacceptable. And make no mistake, one of the most glaring inequalities, disparities in the HIV response is for children. The failure to meet the needs of children living with HIV. Data clearly show that we have failed. We are missing the kids. Over 850,000 children living with HIV worldwide are not in care and not in treatment. 2/3 of these kids are 5 years old and older, so will not be found by strengthening perinatal and infant services alone. They are the children who have fallen through the cracks over the last 14 years, and now is the time to make up for that. Specifically, kids are much less likely to be on treatment than adults. Only 53% of children 0 to 14 years who are living with HIV are on life-saving HIV treatment, compared to 68% of adults. Nearly half of all those untreated children are in 5 countries: South Africa, Mozambique, Nigeria, DR Congo, and Kenya. Second, kids that are on treatment are less likely to be benefiting from it, to have suppressed viral loads. Only 37% of children living with HIV are virally suppressed, compared to 60% of adults. Children aged 1 to 4 years old have the lowest rates of viral load suppression in Eastern and Southern Africa. In part, this is because regimens for kids have not been great, but access to better regimens for children is needed and now available for better viral load suppression. So we need to transition to fixed dose combinations such as DTG that will help children have better health outcomes. And finally, we have still not fixed the gaps that allowed these children to be missed in the first place. Only 60% of HIV-exposed infants are tested by 2 months of age. Yet we know that the adoption and integration of new point-of-care diagnostic technologies can assist in closing testing gaps. Where we're at now is the result of many years of missed opportunities for prevention, diagnosis, and treatment, years in which we have not truly prioritized our children in HIV strategies or in the follow-through actions. Recognizing the equal worth and dignity of every person and prioritizing children in the HIV response is not only ethical, but it's also critical for ending AIDS. The Global AIDS Strategy 2021 to 2026 aims to end the inequalities that prevent progress, including among children. The strategy has a strong focus on children and adolescents with targets to go along with it. 75% of children living with HIV have suppressed viral loads by 2023, important enough to have an interim target. 95, 95, 95 testing and treatment targets that need to be achieved among all subpopulations and age groups, not just overall. 95% of exposed children are tested by 2 months of age and again after cessation of breastfeeding. And 90% of adults living with HIV receive preventive TB treatment, which should also decrease household risks for kids. Reaching these targets need not be incremental. I urge you to be bold and creative. For example, how could you rapidly, ethically, and supportively find the approximately 40,000 missing kids in Kenya today? Well, yes, also strengthening the systems that will ensure no kids are missed in the future. Several result areas in the Global AIDS Strategy identify clear actions for kids and adolescents. Result Area 2, testing, care, treatment, and well-being of adolescents, youth, and adults living with HIV, including young key populations and other priority populations. Result Area 3, integrated and differentiated services to prevent vertical transmission to end pediatric AIDS. And I stress here both components. We must end vertical transmission, but ending vertical transmission alone will not find those kids that are currently missing. Also, the societal enabler result areas 4 through 6 which include addressing stigma, discrimination, unsafe environments, are critical to children, to adolescents, and also to their parents and families. Such actions might be included in the outcome document of this consultation. So let me conclude by congratulating the government of Kenya and its national and international partners for your commitment to prioritize the needs of children living with HIV and TB. On behalf of UNAIDS, I would like to reiterate our solidarity and full support to the National Action Plan on Pediatric HIV and TB that will come out of this meeting. So I wish you fruitful deliberations. Thank you.
Thank you so much. And I think in that remarks, the recorded remarks, Shannon has posed a very critical question: where are the kids? And she's brought in the numbers from both the global perspective, but as well as giving the Kenyan perspective, where we have about 40,000 children who are living with HIV who have not been identified. And I think in the course of this meeting, we really need to answer some of those questions and be able to put in place interventions to ensure that we are able to identify these children and put them on treatment and be able to suppress them. So at this point, I want to welcome Francesca Merico, who is from the UNAIDS PEPFAR Faith Initiative. She shall be giving us remarks in relation to the Rome Action and some of the initiatives that are being driven through the Rome Action, some of the achievements so far and what remains to be done. Thank you so much and welcome, Francesca.
So good morning, everyone. Thank you, Dr. Momani, and thank you, everyone. It's really indeed a great opportunity for me being here with you. I hope you can all see my screen. Thank you also for the opportunity of sharing about the Rome Pediatric HIV and TB Action Plan, which is one of the background resources of this important consultation. And it is also an initiative in which the government of Kenya has been really very much engaged. Recently, Dr. Momani has presented some of the key progress towards the commitments of the action plan that the government of Kenya has been implementing. It was really, Dr. Lazarus, a great presentation and a great progress that have been made. We also hope that this tool, the Rome Pediatric HIV/TB Action Plan, can be used as a model of multi-stakeholder collaboration and partnership to optimize access to HIV and TB services for children. So, okay. The Rome Action Plan is a compilation of commitments and key actions by stakeholders to accelerate research, development, registration, introduction, and uptake of HIV and TB diagnostics and medicines for children living with HIV. The action plan is the result of a series of high-level dialogues that have been convened by Cardinal Turkson from the Vatican under the UNAIDS and PEPFAR Faith Initiative. And it has been organized by UNAIDS, PEPFAR, the World Health Organization, the Elizabeth Glaser Pediatric AIDS Foundation, the Stop TB Partnership, and faith-based organization. As I mentioned, the Rome Action Plan is the result of a series of high-level dialogues. And here the slides show you some of these key events that have contributed to bring together this action plan. The first dialogue meeting took place in 2016. It was a consultation that took place in the Vatican together with Caritas Internationalis, faith-based organization, UNAIDS, and PEPFAR, and it focused on developing a specific roadmap on pediatric HIV by faith-based organization. This meeting was really important also because it contributed to determine those that were included as the key targets for children, the treatment and testing targets for children that were included in the 2016 Political Declaration on Ending AIDS. Immediately after this first meeting in May 2016, there was another high-level meeting. And this time it was decided to gather together pharmaceutical companies, both generics and originators, in order to discuss about the challenges that were limiting the research and development of optimal products for children. In November 2017, we had the first Rome Action Plan, which was focusing on accelerating optimal formulation for children, so the research and development, and again, the registration piece. In December 2018, we covered also and introduced pieces around diagnostics. And then finally, in November 2020, TB and the co-infection was included as part of the discussion and of the commitment. Many of the action points of the action plan promote a multi-stakeholder approach with greater coordination among partners. And it's really this coordination that even Maureen before mentioned that is key to the success of the action plan and its implementation. And the partnership has set a new standard of what is achievable when stakeholders with shared values work collaboratively. Here in the slide in front of you, you can see all the stakeholders that are part of this initiative. We have donors, we have regulatory authorities, we have research networks, UN agencies, pharmaceutical company, diagnostics, implementing partners, including faith-based organizations, and of course the government. And as I've mentioned, the government of Kenya has been key in this dialogue process and in the Rome Action Plan. All these stakeholders came together looking at three major areas. And actually, the discussion at the high-level dialogues has been structured somehow similarly to the one that are going to take place today and tomorrow in Kenya. So each of the stakeholders look at the challenges. What are really the urgent challenges in the area of pediatric HIV and TB that needs to be addressed? The second point was, what is that my organization can offer in order to address such challenges? And the third point was about, what do I need from other stakeholders to fulfill my commitments and my action? And this collaboration, as mentioned before, has been key to the success. So looking at some of the impact, here we have some successful example of this effective collaborative platform, which included the accelerated development of new pediatric HIV formulation, including the dolutegravir for infants, increased production capacity of lopinavir, ritonavir pellet and granules to respond to market needs, lower all-inclusive prices for early infant HIV diagnosis, and then harmonization of the registration and regulatory system, including through the collaborative registration procedures for both HIV, pediatric treatment and diagnostics. The Rome Action Plan has had a concrete and measurable impact around the research and the development piece and the introduction of registration, but still much more needs to be done around service delivery, around optimizing access to HIV and TB services for children, which is really a key element of the discussion that are going to take place today and tomorrow. The collaboration among stakeholders is the key asset and the key element, and the fact that all stakeholders continue to engage in the process in a constructive and enthusiastic manner. Somebody before, and I think it was the UNICEF representative, said that with the action plan, which is going to be the outcome of this consultation, must come an accountability framework, and we cannot agree more. Since 2017, the accountability of the Pediatric Rome Action Plan has been ensured by the Elizabeth Glaser Pediatric AIDS Foundation and the World Health Organization. We have regular exchanges. We have a website, which is the www.pediatricHIVactionplan.org, which includes all the different actions and commitments by the stakeholders, but also that reports every 4 months the updates related to the progress towards the milestones. So the COVID-19 pandemic, as we have heard before, created a lot of limitation and has limited some of the progress that have been made in access to pediatric testing and treatment. Here we see a list of such challenges that we are now asked to face and to address. So we invite really the working groups today also to look at the challenges posed by COVID-19 to access to HIV and TB services for children. So what I wanted to do now, if you allow me, is just very quickly show the website to you of the Rome Action Plan, and then invite all the stakeholders during the consultation to take into consideration some of the language that is included in the Rome Action Plan, to look at it as if it might be helpful for the plan that you're going to develop in Kenya. So just very quickly, sorry, I'm trying to share again my screen. Okay. Just here in front of you, you have the Pediatric Rome Action Plan. Here again, the list of all the stakeholders. And if you look at, for instance, we're going to go with the faith-based organization, Caritas Nigeria. It has a very specific language in terms of actions and commitments by Caritas Nigeria on diagnostics and treatment. And as you can see here, there are not only the actions reported, but also specifically the progress and the updates that have been made. So again, I just invite everyone to look at the language used and consider if it might be helpful for your deliberation. And thank you very much for the opportunity to share the Rome Action Plan with everyone today. Thank you.
Thank you so much, Francesca, for your remarks and the presentation highlighting the Rome Action Plan, the commitments, as well as some of the progress that has been achieved through the initiative. And also just like to confirm that Kenya is part of this Rome Action Plan. And through this, we are really making some significant progress in some of the areas that we have issues. So thank you so much. And I know some of the things that you mentioned will also be coming up in the presentations and also in the track sessions during the discussions, and will also be helped to inform the final action plan that developed from this meeting. So at this point, I would like to welcome the next speaker, who is Dr. Christine Kisia. Dr. Christine is a health promotion and HIV officer at the World Health Organization, that's WHO country office in Kenya. She provides overall technical support in HIV prevention, treatment, care for adults, adolescents, children, and pregnant women. She has supported the country in the adaptation, implementation, monitoring, and evaluation of national policies, plans, strategies, and technical updates related to HIV. Dr. Kisia is a medical doctor and a public health specialist with over 15 years experience in the field of HIV/AIDS and health promotion. So she's going to talk to us about access to better medicines and diagnostics and the strategic intersection between TB and HIV. Thank you so much, and welcome, Dr. Christine. Dr. Christine? Okay, Dr. Christine, can you hear us? All right, so as she comes on, or as we confirm, I would just like to confirm to the participants that we are seeing very interesting feedback on the chat.
Doctor, sorry, you had unmuted me. I was unmuted and the host was not allowing us to unmute.
Okay. Oh, apologies for that. Please go ahead.
Yeah, so good morning and thank you, Daktari, for the introduction and for the invitation. Just give me a few minutes. I try and share my screen because I was disabled. I couldn't do that, so sorry for that.
Okay, just go ahead. So as she does that, I was just informing the participants that we are seeing your charts. You are very interesting feedback, very useful feedback coming on the charts. And we have a team that's specifically taking note of those and recording them. And we shall be able to address some of them during some of the sessions that we shall be having in the meeting. So go ahead, Christy.
So just to confirm, can you hear me and can you see my screen?
Yes, we can see your screen and we can hear you.
Okay, okay, thank you. Thank you very much. Thank you, Dr. once again for the invitation and for the introduction. Good morning, everybody, and all protocols observed. And thank you for this opportunity. So I'll go straight ahead. I think my presentation is going to be much easier given, oh, sorry. Yeah, sorry. So yeah, my presentation will be easier because I think the previous speaker has touched a lot on the Rome plan, and also all the other previous speaker from the testimonies and the remarks from UNICEF, UNAIDS, PEPFAR, Global Funds, have all touched on some of these issues. So I will be talking on access to better medicine and diagnosis and the strategic intersection between TB and HIV. A lot of this is from the discussions held at the Vatican meeting last year, which was also highlighted by the previous speaker. So just to highlight some of the issues that were raised by the speakers, but more so what is needed from us, the different stakeholders who are in this meeting. Trying to. Okay, so please just anytime you lose me because I have a network that's a bit not very good, just let me know. So just to go over the figures again, which have already been said, but just to bear in mind that these are not just figures, but these are actually children that we are losing. And we know that children are one of the most disadvantaged populations in the HIV and AIDS and TB response. And we have lost, like in 2019, we had 95,000 AIDS-related deaths that occurred in children. And 2/3 of those deaths were in 21 focus countries. And as we know, Kenya is one of the focus countries. Even if we do top 5 focus countries, Kenya will still be among the focus countries. So we are losing a lot of our children. We had almost 1 million children who are living with HIV who are not accessing treatment. That's a huge number. 65% of this were aged between 5 to 14 years. And of course, we know that if they're not getting treatment, these are the children that we're also going to lose to TB, which is one of the major cause of AIDS-related deaths. And we lost 36,000 children who are living with HIV who died from TB. Of course, this would come from these 85,000 children who are not accessing treatment. We have had a lot of the challenges that hamper that rapid development of pediatric formulations. We've had people talk of the bad tests, the difficulty in formulations, and a lot of it is because of the lack of data. Clinical studies are not complete, slow market uptake, among many other issues. And then we also have issues in the diagnostics. We have diagnostics that are not really friendly to children. For example, is sputum for TB, and we know that's a difficult one for children. We also have issues of delayed regulatory systems or approval. And of course, we know all this are going to affect the uptake of services and diagnosis and treatment of children with TB and HIV. Just to go some of program data, this is globally, of course, but with a focus on some 20 countries. We know there's been good progress in reducing mother-to-child transmission of HIV. We have seen dramatic good progress from 2011, where we had the global plan introduction of elimination of mother-to-child transmission. And of course, we know a lot of countries have done very well in putting the mothers on ARVs, including Kenya. I think out of 2019, 94% of our pregnant mothers who are HIV were on lifelong ART. So in that area, we are doing well. But unfortunately, we still have a very high final mother-to-child transmission rate. It's 11%. Yeah, we say 10.8, but it's a human, so 11%. And as Dr. Mumani said in the beginning, you have 10 women, one of them will pass HIV to their children. And this is basically it's unacceptable. We have one of the highest MTCT rates also. And of course, we also have to recognize, as been said previously by everyone, with COVID, these issues, the targets that we had for 2020, targets that we had for 2025, most countries, including Kenya, are unlikely to reach them because of the disruptions that have been caused by COVID. Of course, if we look at EID coverage over the years, we can see from 2015 to 2019, we've done better, we've done well, but again, it has been a very slow progress, very, very slow. So if we look at Kenya, yes, we've moved from 47% to 70% coverage, but this is still not acceptable. We have countries that are doing much better, but it means we are missing out on, these other children that we are not being able to cover. There's also the issue of POCs that has been mentioned a lot. We are moving in support of EID. We are moving from centralized platforms because of the delayed timelines, the issues of low treatment rates, issues of low results return. So of course, there's that push for POC. And this is one of the meetings where we advocating for that push for POC so that the infants are able to get their results in a timely manner and of course be initiated, early initiation of treatment. We can look at many other program examples, and maybe it's the last one we look at, which was also mentioned, viral suppression. We know we are doing very well in adult viral suppression, but we are not doing well in children viral suppression. For adult, I think right now we're around 92%. This is for 2019. And if you look at the focus areas, you'd see the difference between all the countries are doing well in adult, but they're lagging behind in children. For children, Kenya, we're around 77. And I think this situation can be replicated in almost all the program data, both in HIV and in TB, where we'll see the children are consistently lagging behind. So, as I said, we have similar challenges in TB diagnosis, leading to large gaps in case detection and of course, provision of TPT. We know that children present with many challenges, especially in diagnosis of TB. Most children, we cannot get good quality sputum specimens. Clinical presentation of TB in children is very difficult to use that as diagnosis because it's very similar to other childhood diseases like pneumonia, malnutrition, bacteria infections, and all that. So there's need to develop some non-sputum-based diagnostic tools that could give rapid and reliable diagnosis of TB in children, as well the optimization of the current available diagnostic tools. So diagnosis case finding in TB is a major issue. But we also know that treatment in TB, over 90% of the children who have TB do not get treatment. That's a huge number. So they're either never diagnosed by their first year, it's never diagnosed and they actually just die. So we can look at this not only as a TB issue, but more of a child survival issue and look at the child rights that are actually being violated, that we are allowing so many children to die just because we are not diagnosing them. There is some progress in TB, of course, when we talk about integration into HIV, MCH services and all that. So we are seeing some progress, but again, it's slow and we need to do a bit more. I think this slide was presented by the previous speaker, just to emphasize on the disruptions on COVID-19 pandemic and how they're affecting, and they would still be affecting even in the long run. I think some previous speaker also talked of some modeling studies which are showing that we're expecting higher HIV rates because of all these COVID disruptions. And some of the data that WHO got from country programs showed that there was a lot of disruption from basically every side. In the lab, there was limited access to facility-based services. Some devices like EID were redirected to COVID testing. So that meant there were a lot stockouts in the lab commodities. EID tests were not being done, VL monitoring was not being done. Countries was setting up their POCs. This was also affected. So a lot of countries had delayed in activation of their POC EID sites. And of course, that led to reduction of reduced HIV testing. We had drug stockouts in most countries. Remember, COVID hit when most countries, including Kenya, were doing the transition, DTG transition and TLD transition. And so a lot of countries had stockout, but most important is almost all countries had stockouts of nevirapine syrup, which is used for postnatal prophylaxis. So again, you see, even currently right now in our issues of stockout, we had the pediatric commodities were the first ones to get to have a stockout. So again, every time it's the pediatric side that suffers the most, not only in the COVID, but again, exacerbated by the COVID pandemic. And of course, inadequate HR because of people being repurposed for COVID and all that. This is a snapshot of the meeting participants in the Rome 5 meeting that was held in November under the Vatican. And just to show, it was many different stakeholders, as the previous speaker highlighted. We have the donors, the governments, the UN bodies, the suppliers, the manufacturers were all in it. So this is just to show that there is commitment, political commitment to scale up diagnosis and treatment of pediatric HIV and TB. So what exactly, I think I missed a slide, I'm not sure. Yeah, I think I missed a slide, sorry. Anyway, so just, I think I missed a slide, but it's okay. So this is just to show what were specifically the country actions that were highlighted for in the area of accessing to better treatment, diagnosis and treatment for pediatric HIV and TB. This is what we are being called as a country to do. And these are the country means the Ministry of Health, the country partners, all the stakeholders that work within the country. There are other stakeholders that have different actions that were highlighted. We had the suppliers, the donors, and also WHO, which has specific actions also that is required to do. But for the country, the actions basically center around increased case finding. So improve identification and monitoring through collaboration. So increased case finding, that's what the countries are being called. So more efficient case finding, issues of regulatory, issues of better and more transparent pricing, clearer guidance when we're doing our adoption and adaptation of our guidance, of our guidelines, when we tend to leave out the pediatric sections or delay the pediatric part and move on with the adult part. And of course, strengthened commitment to pediatric diagnostics. This is just part of the Rome 5 pledges. I just picked the ones that were very much touching on access to better diagnosis and treatment. So issues of new optimal pediatric and HIV/TB formulations, I think that has been discussed in details. Improved diagnostic devices and assays for children, lower prices, wider availability. Regulators need to streamline the clinical trial development models. The government pledges, and Kenya was also involved in this, and Kenya was also one of the government that also committed to some of these pledges. And of course, action points that plan to promote a multi-sectoral approach with coordination among partners, which is what we are planning to do at the end of 2 days, start working on our action plan, and of course, an accountability system established. But the Rome plan has many pledges and many commitments for the different stakeholders, as was previously said, and you can find them this on the website. So just to conclude, just 4 points for conclusion. Both HIV and TB face similar diagnostic and treatment issues, and we need to tackle them in a strategic, integrated manner as much as possible. Global effort to tackle HIV and TB in an integrated manner. We are acknowledging that global effort is there, and there's a rise in the political advocacy And this meeting is just but one example that has brought in a lot of stakeholders, and it will give rise to that political push for addressing these two areas. Access to better diagnostic and treatment for TB requires contributions across all the stakeholders. So all of us have a role, and I hope during the group discussions, we'll be highlighting the different roles of the different stakeholders. And we have various engagements and platforms that are all discussing this, but the Vatican or the Rome platform, which is a continuation of the meeting we are having now, is one of the platforms that has been very useful in bringing partners, especially at the political level, to highlight and advocate for this. The last point is just a question on what we can do at the country level to commit to to contribute to what has been committed. So again, our issue would probably be centered more on introduction and scale up of diagnosis and treatment. And I just highlighted a few things, like in the steps when we are bringing in our diagnostic or treatment options from the beginning of guidelines, adoption and adaptation, our regulatory aspects, the training components, efficient case findings, integration, utilization of, we know we have TB POCs that basically some are lying idle, but we're not basically utilizing them for EID and VL. Integration testing platforms, which are also being done in other countries. So for us is to ask us, what can we do as a country to contribute to the commitments that Kenya also committed to? Thank you very much.
Thank you, Dr. Christine from WHO, for that very nice presentation on access to better medicines and diagnostics, as well as how TB and HIV interrelate, and why we need to develop a joint strategy to address both TB and HIV in children, and for highlighting some of the issues around case finding, where we need to identify the cases, addressing issues around regulation, pricing, as well as emphasizing on the need for multi-stakeholder engagement and collaboration. So thank you so much. So at this point, we are going to move into the remarks from the government side. And amongst us in this meeting, we are honored to have Honorable Joseph Mbai, who is the chair of the Health CEC's caucus. And Honorable Mbai has been very instrumental in most of our meetings that we've had, really bringing in the strong commitments from the counties. And we know even some of the discussions that we shall be having in this forum really need to be picked up by the counties in terms of actual implementation and being put in the action plans in the counties. So at this point, I want to welcome Honorable Mbai. Please give us your remarks.
Thank you very much, Daktari. I must take this opportunity to thank the organizers of this meeting to discuss this very noble issue of HIV and TB in pediatrics. As a representative of the counties, I'm very delighted to say that we are the ones who have been given the mandate to deliver the implementation aspects of management of TB and HIV. And one of the things that we really need to ask ourselves is, where did the rain start beating us? Because we have very good documents, we have good policies, we've had many meetings, we have given so many directions, we have also very good guidelines, and we've also have some very good practices and experiences that have been input, but we still find ourselves having challenges in the two areas of HIV and TB in children. And in the counties, yes, that is where the children are, and that's where they are being managed. And one of the things that I wouldn't need to highlight is that if I were to give, like, for example, in Muranga County, where I work, in the year 2020, I had 149 pediatric TB cases. That was a drop from 2 cases in 2019. And I know this narrative can be repeated across the 47 counties because that is where HIV and TB management in children is done. And one of the key areas that we really need to look at using the practices that have been there and the guidelines by MOH is TB diagnosis in children. Because one of the things that we realize is that TB diagnosis in children poses a challenge all the time. And because sometimes children are not even able to expectorate. So we need to look at what do we do, especially in level 2 and 3s. Do we avail the TB lamp as a guideline in terms of testing? Sorry for that. And then we must also invest continuously in training on healthcare workers on TB diagnosis and management, especially in areas like in gastric lavage skills, so that we can be able to have the samples taken from children. Then the issue of availability of drugs. When we have a lapse in availability of drugs, then we miss the opportunity to manage those patients well, because if there's a gap in treatment, then it means that the cases will actually beat us at some time. And then we also need to manage the issue of short expiries, because we know very well that we need very efficacious medications that can actually take care of our children. And the issue of contact tracing cannot be overemphasized, especially for bacteriological confirmed TB cases in household levels, because you realize that if we don't do that, then the ones who we have not found will continue transmitting the same in the household levels. Now, in terms of pediatric HIV in the counties, yes, we still have challenges. And one of the challenges we have is viral suppression, because I remember that lady who was giving an example of how she was managing her child, talked about the palatability of the drugs that we are giving our children. And if you look at Caletra syrup, the taste is not that palatable. So children between 0 and 4 years will have a problem in taking it. And we really need to look at ways and means of investing in that. And as a country, we must take responsibility, because it's our business to make sure that our children are safe and they are getting the correct treatment. Then the other issue in HIV is the late identification of positive children. And I think because we are the ones who are managing health staff, healthcare workers, we really need to be very strict on adherence of retesting protocols for pregnant mothers and breastfeeding mothers, so that we are able to make sure that they are captured early enough and they are linked to care and treatment. And one of the things I've noted very seriously, and I want to bring it to attention of this forum, is that there is a very serious connection between teenage pregnancies and transmission of HIV to unborn children. Because one of the things we've noted, especially in Muranga, where we have a program that we run on teenage pregnancies, is that when a teenager becomes pregnant, they don't attend the ANC visits early. You'll find some of them will come out when they are already 7 months pregnant. So we lose an opportunity there to test that teenager and to know whether they are HIV positive, so that we can be able to protect the child from getting infected. And that's an area that, because it's serious, it will continue hindering our indicators as far as mother-to-child transmission is concerned. And it's an area that we must, as a society, look very seriously. And then the other issue is capacity gap among healthcare workers in terms of pediatric HIV management. We constantly need to continue training and make sure that the people managing HIV in children in the counties, they have the proper knowledge, they have the proper guidelines, the proper protocols, and they are able to do the necessary according to the management of HIV. And then the other thing is constant supply of commodities. We realize that when commodities are out of stock, definitely we will have challenges and we lose on the gains of what we'll have achieved even in 10 years or more. So supply of commodities cannot be overemphasized. The EIDs, the ARVs, the HIV testing kits, it's very critical on that. Then the other thing is on financing. In the county governments right now, I think it is very clear that counties start now looking into putting budget lines in terms of financing issues of HIV and TB. And we've been using the health committees in the county assemblies to make sure that allocation to support HIV and TB. And I think this is critical, and we're disseminating it to all the counties so that the leadership can actually know that they are the ones who are supposed to mobilize resources to make sure that management of TB and HIV is done, not only in children, but across board. And that political goodwill is very important. And I remember we had a meeting with our MCAs, and I was asking them whether they are aware how many cases are there in their wards, how many cases are of children, mothers, or adults. And the majority of them were not well sensitized. So it's an area that we really need to invest in to make sure that we have that political goodwill. The other thing is that as a team that is dealing with this, we also need to be aware of the political changes that happen in government, especially when elections are done. You find that governments change. A new governor comes in office, and he comes with their new teams. So when we are putting these policies and guidelines, we must be aware that we put guidelines that cannot be affected if there is change of office, so that health has a seamless way and harmonious way of moving forward without any interferences. And finally, it is not lost on me, in the year 2017, we lost the gains of HIV and TB management because of strikes, human resource strikes in the health sector. In terms because the people who are probably taking care of them are not at work. Then looking at we have made a lot of noise about COVID. We can do the same on TB, we can do the same on HIV. And if you look at even the mortality rates of COVID as compared to HIV and TB, you realize that more people have died of HIV and TB than of COVID. So as a country, we also need to make a decision whether which priorities in terms of disease management are we taking, because and data is used to make decisions. So some of those data, we must be very bold and say that this is the way forward. And for us in the counties, we are very committed. I chair a caucus of 47 members who are also very committed. And nowadays we are vibrant and we are alert, and we are ready to engage, cooperate, and collaborate with anyone who wants to work with us to make sure that we deliver our mandate. So with those many remarks, I want to stop there and say thank you very much, Chair. Over to you.
Thank you so much, Honorable Mbaye, for those kind remarks. I mean, challenging us. I think you'll all agree with me that Honorable Mbaye has the numbers at his fingertips, and really talking about the political, leveraging on the political goodwill at the county level, even all the way to the ward level. I think we have taken a note of your remarks, and we will continue engaging. And even as part of the action plan for this meeting, I think it has to come out clearly on how This is going to go all the way down to the county level to ensure that implementation and even allocation of resources happens at that level. So thank you so much, and even for finding time in your midst of many tasks to just give us those remarks. Thank you so much, Mheshimiwa. So at this point, I want to just take it back to my co-moderator, Dr. Lorraine, to handle the rest of the session.
Okay, thank you very much, Daktari. So as we move on into the next session, I would like to invite Dr. Mike Ekisa, who is the chair of the County AIDS and STI Coordination Caucus. He'll be sharing with us the subnational perspectives as far as HIV programming within the counties is concerned. Over to you, Dr. Mike Ekisa.
So Dr. Lorraine?
Yes.
Yeah, apologies for that. So Honorable Mbai has already given remarks on behalf of the county, so we'll just go direct to
fantastic.
Dr. Wako. Yes.
No problem, no problem. Thank you very much. So we'll move on to Dr. Wako Ejersa. Dr. Wako is a public health specialist in charge of strategic planning and has had professional experience in implementing health policies at local and national level. And he is the current head of program, that is the National TB Program that supports TB, lung health, and leprosy. So karibu sana, Dr. Wako, over to you.
Thank you very much, Dr. Lorraine. I hope you can see me and hear me.
Yes, we can hear you.
Great. Yeah, so may I take this opportunity to recognize all the dignitaries today on board this beautiful discussion about HIV and TB in children. I want to thank everyone for taking this leadership. UN family, the Global Fund, the US mechanisms, USAID, PEPFAR, CDC, the government, national and county governments, and of course civil society, the powerful advocates from the youth, the mothers, Lean on Me, Vivian, and everyone for really taking their time to discuss this very important topic. So I salute you all. As was introduced, I'm the head of the National TB program in Kenya. And just to go down the memory lane, under the auspices of the church, the World Health Organization, EGPAF, PEPFAR, UNAIDS, and other global partner organizations, the world came together to advocate for better pediatric HIV and TB care. And this agenda, consolidated in Rome, have come to be commonly known as the Pediatric HIV and TB Rome Action Plan. The action plan resulted in commitments to accelerate, research, introduction, and update of HIV and TB diagnostics and medicines for this vulnerable population, with the aim of improving not just their quantity, but also their quality of life. Those involved in these commitments have been drawn not just from the donors, the World Health Organization and the Global Fund communities, but also pharmaceuticals, diagnostic manufacturers, academia, the faith-based organizations and other partners. Several national governments and respective ministries of health, including Kenya, are signatory to this agenda with the sole aim of ensuring the commitments are met. To this end, there are at least 79 commitments to enhance TB diagnostics and treatment for children spread across all the major players that we've talked about. These collectively also add to the United Nations high-level meeting of 2018 on TB commitment, which also aimed to reduce the burden of TB globally and among various populations, including children. First ever post-independence Kenya TB prevalence survey of 2015-2016 showed that as a country, we are missing almost half of the people with TB. Children are not spared in this. So they form the bulk of those missed, undetected TB cases. In the past year, 2020, the country notified just about 72,900 people with TB against an expected incidence of 140,000. So you can do the maths that we still have a lot of undetected cases within the communities and the ramifications of, infectivity out there. Of those notified, only 8%, that's about 5,600, were children. This is against a target of 12 to 15%, indicating the need to continue enhancing efforts in TB case finding, screening, testing and diagnosis, and of course, contact management. Even with the COVID-19 disruptions, which have adversely affected the TB world. So diagnosis of TB in children continue to remain a major challenge, not just in Kenya, but all over the world. Diagnosis of TB in general relies on the production of sputum, which is more difficult in children, as my previous speakers have spoken to, due to the bacillary TB and the difficulties of expectoration among children. Even if obtained, the sputum often has to be transported to one of the less than 3,000 gene expert machines in the whole country. The 300, despite a backdrop of over 10,000 health facilities, we have only 4,500 offer TB care. So you can see the disparities we have. It is clear we need children to access better TB diagnostics, which are based on universally available samples like stool and urine. So the World Health Organization in this regard has approved the use of Gene Expert testing platform to process stool specimen from children presumptive with TB. Kenya is in the process of rolling this approach out, which will aid in the diagnosis of TB in children. However, this does not eliminate the need for continuing to optimize, sample referral systems for the few gene expert machines in the country. Indeed, other molecular platforms are also being discussed for introduction, including TrueNut. So another approach we are looking at to improve diagnosis of TB is to use urine specimen, which every child is able to produce. The TB lab, as our county executive have talked about. We've piloted this approach, have learned our lessons, and the process of procuring adequate commodities to cover the people living with HIV and AIDS. However, this approach, the TB lab, will only benefit the people living with HIV, leaving out the majority of non-people living with HIV presumptive TB population. So there is that gap. But start is better than nothing, of course. Yet, I think another approach to aid in the screening and diagnosis of TB among children is the use of chest radiography, commonly called chest X-ray. This approach, of course, continues to gain traction in the country guidelines, and it's appearing in all our guidelines with the multiple challenges of cost and access and capacity for interpretation at the ground level. So we don't have, the requisite human resource across the country to do interpretation and of course the infrastructure for X-rays. So as a country, we recognize the compounding effect of the use of this approach to aid diagnosis. It can even help us detect other lung and heart conditions if TB is ruled out. So there's that multiple benefit from the simple chest X-ray. We as a country are in the process of taking stock of all chest X-ray machines available in this country, as we plan to make more available and plan on using artificial intelligence to aid in their interpretation, such that we try to fill the human resource gap, the skills, by having artificial intelligence and reporting across the levels of healthcare. So in the arena of treatment, younger children currently enjoy child-friendly disposable tablets. To this end, we applaud all those involved in the development of this, including the pharmaceuticals, who have very robust, R&D section. But we still ask, can we have treatment regimens shorter than 6 months? I believe the answer is an emphatic yes. As we gang around this problem, I think we should look at how we can shorten the duration and invest heavily in R&D. The R&D should be put on the table. Most of the medications used for treating TB were invented decades ago we for sure can have newer regimens. With regard to drug-resistant TB, we still lack child-friendly formulations of some of the repurposed and key medications. And again, for sure, can we have shorter treatment for drug-resistant TB, for DRTB? Tuberculosis can never be eliminated unless we terminate the cycle of being at risk and developing disease. So preventive, I'm here now focusing on TB preventive therapy. Certain populations continue to be at greater risk for developing TB disease. This includes children, contacts of open cases of TB, children contact, and children living with HIV. So these populations have to be protected in what has now been internationally dubbed as the TB preventive therapy, TPT. This process starts with adequate contact management and proper screening and ruling out TB amongst those living with HIV. Kenya has adopted, I just want to reassure that Kenya has adopted the newer TPT regimens in line with the most recent WHO guidelines. This includes the use of the shorter, treatment regimes in an expanded population, including the 3 months of daily rifampicin and isoniazid, and 3 months of weekly rifampicin. The challenge is children living with HIV are not able to use rifampicin-based regimens due to multiple drug interactions with their ARVs. Though rifampicin can be used in children older than 2 years, we currently do not have formulations suitable for children in general. So I'm just highlighting an area, a gap that we need to focus in terms of treatment. This leaves only the 6 months of daily isoniazid available for children living with HIV. We for sure need better, shorter and more palatable regimes for children living with HIV. I think this has been spoken to by the previous speakers. So we need to look around the formulation for children. So my remarks cannot be complete in conclusion unless I point out that the Kenya National Tuberculosis Program, the Ministry of Health, and the government of Kenya in general is committed to reducing the morbidity and mortality associated with TB in children. So I'm reiterating the commitment of the government and of course affirming that there's some gaps in managing TB in children as a government. The government continues to increase funding. Domestic funding has been going up very nicely towards TB in general, including contribution to the counterpart financing, of course, ensuring adequate staffing in our programs, championing universal health coverage so that everyone is reached and that the numbers, as the previous speakers say, actually mean people. So we need to universally, reach every child amongst other initiatives which improve the livelihoods of our population. That's having an impact in TB. So at this point, I would want to wish you all very fruitful discussions in this 2-day meeting. Thank you very much and God bless you all.
Okay, thank you very much, Dr. Wako, for your very good remarks, particularly in highlighting the disproportionate gap in case finding, diagnosis, and therefore care and treatment for children, particularly children with tuberculosis. Of note, you have mentioned the need for child-friendly diagnostics as well as child-friendly formulations for drug-resistant tuberculosis. You've also mentioned the government's commitment towards increasing funding for childhood TB in order to reduce morbidity and mortality. So, Daktari, thank you very much for your remarks. Moving on, I would like to invite Dr. Catherine Ngugi, who is the current head of the National AIDS and STI Control Program, NASCOP. Dr. Ngugi is a public health specialist and has been supportive of various issues and programs, including sexually transmitted illnesses, maternal and child health transmission of HIV, PrEP, and also early infant diagnosis. Dr. Ngugi has a wealth of knowledge and experience, especially in designing curricula and so forth. So Daktari, we would like to welcome you today. Karibu sana. Over to you, Daktari.
Good morning, everyone. Thank you, Dr. Lorraine. Good morning, ladies and gentlemen. Again, I'd like to recognize the following. CEO, National AIDS Control Council, Dr. Ruth Masha, Chair of Health, CEC Caucus, Joseph Mbai, UNAIDS Country Director, Medine Sehau, UNAIDS Deputy Executive Director, Dr. Shannon, World Health Organization Kenya Representative, Francesca Merico, PEPFAR Kenya Coordinating Country Program Representative, Dr. Daniel Tamu, Global Fund Country Program Representative, Mr. John Ochero, Chair of the CEC Caucus, Dr. Mbai, representative of faith-based organizations, representative from the networks of people living with HIV, civil society, and young people, specifically Vivian and Maureen Morenga, distinguished guests, ladies and gentlemen, and all other protocols observed. Good morning. It's my great pleasure to be here today to participate in the National Multi-Stakeholder Consultation on Pediatric HIV and TB. This meeting today demonstrates what strong collaboration and partnership among the various governments, multi and bilateral donors, development, donor partners, faith-based organizations, civil society organizations, and partners with regards to pediatric HIV and AIDS and TB response in our country can do. Let me start by sharing the status of where we are as a country in regard to pediatric HIV. Globally, Kenya has one of the largest HIV epidemics with about 1.5 million people living HIV. We know we have identified around 1.2, and we know but we have around 300,000 that we still need to identify. Among the 106,807 pediatrics aged between 0 to 14, we have only been able to identify around 70,000. Overall national prevalence have reduced over the years to 4.5%, and of the estimated 106 are those children aged less than 15 years. On the other hand, the mother-child transmission of HIV has significantly reduced from a high of 17% in 2014 to 10.8% in 2019. We appreciate that through partnerships, there has been significant progress made in efforts to reduce mother-to-child transmission of HIV and syphilis. However, we know that more can be done. Despite great progress made since the early days of epidemic, the HIV response for children has fallen behind as compared to the response in adults. We need to intentionally and deliberately put the children agenda as a priority. With the 95-95-95 UNAIDS targets for the management of HIV, adults start at 81% of knowledge of status, 81% ART initiation, and 77% viral suppression in this target population. However, when we compare with children, we have managed only to attain 67% of identification of HIV-infected children, 7% of ART initiation, and partly 55% viral suppression. Even though we know different counties are at different levels, but as a country, we are really not doing well. We know, yes, there are things, areas that, especially on diagnostics, that we still get affected over and over, not only in costing, but we have innovations. But in this meeting, I know we'll be discussing on ways that we can be able to curb on the first 90, second 90, and third 90. It's sad that in this era, we still see instances of mother-to-child of HIV and syphilis. By end of today, 1 in 10 infants will be born with the HIV, HIV-exposed children. They are really at risk. How can we collectively turn this tide? Looking at the 2019 estimates, a total of 6,806 new infections were among children below 15 years. Out of the total 41,416 new infections in the country. In the same year alone, 2019, around 20,362 children, 10 to 14 years, got pregnant. Again, this is unacceptable. We know that this population is vulnerable to HIV acquisition and further transmission of HIV to the infants. This makes children and adolescents a major cause for concern in the fight against HIV. We need to look beyond HIV and find ways to offer social protection to adolescent girl and orphan, as well find ways to have them retained in school and transitioned to secondary education. Ladies and gentlemen, this consultative forum comes at a very important time to provide an opportunity for dialogue between all the stakeholders in the country at the levels of governance among implementing partners, faith-based organizations, development partners, civil society, adolescents and young people groups, and networks of people living HIV to come up with commitments and action plans that will help in improving access to services and better outcomes for children and adolescents living with HIV. As a country, we must find ways to bridge the gaps in finding, diagnosing, and treating HIV and TB among children living with HIV. The commitments being made here today will hold each one of the stakeholders accountable in the fight against HIV and TB in children. Children in particular need better diagnostics in HIV and TB, child-friendly antiretroviral therapy, including fixed dose combinations and palatable formulations. Early infant diagnosis results harms treatment outcomes when children are started on treatment with advanced disease. You heard about Maureen Murenga giving her own personal story, which was really disheartening. Together, we need to put in place realistic measures to help identify children living with HIV, not yet on treatment, and retain them in the continuum of care. More emphasis should also be put on retaining the mother-baby pair or provision of family-centered services in our facilities. I was really impressed the other day when CDC officer presented on one of the baby pair projects that they are implementing in one of the sites that they support. And I look, how do we scale up on that baby pair innovation? Ladies and gentlemen, we hope that the consultations today will enable counties and healthcare providers to tap into the promising practices from fellow health workers and learn of community-led responses that support the identification and retention of HIV-infected children and adolescents. Why is this important? Data tells us that despite achieving 93% of ANC coverage and testing is at 81% at first ANC for HIV and syphilis, it is below the desired performance. We still have challenges in fourth ANC attendance and skilled birth attendance, which contribute to missed opportunities in testing and provision of maternal and infant prophylaxis in the prevention of mother-child transmission. Mothers are attaining fast ANC rate, leading to missed opportunities in testing and identification of those requiring intensive support to prevent transmission. The situation has been heightened by the COVID-19 pandemic, which has also contributed to a notable increase in the number of clients missing clinic appointments and a significant number of home deliveries. The low pediatric treatment coverage is a concern for us. Therefore, as part of efforts to intensify HIV pediatric case finding, Kenya has made significant progress towards adopting points of care technologies for early infant diagnosis of children. Currently, there are 66 POC early infant diagnosis platforms in the country. They are distributed across the country, many in hard-to-reach areas such as the Kenyan coast, northeastern, Turkana, and a few in Nyanza and Western. However, like ministry, we note with concern the lack of continued support for these platforms to ensure continued service and procurement of reagents. We urge our partners as well as county governments to allocate resources to ensure not only support of the existing point of care early infant diagnosis platforms, but further scale up to enhance timely identification of children living with HIV. Other additional efforts include the scale up of family testing at the family and community, as well as integration of HIV testing services in all children service delivery points at the health facilities. On the issue of suboptimal viral suppression outcomes among children and adolescents living with HIV, where only 77% of children on ART are virally suppressed, there is need to ensure maximal viral suppression to reduce the resistance to the life-saving ARV medicine and avail future options for these children and allow for normal growth and development of children and adolescents without being limited by the HIV. We know the dangers of low viral suppression cannot be underscored as these children are on lifelong ART. To address this, the Minister of Health in 2019 issued guidance and initiated a nationwide effort to transition all children optimized ART regimens. Currently, there has been a successful transition of children and adolescents from nevirapine-based regimens, where the transition from evavirance-based regimens is on course. over 60% of our children and adolescents living with HIV are on DTG-based regimens. The Ministry of Health is happy to report that we are at advanced stage to revise our national ART guidelines to adopt pediatric dolutegravir as part of our efforts to roll out pediatric-friendly regimens. And we hope in the coming months, from August or September, that we will transition the children that really need that this medication. More so on palatability, but as well as on easier way of and faster of attaining virus suppression. We are currently working closely with our partners to finalize a transition plan that will ensure the availability of pediatric DTG for our children from September, as I said, September, August there. Other additional efforts to improve virus suppression in children include the introduction of patient-centered differentiated models for treatment as well as ongoing caregiver literacy training. I wish to reiterate that as a ministry, we have committed to mobilize domestic resources to assure the security of HIV commodities, especially pediatric ART. I want to take this opportunity to appreciate Clinton Health Access Initiative under the leadership of Mr. Gerard Masharia and United for lobbying for pediatric DTG that is being introduced in the world. Kenya was among the first 5 countries through our Cabinet Secretary, Honorable Mutahi Kagwe, to request for the support. And through CHAI and United, we were allocated 25,000 packs of 90s. As well, we thank the 2 organizations, that CHAI and ECPAF, that have been able, and UNICEF, that have been able to support us in scaling up for POC and EID. Leveraging on Kenya AIDS Strategic Framework 2 and near final national strategic plans for HIV, viral hepatitis, and other STIs, we aim to achieve the vision of Kenya free of HIV infections, stigma, AIDS-related deaths by contributing to the attainment of universal health coverage through comprehensive HIV prevention, treatment, care, and support for all people in Kenya. We hope to reduce new HIV infections by 75%, reduce AIDS-related mortality by 50%, micro-eliminate viral hepatitis and reduce the incidence of sexually transmitted infections, reduce HIV-related stigma and discrimination to less than 25%, and increase domestic financing of HIV response to 50%. Strategies in Kenya AIDS Strategic Framework 2 are also geared towards optimization of ART treatment for all subpopulations to improve patient health outcomes, strengthen differentiated service delivery models to improve access and strengthen multisectoral engagement through private sector in HIV service delivery to expand coverage and enhance the effectiveness of interventions. Ladies and gentlemen, the pandemic has taught us the importance of building resilient health systems that can adapt to manage health crises while continuing to address the ongoing health needs of the populations we continue to serve. I know together we shall do it. Our country remains committed to the joint United Nations program on HIV and AIDS 95-95 targets for ending the AIDS epidemic by 2030. We are committed to the elimination of mother-child transmission of HIV infections, of HIV in pregnant and breastfeeding women from the current rate of 10.9% to less than 5% by 2024. But we cannot do it alone as government of Kenya, both nation and county governments, without the invaluable stakeholders from faith-based development partners, people living with HIV, civil society organizations, bi and multilateral partners. Through the support and combined efforts of the stakeholders in the forum, we'll be able to brainstorm on the proper solutions to address the gaps highlighted above and come up with the key action plans that will take us to the next level in our HIV response. The accountability framework of the commitment will allow us to take stock of our progress and raise awareness on the gaps we are facing as a country to promote case finding and greater access to HIV and TB testing, treatment and care, and strengthening the linkage and collaboration between healthcare facilities and the community. Some of the results we envision from these consultations at the facility and community level are that all pregnant women enroll early into clinics, initiated on treatment early, retained in care throughout the pregnancy and breastfeeding period, adherence to Minister of Health guidelines, especially on retesting guidelines, counties meeting their EMTCT targets, more male engagement in maternal services, community mobilization of HIV for HIV prevention, care, and treatment services with improved community facility linkage, social protection for vulnerable children in society, more interventions to address teenage pregnancies and sexual and gender-based violence. No time can be better than now to create those synergies to meet our goals of having 0 new infections, 0 AIDS-related deaths, and 0 discrimination together. From the speakers, I really want to highlight Vivian and Maureen Merenga, first thanking them for the openness to reduce stigma and discrimination. They have shared intimate information about their personal journey. Maureen, we hear you that there's need to prioritize psychosocial support and ensure client-centered services. Thank you, Dr. Tamu, Dr. Medin, Mr. Ochero, Ms. Manza, Bishop Rangat, Dr. Shannon, Francesca, Dr. Kisia, Dr. Wako, Dr. Mbai, and the upcoming speaker, Dr. Masha, for gracing this very important meeting. To succeed in the fight to end AIDS, partnerships of governments of the national and county level, development partners, implementing partner organizations, civil society organizations, and people living with HIV care are essential. I know on 8th June 2021, Kenya, in collaboration with PEPFAR, WHO, ECPAF, UNICEF, ICAP, there will be a high-level meeting on pediatric side meeting on HIV and AIDS. The meeting is dubbed as Ending the Inequalities, Leaving Children Behind in the AIDS Response, Fighting Complacency and Closing Gaps. The event will highlight achievements and gaps when there is political commitment, financing, and community leadership. And we thank the organizers for ensuring that Kenya is at the table. With these remarks, our children and mothers must survive to thrive. The buck stops with us. I wish you all the best in this two-day meeting. And at the end of tomorrow, we will have our action plan. And I hope that we can, all of us, be held accountable for the commitments that we make. Thank you all, and God bless you.
Thank you very much, Dr. Catherine Ngugi, for your very passionate remarks. You've mentioned and highlighted that while we are improving our mother-to-child transmission, we still have a disproportionate and unequal identification, ART initiation, and viral load suppression among children and adolescents. And the other issue that you have highlighted is the increased number of children or adolescent girls. You said over 20,000 who got pregnant in 2019, thus increasing their vulnerability to HIV. Thank you for highlighting that we have made great strides in actually transitioning children towards child-friendly formulations for HIV. Thank you very much for your remarks. And we'll be moving now to Dr. Ruth Libon Masha, who is the CEO for the National AIDS Control Council. Dr. Ruth is the Chief Executive Officer of NAC, as well as a public health specialist responsible for coordination of national HIV and the AIDS response in Kenya. She has worked with the United Nations Joint Program on HIV, as well as been an advisor to the Global HIV Prevention Coalition and adolescents. So thank you very much for joining us, and over to you for your remarks.
Thank you very much, Dr. Lori. Let me take this opportunity first to begin by thanking the participants, and my salutation has just alluded to the previous speaker, Catherine, not repeating that. I would like to acknowledge all of us, especially those of us listening from the international platforms. We want to acknowledge our partners from the UN, from the American government. We also want to acknowledge our communities of people living with HIV, civil society implementers, as well as government colleagues who have just spoken. Allow me to start by just reflecting on one statement that was done by the late Nelson Mandela. He said that the true character of a society is revealed in how it treats its children. So today we are here, all of us, and we've convened to speak about children. Children who may not have an opportunity to sit in front of these particular platforms that we have to represent their concerns. And as such, we are called to ensure that we are treating our children well so that we can live through the character of a positive nation and a society that cares about the children. The previous speakers have spoken a lot, and I don't want to repeat that. We've heard a lot about there is need to improve collaboration among stakeholders. We've heard about the Rome Action Plan, that we need to accelerate development of new pediatric HIV formulation at the global level. We've heard about the demand for concrete and measurable results for children, pediatric treatment for both HIV and TB. We've also heard that we are leaving many children behind. We've heard that there is need for us to ensure that we get back on track, especially due to the COVID-19 related disruption. And we've also heard that there is political commitment. And this political commitment is two-way. One, there's technical commitment that has been alluded to by most of us who have spoken previously with a lot of passion, that indeed we all would want the best for our children. And then there's also political commitment. We've heard that there's need to strengthen diagnosis and treatment for HIV and TB, including within the pharmaceutical industry. Everybody is willing to do something. So in essence, what we are saying is that we are all in convergence today, and we are all speaking to ourselves that indeed there's something we can do. We also take note of the successes that have been done. And like Dr. Catherine has passionately just presented, we have done well in some places. But in addition to doing well, we know that there are gaps. And we know those gaps, we also know how we can address them. So in terms of all of us convened today, the actions to take moving forward are not gray. They are concrete actions that you've all spelled and with the passion that it's desired. Allow me to move back to Kenya specifically. We have seen quite a number of progress areas. I would like to note that, for example, we have seen child mortality reduced. For example, in 2008, we were having around that 1 death per 1,000 live births. By 2014, that had gone down to 22. We also know that we have done well in the HIV response. We've reduced the number of AIDS-related deaths, but there are still deaths. And that's why the concern is for all of us, that even for that one AIDS-related death that occurred that could have been prevented, there's something we could have done better. We've had calls that one of the areas that we need to do and do differently is to be able to account for every mother, every child. I think this is usually said in paper, but we have done it before and we know that it can actually give us results. In 2016, in the HIV response in Kenya, we had a moment of celebration where we noticed that we were able to reduce HIV transmission rates from mother to child from as high as from around 13% to almost 8.6%. And we celebrated. But this celebration was not long-lived because the next year we started beginning to see something different and we began to see the gains are fragile. And these gains we had gotten for children are fragile. But what did we do well? We aligned our political leadership with our technical advocacy. We did jointly ensure that the partnership were well coordinated. We also did a very important thing that we jointly came together with communities of people living with HIV. And we had an initiative that we said we want to account for every mother, every child. We never did it on paper, but we practically did look for the mothers and children that we had missed. Mothers who had come to us, they had come to the facilities, they were tested, diagnosed with HIV, they were still pregnant, but you could not see them in our records as having received treatment for prevention of mother-child transmission. And so we went out there, supported by the partners, most of them represented here, including UNAIDS. And we began saying, let's look at our data and then move the data to the person and we trace the person. And then we trace the person and then we asked them, if they were still pregnant, what can we do differently? Can you come to the facility? In the end, we were able to account for that period of what we call the lost opportunity. The opportunity of a mother who presents themselves to a facility. Just like the earlier speaker said, Maureen Morenga did allude to the fact. She did arrive to the facility, but we were not able to give that service. And that particular experience for me really shows that it can be done. Sometimes when we talk about challenges, they look too many that we realize that unless we unpack them, we unbundle them, we are not able to achieve the results that we desire. So as we convene today, my prayer is that we shall look into our successes and ask ourselves, where did we succeed? What ingredients were on the plate for us to succeed? And then when we look at our success story, we then go back and say, where did we miss the opportunity to save a child? Where did we miss the opportunity to ensure that child was retained within our services? And then we ask ourselves, which children are we leaving behind? Who is the mother of this child? Dr. Mbai has been talking about adolescents. and Catherine alluded to it. In one of the cohort analysis we did, we found that within a short period of time, we could actually account for 60% of the mothers who had transmitted HIV to their children being adolescent girls between the age of 15 and the younger mothers to the age of 24. So what does that tell us? It tells us that there's a cohort, a group of people that we need to focus especially on this agenda of pediatrics. The other way that we know that we have done a lot of studies, we have done community-led studies, we have done scientific studies, but we need to ask ourselves, how swiftly are we translating this evidence that we're generating into our programs? Because if there's a disconnect between the evidence we have and what we have implemented in the programs, then there lies in a key gap that we need to start bridging. I think for me today, I'd like to call all the partners on board that can we get a way of making sure that any evidence, including new evidence that drugs work better, is swiftly translated. And that's why I want to thank NASCOP, led by Dr. Catherine. Dr. Kate has always been at the seat saying, let's put the children in a better, within a better regimen that give us positive results. So that is the kind of advocacy we want moving forward. Advocacy that has key action that it says, this is what we can do and do it for the children and for the sake of our children and also for the sake of the children of our children. So as the National AIDS Control Council, we look at the strategic focus areas that we have highlighted within the National AIDS Strategic Framework. And we are saying that let's sustain the leadership, the advocacy and communication for pediatric programs. Because as I said earlier, these children will never sit with us here. They need our voices. And they need our voices with the passion that they would have done if they had ever been given an opportunity or if they were in an opportunity to be a grown-up person and say what they were going through. The other one is expanding equitable and quality testing, prevention and treatment services for HIV and syphilis to all pregnant women and children. And then we add also TB services, as we heard from our colleague, Dr. Wako. The most important element here is we need to start beginning to say, in terms of this subpopulation, is it a geographical location that we are leaving behind? In Kenya, we all know that today we have mothers in areas we call arid and semi-arid counties, whom, because of the way the program is designed, that we are not reaching adequately. It is important for us to start thinking about those mothers. The mother in a high burden county is the same as the mother in a low burden county, because she goes through the same struggles if she's with HIV, living with HIV. So we begin to ask ourselves, how is the system prepared for any transitions that we're making? If we have verticalized a program and now we are asking for integrated approach, what does it mean when we live out, especially where HIV stigma is high? What does it mean when we defund communities and yet we want to address HIV-related stigma? Because our talk should also be our work. If those two are disconnected, then we begin to start seeing a partnership that is fragile, a partnership that does not have communities at the center, a partnership that does not bring public and private sector at the center of our discussion, then it's a fragile partnership. So that is one of the things that moving forward within the strategy that we would want to make them real. The other element is what I just spoke earlier, ensuring that we have routine monitoring of progress and accountability at all levels. For the HIV sector, I think the most important thing is to look at how well are we being able to monitor results. We cannot wait for outcomes. We can actually be able to say, this is the input we've done, and this is the output that we have within the program within the last 3 months. When we begin examining our outputs, then our outcomes shall start being aligned, because we shall be able to correct our mistake before it's too late. Every single mother we save, every single child we save, it's actually 1+ the ones that we are intended to save. In terms of funding, the earlier speakers did say that, of course, we have challenges with funding. Now, one of the things that we need to do is to ensure that both government and especially the Kenya government is putting money on the table, and especially for pediatrics. Dr. Kate, I think, has just alluded to the fact that the discussions that we've had since we had one of the recent crises is as to say, how do we ensure especially pediatric drugs are visible to all of us, and that we shall not ever have a time where we do not know where we are getting the drugs for the children. while I'm not underestimating the fact that you also need the drugs for the adults, I think pediatrics deserves an additional attention. And that's why I really appreciate the partners that came in, the United Nations, Clinton Health Access Foundation, that came out and asked us, what do you want us to do for the children? Because that is what you want people to begin asking. When there's a crisis, can somebody step in and say, is this crisis affecting the children? And what can we do to help the children? So I would like to say that it is in appreciation of the partners, Global Fund presented here, PEFA, one of the largest donors, that we have been able to jointly come back on the table and say that how do we resolve our differences to ensure that we do not have a program that is fragmented. We've also been able to discuss at length what unites us. We are united to seeing one positive outcome, an outcome where we can be jointly sit down and celebrate the fact that we've been able to end AIDS as a public health threat. As for the National AIDS Control Council, we shall continue bringing partners on board together. We shall continue providing those platforms that are needed. We shall also continue mobilizing resources. And most important, the resources to bring communities on the table. And when I speak about communities, I would like to just re-emphasize that we can never replace the power of lived experiences. Those lived experiences ensure that we understand from a different lens that if they were missing on the table, that what you would have done would not be the same as would have programmed without the communities. I want to give an example. I remember one lady, Joki, who is not in Kenya today, when people were discussing what is the best option for the regimen for mothers living with HIV who are pregnant. And there's a lot of discussion on the table. And she put up her hand and asked, which mother living with HIV would not want to take the most effective drug to prevent the virus passing to her child? And with just that one comment, she shut down the discussion that was there if to give every mother the drug or not to give every mother the drug. And that is the power we are saying, the power that saves us the time to analyze things in different lenses, because that power that comes from the lived experiences ensures that we move forward and we are able to swiftly translate the evidence, the science, and what you are seeing is good outcome to benefit all the other people who are not on the table. So with that, allow me just to sincerely thank all of us and also thank the partners, especially UNAIDS that has come up to convene this meeting with the support from PEFA and say that this is indeed a platform for Kenya, which is important, but also to ensure that we just don't talk and following the agreements and commitments that are going to be made on this platform, that we shall be able to move forward and implement them. I also hope that we will be able to reconvene again, because when you call for accountability, we need to call for accountability all the way through, that we shall be able to reconvene again and look at what have we benefited because of this platform. Does our discussion today provide any value into the programming? Does our discussion today provide any changes within the child and the life of a child that we are looking up, who are looking up to us today? So we hope that we will be able to reconvene at a certain time to look at our actions and also be able to say this is the result that we got today. So with that, allow me just to again sincerely thank all of us and say that indeed we have a conducive environment that you can be able to achieve everything that you commit to, and that we jointly can move forward to ensure that there is no child being left behind in Kenya. Asanteni sana. Over to you, Dr.
Okay. Thank you very much, Dr. Ruth, for that very impressive session, just recapping some of the gains we have made, but also reminding us where we have done well in terms of political and community engagement, and also reminding us that after these sessions, we should go back and take stock of where we have come from, what we have done, so that we can strengthen accountability. Thank you very much, Dr. Moving on now, I would like to invite Dr. Lazarus Momanyi, who will take us through a session. But before that, I would like to introduce him. Dr. Momanyi is the acting HIV care and treatment manager and technical advisor for differentiated service delivery at Ministry of Health, NASCOP. He's a medical doctor and a public health professional with over 10 years experience. Daktari, karibu sana to today's forum. Daktari will be taking us through a national program performance on pediatric HIV, as well as the priorities for us. Karibu sana, Daktari.
Thank you so much, Dr. Lorraine. Please share the presentation. Yeah, so as this is being put on slide mode, I think most of what I'll be saying has already been said, but for me, I'll just be putting it from the lens of the data that we see at the national program, because all the decisions that we make are really guided by the data and where we are seeing the gaps and what needs to be done or what's being currently done. I shall be highlighting mainly on the HIV program, and tomorrow during the TB session, some of the issues from TB will actually be highlighted. Next slide. Kindly move the next slide. So this is just the highlight of the presentation. I'll be looking at the burden, the performance, as well as the outcomes for children in terms of viral suppression and retention, as well as I'll give an update on the treatment optimization and then our priorities and next steps. Next slide. So this is just a slide to highlight our burden, and I think you've heard a lot being said about this number there, the 106. This is not just a number, but it's actually real children we are talking about who are estimated to be living with HIV in Kenya. And of note, we are saying that out of these children, we have close to 40,000 children who are still out there and have not been identified. We have done so well for the adults, but then for children, we are clearly lagging behind. And then just the other thing I just want to highlight is in terms of new infections, because we cannot talk about epidemic control without talking about new infections. The worrying trend we see is that most of these new infections are actually occurring amongst the adolescents and young people. So even as we discuss about children, TB and HIV, we also need to just put this in context. Next slide. So this is, as we talk about the new infections, we have again to put into the lens of the counties and looking at our most recent data in terms of the counties that are, what are we doing in terms of reducing the new child infections. And we are comparing here between 2018 and 2019. And we are able to look at the counties in terms of 3 categories. Those are that are doing so well that you're saying that have engaged the forward gear and have been able to reduce the new infections by more than 50%. There are those that have only have reduced infections, but not by less than 50%. And there are those that are actually doing the opposite, and you're seeing increase of new infections. And even as we talk about new infections amongst adolescents and young people, the other concurrent scenario we are seeing is in terms of the increase of the teenage pregnancies amongst very young girls. And I think this has been highlighted even by some of the speakers before. So these 2 issues really need to be handled at the same time. And here you can actually see the counties that we are worried, and we're really worried about the counties, the 15 counties you're seeing down there, where we are seeing increased infections, meaning that then a lot needs to be done in terms of reversing this trend. Next slide. We also know that the PMTCT, sorry, the mother-to-child transmission of HIV, as you heard even from the previous speakers, is really also a big contributor to the infections amongst children. And of note, as Dr. Catherine mentioned in the remarks, that there's been a reduction from the 17% that we saw some years ago to 10.8. But as you can see from the trend, at some point we are doing well and moving towards elimination, which is less than 5%. But then something happened, and we have not yet been able to get to 5%. So a lot of discussions, and I know even during this meeting, there'll be a lot of talk about what needs to be done for us to be able to reach that elimination target and actually be able to see less and less of our mothers infecting their babies. Next slide. So this is just to highlight, we keep on saying that children have been left behind, but then again, what is the data saying? And that's actually, you can actually see from the most recent data is that for the adults, we have done well in terms of identification and putting those who are infected on treatment, as well as the progress towards reaching the 90 in terms of viral suppression. But for children, as you can see, our coverage is only currently at only 63.7%, meaning that for these children, we need to identify the 38,000 who and almost 39,000 who are actually living with the HIV and have not been identified and put them on treatment. And this is the number, I think, from one of the speakers in the morning, I think from UNX, was saying, where are these children? Why are they missing, and what can be done to be able to identify these children? As well, for viral suppression, you can actually see that for children, we are again lagging behind. And some of the efforts we've made from the national program that I'll be highlighting in this presentation and in the other presentation later is really the issue of treatment optimization, just ensuring that these children are on the right regimen, their doses are right, that we have been able to train the caregivers and support them to ensure that they're actually administering the correct medication at the correct time and at the correct dose, and also addressing any other issues, including some of the issues they're dealing with in school and other areas where they're found. Next slide. Kindly move the next slide. Move the next slide. So we've been able to actually look at this in terms of the count. Just go to the first one, the one before that. So we've been able to look at the numbers, not just at the national level, but also looking at the counties. Because of each of these counties, they actually have targets that, or rather the estimates that have been done in terms of how many children in the respective counties are actually living with HIV and how many of them have they been able to identify. So from our national dashboard, we're actually able to disaggregate this data to the county level. And this data is also available for the counties to be able to see in my respective county. For example, if I'm in Bungoma, how many children do I have estimated to be living with HIV and how many of them have I been able to identify? So as you can see, the counties are performing, some have actually been able to achieve their targets, the counties to my left, to the left of the slide. And as you can see, as you move to the right, you can actually appreciate that some of the counties are really doing so poorly in terms of identifying children. And as you can see, we seem to have an issue again around the SL counties. And it could also be said because of some of the issues we have in terms of funding from PEPFAR that was skewed to the 40 counties and the 7 were left behind. But we know as a program that we need to focus in all the counties because a child in Isiolo is as equally important as a child in Kakamega. So our really task is to ensure that we're working very close with the counties. This data is available. And as a national program, we have actually now created this dashboard that is going to be able to identify and highlight each of the counties to their finest disaggregations where they're able to see which of my people are missing. Is the children, the adolescents, or the adults? Go to the next slide, kindly. Next slide. So this is showing in terms of initiation on ART, again, the same trend. You are able to appreciate the counties that have done so well in identification have also done very well in terms of putting children on treatment. So because the main role or the main reason why we really want to identify these children to ensure that they're actually put on treatment and actually on optimal treatment to ensure that they're virally suppressed. Next slide. And this is again just to show the performance of the counties in terms of viral suppression. And again, we are working very closely with each of the counties because we know that some of the issues that these counties are dealing with in terms of viral suppression are really unique to each of the counties. So with this data, then each of the counties is able to make a decision and say, why is it that in Turkana, we have a suppression of, for example, 65% or 70%? Why is it in Samburu, we have a suppression of 62%. So these are some of the data that's really going to help the counties to ensure that they're actually able to be held accountable. And even as we talk about accountability, then data is very important for us to be able to identify those gaps and be able to put in place very specific actions to be implemented by the counties. So we really need to break the actions to the level of the counties for us to be able to achieve the impact that we need to achieve. Next slide. So we have looked at the data in terms of, because if we lump together, then we are not able to see where the gaps are, and we've been able to look at the data now in the finer details, and we've been able to see that actually for viral load, even for viral load uptake, the younger children are still disadvantaged, as you can see, and therefore there's even a stronger role, as even talk about point of care access and scale up of point of care viral load testing. Then this is some of the children are really the population that can benefit from this, and even in line with the current WHO guidance. So even as we revise our guidelines, these are the things that we really need to strongly articulate in terms of ensuring that the access to viral load testing is optimized across all the age groups. Next slide. We have again looked at the data in terms of suppression. And I think, as one of the earlier speakers mentioned, is that the younger children is where we're actually seeing the lowest suppression. And this is the, as you can see from this, is actually where we have the 1 to 4. And these are the children we know that are on some of these very problematic drugs, the very bitter Calitra syrup, which is very hard to let for most of the children. And even where we have introduced pellets, we know that most of the caregivers are actually having an issue administering the pellets correctly, being able to give the right dose, and even ensuring that the child has actually swallowed all the pellets inside. So as much as we've done a lot of training for the caregivers, rolled out some of these options, we know that this is where we really need to have a regimen that is friendly to these younger children, that they are able to tolerate, that is palatable, that is potent, and at the same time is easy to administer even for the caregiver. And hence the role of pediatric DTG that we are talking about. And we believe that if we actually have the newer child-friendly regimens, then we should be able to sort out most of the issues among these children. Nevertheless, in addition to that, we also know that we have caregiver literacy issues. So as a country, we have been able to develop literacy materials, and we're still asking our partners and even the counties to ensure that these materials are rolled out, the caregivers are trained. We've been able to train them on how to administer the doses. But at the same time, we also know that some of these children are also going to school. We have issues around nutrition. So we have to address all the issues in totality to be able to improve the viral suppression at this age. But what you can appreciate is that the viral suppression, as we go up the ages, actually becomes better. So we really need to address these issues in our children. Next slide. So the same issue again, we still see in terms of even retention. So you can actually see that the under 5 again is where we have the lowest retention of our children. Though for retention, you can actually appreciate that across all the age groups, whether you're talking about children, adolescents, adults, we have not done so well as a country because you're talking about a retention of, an average retention of less than 80%, which is really not acceptable, that we are losing the ones that we put on treatment. So even as we talk about children, we didn't talk about what is it that we can be able to do to be able to ensure that we are actually retaining these children on care. We are talking about things like some of the promising differentiated service delivery models that we have been able to scale up for the adults, but for children, we have kind of left them behind. So what can be done to ensure that you're able to retain them on care? Are we able to link the ones who have like nutrition issues, support to OVC, and just really working closely with the other multi-stakeholders to ensure that we're able to retain our children on care. Next slide. So in terms of optimizing early treatment, remember I've talked about the poor suppression in children. And one of the things that we know is true is that some of the reason why these children are failing is because they have not been on optimal regimen. So basically an optimal regimen means that we are giving the child the best available option for them. And for a long time, we know that our children have been on some of the regimens like nevirapine and even efavirenz, that we know that some of them, the children have been failing on them, not because they're not taking them, but because some of those regimens, even just missing a few doses, then the child actually developed resistance, as well as we know that some of them even had what we are calling pre-treatment drug resistance, meaning that already been exposed to that, and therefore they were likely to develop resistance even with good adherence. So what we've done as a program is that we've been able to align our guidelines and our recommendations with the WHO, which says that this needs to be weight-based, because we know that when we give our children drugs as per weight and not as per age, then we are able to ensure that they're getting the right dose. And we also simplify dosing even for the caregivers and for the healthcare workers as they give the response. We also know that some of the regimens that we are optimizing or giving our children, like dolutegravir, actually is more potent and has even a lower genetic barrier, meaning that even in the scenario where the child misses a few doses, then they don't necessarily develop resistance to these newer medications. Next slide. So this is in terms of our journey, how we've come. We know that in the 2018 guidelines, we actually recommended that children should be put on optimal regimens. And we issued a guidance in 2019, October, that kind of was an RRI accelerating the transition. And here we are really focusing on phase out of nevirapine, children who are on nevirapine-based regimens. And we are happy to report that most, if not all of the children have been able to move out of these regimens. We have seen still some counties reporting that some children are on nevirapine, but we know that this could be reporting issues. So we are working very closely to ensure that we have the correct data from the facilities, as well as in October, last year in April, we also issued what we call a second phase of optimization. Just again, now even the ones on efavirenz to ensure that they're actually moved to the right regimens. And we have actually made very good progress, as I'll be showing you in the next slide. One of the things that we've been able to do also is we know that for the ones who are below 20 kgs, we do not have DTG available for them. And we know that DTG currently is the best option, or rather what is best for these children at this time, because of some of the issues that I'll be highlighting in the other presentation making the afternoon around palatability, ease of dosing, and even storage and all those issues. So, but as Dr. Catherine has mentioned, that we have made a very good plan, and we know that anytime from August, actually, we'll be starting, the first child in Kenya will be on pediatric DTG, and therefore this will be quickly scaled up to ensure that it's available for all the children who need it across the country. Next slide. So one of the things that you can appreciate from this slide is now the fact that just in the last 1 year, we've been able to ensure that we've scaled up the children who are above 20 kgs to actually be able to get the DTG 50 milligrams. And right now, as you can see, we are talking about 63% of the children under 14 years who are actually on on the DTG 50 milligrams, which is really the best regimen available for them. And therefore, any child who is achieving a weight of 20 kilograms is actually being moved to DTG 50 milligrams. At the same time, you can actually also appreciate the yellow is the efavirenz, which is the other regimen that we're transitioning our children from. And you can actually see that from the last 1 year, we've been able to reduce the number of children who are on that regimen from 23,000 to just having 5,000 right now. And even the 5,000 remaining, we know that they're about to achieve the weight of 20 kgs where they'll be moved. So we are avoiding moving them twice. But again, this is one of the populations that will actually benefit once we have pediatric DTG available. For nevirapine, as I've mentioned, we've actually been able to successfully transition, but even for the few that are reporting, we know that probably they're just reporting issues, and we are working with them closely to ensure that those children, if there are any, then they are not on a nevirapine-based regimen. Next slide. So as I wind up, I think what I wanted to point out, one, is that for the identification, we still have issues, as I've seen. We have not been able to identify the 38,000, almost 39,000. So we really need to strengthen issues around HIV testing at the various service delivery points, issues of index testing, issues of innovative testing approaches like the peer parent that we've been able to implement in some of the counties and seen actually has results. So these are some of the promising or rather testing approaches that we need to really just implement, as well as even within the community. We know that some of these children are within the community. So what can also be done from the community level in terms of ensuring that all these children who are out there have been tested. And so we hope to get some of those good suggestions in some of the track sessions to help us to be able to put together a plan, a national plan that can actually help us to be able to identify these children, as well as scale up of point of care early infant diagnosis, as has been mentioned, to ensure timely identification and decision on ART. For the suppression, as I've mentioned, we know that transitioning these children to optimal regimens is going to be one of the key things for us to be able to suppress these children. We are talking about introduction of pediatric DTG that is very critical, and I'll be highlighting that in the other presentation, as well as we've talked about DSD models for these children to ensure that they're actually retained on care, they're started and retained on care. Issues around HIV literacy amongst the caregivers cannot be underestimated, because we know that really, as you heard even from Maureen Murenga, that when her child was small, she was really able to ensure that she was on treatment and wasn't even suppressed. So we seem now also to be having issues with the older children, maybe are going to school. So along each of these age groups actually has unique issues that we need to have unique interventions for. We cannot also not forget our the healthcare workers, because we know that even in these transitions, we are talking about the rollout of the new regimens. We need to ensure that they actually are equipped with the right information to be able to advise the caregivers, to be able to look at the data that they have, to be able to look at the viral suppression. And we're also even talking about children who are on second line regimens. Well, actually, even some of them, we know that they are failing on the second line and they need to be put on third line. So we do not want a situation where the children are actually waiting for too long on a failing regimen. So capacity is very key to ensure that these are able to move the children quickly and be able to provide the best option for them. As a national program, we have also set up what we call the regional technical working groups across the country that are very active in supporting the respective counties to review these children to ensure that they've moved to the third line regimens. We cannot also not forget to mention that we still have a challenge as a country in terms of availability of the third line drugs, but we know that through some of our partners like ECPAF supporting us to ensure that some of these regimens are actually available for the children who need the third line. In terms of the cross-cutting, this kind of multi-sectoral collaboration for like the meeting that we're having now is really critical to bring together all the stakeholders. As you heard in the morning from some of the speakers, each one of us has a role to play, including the faith-based organizations, including the communities. I mean, even just hearing some of the testimonies from the beneficiaries, if another child probably or another adolescent was hearing that, probably they'll be motivated. So there's really a role for each one of us. Issues around linking these children to obviously support for those who need. As a national program, we are reviewing our guidelines, as Dr. Keita mentioned, to ensure that we have aligned all these things to, that we are seeing the interventions to our guidelines. As well as, lastly, we cannot, of course, underestimate again the issue around commodity security, as Dr. Kate and Dr. Masha mentioned, that we need to ensure that these drugs are available. So even as we plan the transition, these are critical issues that we need to tackle. Right now, we know we're even dealing with issues about availability of some of the regimens, like the Calitra syrup and some of the pellets. So these are really issues that we must tackle if we are really going to achieve suppression for our children. Next slide. So this just to acknowledge the healthcare workers, the county governments, our funders, Global Fund, PEPFAR, implementing partners, developing partners, as well as the networks of PLHIV who have supported us. Thank you so much, and back to you, Lorraine.
Okay, thank you very much, Dr. Momanyi, for that very insightful presentation. Thank you for highlighting the gains that we currently have, as well as the gaps and where exactly those gaps are. I think of note is that the younger the children, the more disadvantaged they may be as far as viral load suppression is concerned and retention. And I'm happy to note that there's a lot of effort towards availing dashboards so that programming can be data-driven in terms of decision-making, and also allocating resources, and also ensuring that our interventions speak to what the data is telling us. Thank you very much, Daktari. So team, we are now at a point where we need to take a break. And at this point, I would like to invite the next set of moderators who will be taking us through the next set of sessions. That is Maureen Inima and Dr. Wangui Muthigani. So at this point, I'll request that we all take a 10-minute break and come back at exactly 1:30 Kenyan time. That is 1:30 Kenyan time. So over to Maureen Inima and Dr. Wangui Muthigani. Otherwise, let us all take a break, a 10-minute break or 13-minute break, and come back at 1:30 p.m. Kenyan time. Over to you all.
Probably Maureen. Okay, sorry. So thank you so much. I think as the video comes on during the break, just to let everyone know that at the time we are coming back at 1:30 Kenyan time, you shall be automatically taken to the group that you preferred during the registration for the track discussions. Or sorry, we shall be having the presentations first. Sorry for that. We shall be having the presentations first before the track session. So at the moderators will be Maureen Inima and Dr. Wangoi. And this is just to thank everyone and also my co-moderator, Dr. Lorraine, for being the very able co-moderator. We shall share I've seen the questions about the presentations. We shall be able to share the final copies of the presentation to be availed to all the participants who will be available. So thank you and enjoy your break. Edwin, could you play the video in the background?
So let me tell. Hi, sharing the video in a short while.
Letting go of every single dream, I lay drawn down at your feet. Every moment of my wandering never changes what you see. I try to win this war, I confess. My hands are weary, I need your mighty warrior, king of the fight. No matter what, I face you by my side. When you don't move the mountains, I needed you to move. When you don't part the water, I wish I could walk through. When you don't give the answers, as I cry out to you, I will trust, I will trust, I will trust in you. Letting go of every single dream, I lay drawn down at your feet. Every moment of my wandering never changes what you see. I try to win this war, I confess. My hands are weary, I need your mighty warrior, king of the fight. No matter what, I face you by my side. When you don't move the mountains, I needed you to move. When you don't part the water, I wish I could walk through. When you don't give the answers, as I cry out to you, I will trust, I will trust, I will trust in you. Life's got surprises, and don't always expect a happy ending. But when you lose your hope, just keep on smiling. Reach for the stars and keep on fighting. 'Cause even when it's dark, dark and you're alone, don't ever give up. No, don't lose your hope. Just look up above. The sun is rising, a new dawn. Just keep on striving and don't lose your fighting. And even when it's dark, dark and you're alone, don't ever give up. No, don't lose your hope. Just look up above. The sun is rising, a new dawn. Just keep on striving and don't lose your fighting. And don't give up now, no.
Jambo, my name is Lydia, and as you can probably tell, I am a child, and today I seek to be the voice of children across the globe. Recently, my mom has spoken about HIV to me and my siblings. My mom has told us that many children are living with HIV, 2.8 million children, she said. My mom knows a lot about viruses and diseases, and she said that each day, 880 children become infected with HIV, and 310 children die from AIDS-related causes. She said that most of these infections are preventable only if their moms had the chance of taking the medicines necessary to control HIV. My mom said that all children living with HIV need special combinations of medicines to feel better and to live a healthy and normal life. I was shocked to know that not many children living with HIV get the medicines they need, and that only half of them has access to life-saving medicines. This is so unjust. Learning this made me feel a bit sad and angry. Why isn't it more being done for babies and children living with HIV? I am asking you all to join me in standing up against these unjust situations. Please join your forces and become the voice of children living with HIV. I am asking to all faith leaders to speak to the leaders of our countries and to the important people who have companies that make medicines for children, so that the best medicines for children are developed and given to the children. I am also asking faith leaders to talk about HIV in places of worship and to tell parents that there are medicines that can save their lives of those babies and children living with HIV and help them grow like all the other kids. I'm confident that each one of you can play a big role in the life of the children. Thank you so much for listening to me. Now, please act.
Letting go of every single dream I lay drawn down at your feet. Every moment of my wandering never changes what you see. I try to win this war, I confess. My hands are weary, I need your hand. Mighty warrior, king of the fight. No matter what, I face you by my side. When you don't move the mountains, I needed you to move. When you don't part the water, I wish I could walk through. When you don't give the answers, as I cry out to you, I will trust, I will trust, I will trust in you.
Is Michelle. I come from Kenya, and this is a message addressed to the religious leaders. Dear religious leaders, first of all, I would like to thank you for the work you have done and continue to do on HIV. Today, I would like to place a special request to you to eliminate stigma and discrimination. Over the years, people living with HIV, TB, and recently COVID-19 have faced stigma and discrimination, which have caused them lots of suffering. Stigma and discrimination make people with HIV, TB, and now COVID-19 scared to seek for help and support. Also, they cause that many drop out of treatment. It is my humble request that in your capacity and God-given capacity, you could join me and other children to speak out against stigma and discrimination. I hope that all places of worship everyone can feel to be loved, where everybody knows there will be someone to help. Offer support and psychological counseling in places of worship. Also provide safe places where people can comfortably share personal testimonies as well as messages of hope. I dream of a world without stigma and discrimination. Help me to earn them. Yours hopefully, Michelle Nganga.
Good afternoon, everyone, and welcome back to this wonderful auspicious day meeting on the National Multi-Stakehoders Consultation on Pediatric HIV and TB. So I have my co-moderator here, and I'll allow her to introduce herself and also to introduce this session. And I hope that you join us and participate actively as you have in the previous session. Thank you very much, and over to you, Maureen.
Thank you very much, Dr. Wangui, and good afternoon, everyone. Thank you again for tuning in, and thanks a lot for the discussions that are currently very rich. And I am a program officer. I'm based at the National AIDS and STI Control Program, and I'm focal person for quality improvement. So we'll shift gears now and look into some of the solutions and actions that we are proposing that will be related to some of the gaps that have already been highlighted in session 1. And so we will have some key priority areas to look at. And we'll do that by having 4 presentations. So some of the key priority areas would include actions related to low levels of early infant diagnosis, and equally review solutions that will enhance efforts to find children living with HIV. And we shall also discuss other optimal pediatric products. We shall also want to discuss solutions and actions related to access to optimal prophylaxis and children-friendly ART, including fixed dose combinations in palatable formulations. We shall also discuss suitable shorter TB preventive therapy, particularly for children, child contacts for people with MDR TB. And so to discuss, we know that this has been, children formulations have been a problem, especially making them fail to adhere to treatment, especially because of the palatability. So we'll want to see some of the proposed actions to support optimal treatment. So to discuss this, we shall have 4 presentations, and this will be focusing on certain areas. So we will look at service delivery in early infant diagnostic testing and access to optimal prophylaxis and child-friendly ART and TB preventive therapy. That will be covered by Dr. Lazarus Momanyi, who is the current acting care and treatment manager and has just left the floor in the first session. We'll also have a session that would look at, a presentation that will look at community response to early infant diagnosis, diagnostic testing and access to optimal prophylaxis and child-friendly ART and TB preventive therapy. And that will be covered by Dr. John Mutoko. So just to mention that Dr. John Waiharo Mutoko is the clinical director at EDAP, and he has had vast experience. He's had experience for the last 11 years implementing TB and HIV programming at EDAP, which is a faith-based organization operating in the eastern slums of Nairobi. So he will come in to give vast experience of what has happened, because he's also a technical working group member at the national and county level. We'll also look at innovation and leadership and governance. We'll want to discuss this with respect to early infant diagnostic testing and access to optimal prophylaxis and child-friendly ART and TB preventive therapy. And that will be covered by John Mungai. And John Mungai is the project officer with the CHAI, who is working on optimization. And then finally, we'll want to discuss gaps in data management system, limiting progress tracking for validation of elimination and achievement of expected impact. So we'll have Dr. Violet Oramisi, who's a medical doctor and currently the lead of the Strategic Information and Research unit at NASCOP, commonly known as SIRI. So as the technical lead, she will come in and just give us a glimpse of the perspectives of the gaps in data management systems that could be impeding our support for the pediatric HIV and TB. So I want to take this opportunity to welcome the 4 presenters. They will move simultaneously based on the themes that we have mentioned, beginning with Dr. Lazarus Momanyi. Over to you, Dr. Lazarus Momanyi.
Thank you so much, Maureen, for the introduction. Kindly, admin, share the slides on the screen. So, and you can move the next slide. As Maureen has mentioned, I've been focusing on service delivery. Some of the things that I've mentioned, I'll just allude to what I've previously presented, and I know some of the issues that also mentioned will be covered by the next speakers because these issues correlate. But I'll be focusing on early infant diagnosis testing, access to optimal prophylaxis, child-friendly health, and TB preventive therapy. Next slide. And this is with the outline of my presentation, basically looking at the early infant diagnosis from what we're seeing from the service delivery point, as well as transition to optimal child-friendly regimens and TB preventive therapy for children. Next slide. So we know that mother-to-child transmission of HIV still remains high. As we said, currently we are talking about a transmission rate of 10, meaning that actually almost 11, meaning that out of every 10 mothers, one who's HIV positive, one is infecting their child, and this is quite high. And one of the ways for us really to know whether children are getting infected or the outcomes is really to do what we call early infant diagnosis. And currently as a national program, we have an algorithm or basically a guideline on when this should be done for the children or for the infants. What we recommend is that really the first test should be done within the first 2 months, because that's when you want to identify the children as early as possible and put them on treatment. So as you can see, out of the total 71,100 early infant tests that are being done, only 41,000 are actually being done in the first 2 months, which is a very clear gap for us. Next slide. And this is clearly highlighted in this cascade. As you can see, we look at this in terms of how many mothers are estimated to be HIV positive while they're pregnant, meaning that these are the ones then who need to be tested at our facilities, identified, and put on what we call maternal heart, which is basically when we find our HIV positive mother, we put them on treatment to ensure that her virus is actually controlled, because we know one of the factors for transmission from the mother to child is a high viral load. So as you can see, in terms of that, we've been able to, like out of the need of 60,000, we had 60,000 who identified. So you can start with at each of these cascades or level, we are missing some mothers. So we have about 2,349 mothers who were not identified, and meaning that probably they were in the community and they never came to the facility for testing, because we know our testing at the facility is actually almost 100%. And then out of this, now we want to know how many of these then actually went ahead and got the early infant diagnosis within the first 2 months. And there is now where you see a gap where I've highlighted that we missed, out of these 60,000 who were identified, we missed 19,000 within the first 2 months, meaning that if they were tested, then they were tested after the 2 months, meaning that there's a clear gap there that we need to address to ensure that the moment we identify a mother at either at the natal care or at the clinic, then we are able to ensure that the child comes back to the clinic and the child is brought back, and we're able to test this child and be able to diagnose as early as possible, because we know some of the transmissions actually could be occurring. As much as most of them happen after 2 months from the data, we know that some of them are still happening within those 2 months. So the longer we delay in testing the child, the longer actually we are taking to put that child on treatment. As well, we know that there are also gaps in terms of access to the early infant diagnosis, which will be alluded by some of the presenters. Next slide. So this is just to show over the years in terms of what needs to be done in terms of identifying the children within the first 2 months. And if I may look at, you may look at the last, that's the July to December 2020, you can see that 71% were actually tested within the first 2 months. So there is some improvement in terms of ensuring that the children or the infants are tested within the first 2 months, but still more needs to be done to ensure that most of them are actually tested within the first 2 months. And this is very critical in terms of early identification and starting on treatment for those who are actually the children who are HIV positive or are determined to be HIV positive. Next slide. So this is just to show you in terms of early infant diagnosis. Again, now looking at the months, and this is the first test. You're talking about the first test, looking at the performance in terms of across the months. And as you can see, the positivity we are talking about ranges between 1.6% in some months to 2.4 months, basically meaning that for every 100 mothers who are HIV positive, when we test their infants at the first test, which we are saying that up to 70% of this is happening within the first 2 months, that out of every 100 mothers, 2 of them are actually, 2 of the infants, of those infants are actually positive. And meaning that this is very important because then we are able to immediately ensure that the child is actually put on treatment. Next slide. In terms of maternal heart and infant prophylaxis, we're actually doing well. We know that you've had challenges here because of the availability of some of the regimens. For example, the nevirapine syrup that is used by the mothers to ensure that because the guideline says that when you have a mother who is HIV positive, because she's breastfeeding and we want to prevent the child from getting HIV from the mother, then the child should be put on prophylaxis, basically given the nevirapine syrup to take for the entire period when the mother is breastfeeding. And we've had some, in the recent past, we've had some erratic supplies of the nevirapine syrup, meaning that some of the children were not on this regimen, which is leading to some of the gaps that you've seen. But overall, when you look through the months, we are actually doing well in terms of all the children who needed the nevirapine syrup, 60 up more than 90%, meaning that 9 out of every 10 of those children or infants is actually getting the syrup. But we're also happy to report that currently we've been able to stabilize the stocks of the nevirapine syrup for the children, and this is now available at the facilities. So we are very confident that any child who needs the nevirapine syrup then is able to get it for their own prevention so that they don't contract the virus from the mother. Next slide. So what are some of the opportunities we have? We know that in terms of testing of the mothers, we've been able to roll out what we call dual testing, meaning that a mother who comes to the ANC can be tested both for syphilis and HIV using the same test kit. And this is really important because it's going to improve our coverage for testing for syphilis, because we know currently we are talking about double elimination and also now even triple elimination by adding hepatitis prevention or prevention of hepatitis. At the same time, we've been able to, as Dr. Kate mentioned in a presentation, roll out what we call the early infant diagnosis, a point of care in some of the counties. As you mentioned, about 6-7 platforms across the counties. That really, helps us to ensure that all the children are tested at the same time, at the earliest time possible. And we know that they also reduce the turnaround time, meaning that the mother and the child do not have to wait for the diagnosis to be sent from the lab as they do the other convention testing. And this is really helpful and even ensuring immediate linkage to ART for those who need. But as mentioned by Dr. Kate, we need to advocate for more resources, both from our partners, but also even from the counties, for ownership from the counties to ensure that these machines are actually serviced and the reagents are available to ensure that they are working so that we don't have them lying around and they are actually needed by the children. Next slide. Next. You can move the next slide. I already talked about it in my first presentation. Next. Yeah, there. Yeah, so I think I also talked about this in the first presentation, but just to highlight on what you've done in terms of optimization. And optimization, I said, is just putting the child on the right regimen. Just to highlight what's in the box that we have. We developed a sensitization package in 2019 for healthcare workers to empower them to know what they're supposed to do, which regimen should be changed to what. We developed a dashboard that is actually able to help us to be able to monitor the regimens that we are transitioning the children from and how many children are remaining. But we also have regular data review meetings with the counties based on the dashboard, where we're able to say, County X in Kisumu, you have 10 children on nevirapine, where have those children not been changed to the right regimen? So this data is really very critical for us to be able to support those transition processes. Next slide. And this is just what I presented earlier, but now in terms of a chart, you can actually see how we've been able to transition our children. The ones on nevirapine, if you look at the where we are 23,000, talk about 5,000 only at this time. We have also been able to increase the number of children on DTG. Basically, this is because of the 50 milligrams that's now available for those children who are attaining the 20 kgs. And we are very certain that once we have pediatric DTG on board, then we should be talking about up to even 90% of our children on these optimized regimens. Next slide. Some of the issues that we are dealing with, even as we talk about optimization, is issues about documentation and reporting. And I know Dr. Ramis will be mentioning some of this, that we have some of the counties really not reporting the correct regimen or missing weight in the National Data Warehouse. So we have the National Data Warehouse is actually where all the EMR sites that the facilities have electronic medical records report. And from here, we're actually able to get patient level data, meaning that if I want to know the suppression of children who are, let's say, 5 kgs, I'm able to go in and get this data without really even having to use any paper-based system. And therefore, we really need to have the correct data. We have also had issues with the availability of some of the regimens, especially the pellets and the syrup. And this is the program is currently fast-tracking the deliveries. And for the Calitra syrup, I think we are told it should be here by next week. For some of the pellets, we're also trying to fast-track, even as we are waiting for the pediatric DTG. Next slide. So I'll briefly talk as I end about pediatric DTG, dispersible tablet. Go to the next slide. So why are we even talking about pediatric DTG? Basically, as I've shown you, all our children who are under 20 kilograms have to be put on a treatment. The part of their backbone or the other part of the 3 drugs is what we call a PI, a protease inhibitor, which in this case will either be Calitra syrup, which has its own challenges of being very bitter. It has to be stored in a cold place, and administration is also a challenge because it has to be measured and given the right dose. We have the other children who are on the pellets. Again, the pellets have their own challenges in terms of administration. The mother has to count them and reconstitute in a liquid, maybe milk or some other liquid, and then give the child. And sometimes the child will not swallow all the pellets. So it becomes a challenge. We also have this other problem about storage and even the dosing of it. So this pediatric DTG is actually a tablet that can be dissolved. We are calling it dispersible because it means that it can be dissolved in water. So if a child needs 1 tablet, it can be given once a day. The mother just needs to pick the tablet and put it either in juice or milk or water. And once it's dispersed, it has also been made to test better than the other regimens, meaning that the child now can actually swallow that reconstituted liquid with the drug inside, and it's very easy to administer. It can be given once daily. It can be given up to children up to 3 kgs, and a child with 3 kilograms is basically a child who is newborn, but of course we know that it should be given for a child who is more than 1 month old, as well as it has a high barrier to resistance, meaning that this pediatric DTG can actually, unlike the other medications where if a child missed a few doses, then they'll have developed resistance. For this one, you need to miss more doses for you to develop resistance, meaning that it actually protects the children from moving from that regime to another. And again, we know that this drug can actually be used from across the regimens, 1st line, 2nd line, 3rd line. So it's a very good regimen. It's available. It's been approved by the World Health Organization. We are putting it in our guidelines. And therefore, as Dr. Kate mentioned, if you may move the next slide, we are developing a plan to ensure that it's actually available in the country and for the children. Next slide. And here is just to show the dosing. As you can see, it can be given up to 3 kgs. And it's a once daily dosing, meaning unlike lopinavir or Calitra that has to be given twice, it can only be given once. And it brings all the advantages that you'll want in a child to have. Next slide. So what are we doing about the transition? One is that we know that this has been adopted by WHO, which guides our guidelines. We have also in the draft guidelines that we're developing, which we expect to launch in July, we have put it there that now this will be the preferred first-line regimen for all our children who are below 20 kgs and are above above 3 kg, below 20 kgs and above 3 kgs. Through the child donation from Unitaid, we've been able to get an initial donation of 25,000 doses, that's packs of the pediatric DTG. And in the last 1 month, we were just clearing the approvals in the country. You have to have a waiver and all those, but now we have gotten the waiver. And the information we have from CHAI is that this drug will actually be available in the country anytime in the next 2 weeks. As well, we are also trying to quantify how much more will we need in terms of the transition, if you're going to transition all the eligible children in the next 1 year, so that these additional drugs can actually be bought both from the GOK and from the other commitments, including PEPFAR. We have also started looking at the materials that we need to prepare our healthcare workers as well as the communities to ensure that they are well aware about this drug, how it should be administered, what are the advantages, so that we have that kind of advocacy for it at both from the community but also from the facility. We have some stocks of some of the drugs that we are currently using that as we plan to transition, we need to ensure that we also don't necessarily waste all the drugs, because we know some of these drugs are very expensive. So as we transition, we'll try to do the transition in an orderly way so that we don't have some sudden transition and then we also waste all the other remaining drugs. So this is part of what is being planned. But overall, the main thing we are talking about is that as long as this medication is available, then our children should be able to access it. So we are not going to have it available and kept in the stores, and a child somewhere is struggling with the Calitra and they're not able to swallow. So we'll have to balance and ensure that the benefits of the new drug that will be available now anytime from this month should actually be accessed. But we want to do that in a very orderly way so that we don't lose out on some of the benefits or the gains that we've made in terms of the transitions. So in overall, we are expecting that our children should be able to access this drug anytime from end of July. Between end of July and September, we should have our children to be able to access pediatric DTG. Next slide. So I'll briefly talk about TB preventive therapy. And TB preventive therapy is basically given to people who are at high risk of getting TB. And for us in Kenya, we're talking about those children under 5 who are contacts of TB, as well as those who are the children who are asymptomatic or are newly initiated on treatment. They need to be put on TB preventive therapy to ensure that they don't get TB. So currently, Kenya has adopted the shorter regimens in line with the WHO, when we are now currently using the 3 months of rifampicin and isoniazid as TPT for 3 months. And this shortened because previously, or rather what is currently in use or was being in use was actually the 6 month of isoniazid. So the coverage of TPT has continued to improve over time. And last year alone, we had about 8,803 children who accessed TB preventive therapy. Next slide. So this is just to show you the data in terms of how many cases were notified, how many of those had contacts, what's expected, that's about 9,000. And out of those, how many of them were asymptomatic? Because those are symptomatic and are contacts. For example, if you have a child and they have symptoms of TB, then we have to actually test that child so that we don't give them prophylaxis when they actually have TB. So for the ones who are asymptomatic, then we offer them TB preventive therapy. And you can actually see that up to 60% were actually offered TB preventive therapy, which is around the 60%. Sorry. Next slide. Oh, sorry, you can skip that slide. I think it was a repetition. Apologies for that. Just click next until you go to the next one. So in terms of TPT, what are the challenges? We have, in terms of like listing and screening the household contacts, this is suboptimal. So we need to ensure that when we have a parent or a caregiver who has TB, we should be able to know how many children are under 5 in that household that are actually now exposed, and we put those children on TPT. So this is not currently being done for all of them and needs to be improved. The other thing is that the knowledge gaps amongst healthcare workers also needs to be addressed to ensure that when a healthcare worker sees an adult with TB, then the immediate question they should ask, do you have any child at home who is less than 5 years who should be listed and started on TPT? But remember, we're only doing this for those who are bacteriologically, meaning that the lab, the gene expert, or the testing in the lab from the microscopy has actually said that this person has TB and is confirmed, not the clinical. As well, we have had erratic supply of TPT commodities as the drugs and inadequate awareness of the benefits of TB preventive therapy in the community. So as even we discuss in track sessions, we need to say what needs to be done to just raise awareness, because we know that by actually offering these children TPT, then we prevent them from getting TB. And that's really one of our cornerstones in terms of ensuring that we reduce the instances of TB amongst children. Next. I think that should be the last slide, and thank you so much, and back to you, moderator, Maureen.
Thank you very much, Dr. Lazarus Momanyi, for the very elaborate description of where we are at in terms of service delivery. We take note of the opportunities under service delivery, which you've very well alluded to, the introduction of the dual test kits, the introduction of the point of care platforms, which are 67 in total, the dashboards for monitoring transition, a very well elaborated, successful transition, phase out of the nevirapine. And then we are also getting the promise of a palatable regimen through the introduction of DTG, and also the transition plan considerations. And we look forward to ensuring that our children have this new drug. So thank you very much for that presentation. We go straight to Dr. John. Dr. John Mutuko, if you can hear me, please go ahead with the next presentation.
Thank you very much, Maureen, for this opportunity. So I will just take a few minutes to go through this presentation, and I will really be focusing on the community response for early infant diagnostic testing and access to optimal prophylaxis and child-friendly ART and TB preventive therapy. So the next slide just outlines my presentation for today, where I will just give a brief introduction of the program, that is EDAP, look at the different program areas that EDAP covers, and then just highlight on the main points around the community response in terms of early infant diagnosis, pediatric ART, as well as pediatric TB preventive therapy. So the next slide just shows really that Eastern Deanery is a faith-based organization under the Roman Catholic Church that was founded in 1993. And around in 1996, got some support from the National TB Program to set up a TB lab and started working with CDC around 2001. So from 2004 up until where we are, we have been a beneficiary of PEPFAR funding. Next slide, please. So really, this is just our mission and vision, and really our vision is to offer sustainable quality healthcare for all. Thank you. Next slide. So EDAP is a direct implementer, and everything that we do really is in terms of providing integrated services is done through an innovative community model of HIV, TB care and treatment. And the driving force behind that community model is the volunteer community healthcare workers, primarily and majority of whom are picked from the small Christian communities, or what we call jumuiyas. But it is also important to acknowledge that within the CHWs, or volunteer community healthcare workers, we also have beneficiaries of services who have felt the need to give back to their communities. Similarly, as part of the community model, we have the peer mentors, and for EDAP, we have two broad aspects of peer mentors, that is the adolescent champions, as well as the mentor mothers. So everything that EDAP does is done towards contributing towards achieving the universal 95-95 strategy, which has been highlighted by previous speakers. And we do it ensuring alignment to the PEPFAR 3 guiding pillars of accountability, transparency, as well as impact. So the next slide just shows the different program areas that EDAP is able to provide. Just showing, the different HIV care program areas, pediatric as well as adults, and of course the adolescents, which traverse the two age groups. And of course, various HIV prevention interventions, as well as TB interventions. So we do have a strong laboratory network, including an ISO-certified laboratory that is able to provide diagnostic testing for TB as well as HIV, including molecular TB DNA testing with the gene expert, as well as HIV viral load testing and EID. In the center of everything that EDAP does is what we have highlighted to earlier is the community healthcare workers, and they form a strong link to the community to just make sure that everything that we do is linked directly to the beneficiaries. Next slide, please. So really, when I was told to have a slide on the community response, I felt that I would look at it from the perspective of the community, not just as a beneficiary, but as a major player, and indeed, as part of the solutions for the challenges that we have been facing and have been highlighted in our discussions this morning. So one of the key roles of CHWs and peers in early infant diagnosis and the follow-up of HIV-exposed infants really begins at the point of identification, where community healthcare workers are able to identify pregnant women and refer them for ANC enrollment as well as ANC follow-up. Similarly, CHWs are also engaged in identifying ill or sick children and referring them to CWC, where again, based on the testing algorithm, then they would equally be able to receive testing. This way, we are able to identify various pregnant women as well as sick children who would benefit from early infant diagnosis. Another key intervention and role by the community healthcare workers is really the follow-up of PMTCT mothers as well as their HIV-exposed infants, really ensuring that there is adherence and support for mothers whose children are in infant prophylaxis, ensuring that there is defaulter tracing for mother and infant pairs that might get lost to follow-up, so that again, timely early infant diagnosis is done. They also ensure that they provide health education and support on the importance of infant testing, so that the mother in the community really understands the importance of having their child tested. And of course, after testing has been done, for all HIV-exposed infants who test positive, the CHWs also ensure appropriate linkage to ART. Next slide, please. So again, really, just to highlight the outputs that the CHWs have enabled EDAP to get to. And this is really data that is shared from our SAPR in 2021. And in that duration of time, we were able to ensure that we reached about 4,295 women with HIV testing, and 13% of those had really been referred by CHWs. Similarly, due to their efforts on follow-up of mothers, we were able to ensure EAD testing uptake of 86% at 2 months, a mother-to-child transmission rate of 1.5% at 18 months, and linkages to ART of 88%. And of course, when the efforts of the CHWs are combined with the efforts of the mentor mothers, they have also had a significant impact in the viral load suppression of mothers who are receiving PMTCT. And as has been alluded to, this is an important step in ensuring that we curb maternal to child transmission. And we were able to ensure that the viral load suppressions of 94%, both at the antenatal and the postnatal period for mothers. Next slide, please. So the other role really for CHWs and peers, other community, is in pediatric ART, is the follow-up of these children at the community level. And most recently, really utilizing the community healthcare workers to ensure supervised physical dose for children who are aged 0 to 5 years. And we have all seen in the previous presentation that this is the age group that has the poorest viral suppression, and that is really lagging behind as far as viral suppression is concerned. And we do hope that by really engaging the community healthcare workers and them ensuring that they are doing physical dots, that we should be able to ensure that this small age group that is left behind, gets to at par and gets to achieve 95% viral load suppression. Similarly, we have also engaged the community healthcare workers to follow up on the older children, but really here focusing on those that have high viral loads. And of course, again, the issues around continuity in care have been mentioned, and the community healthcare workers have got a significant role to play in ensuring that they are tracing all the defaulters that are lost to follow up. Next slide, please. So really, this is just a slide that shows, the efforts and the effect and the impact of the efforts of CHWs, specifically the yields of the physical dots. As you can see, before we started the physical dots or virtual dots by the community healthcare workers, the 0 to 5 were really lagging behind at 67%. And after 1 year of virtual dots and about 3 months of physical dots, we have been able to see significant growth of 74%. Of course, this is still far beyond the target, but we believe that this is a strategy that will enable us to reach the 95% viral load suppression. Next slide. So again, when it comes to TPT for pediatrics, the community healthcare workers have not been left behind, and they have played a significant role in what Dr. Momanyi has just mentioned, really the gaps that we are seeing in intensive case finding. And we are engaging the CHWs to conduct community intensive case finding for all children 5 years and below who are contacts of bacteriologically confirmed cases, and as well as referring presumptive TB cases that are identified from community screening for appropriate diagnosis and appropriate treatment. So some of the, next slide, please. Some of the outputs that we have had from CHWs is really ensuring that we have about 813 children that have been received screening for TB as part of intensive case finding at the community level. We have had 27 of those children being initiated on TB preventive therapy, as well as an uptake of 23% amongst eligible CAL HIV children aged 1 to 14 years. Of course, really, this should be much, much higher. So what are some of the challenges? And I think these have been alluded to and mentioned by most of the speakers this morning. And really, I think the issue of low stocks of pediatric ART formulations, and in the last 6 months, really, the struggle has been with Calitra, and this has necessitated, short refills. But this, of course, also ultimately has a great impact in terms of continuity in care and viral load suppression. Of course, again, one of the other challenges has been really the issues around low stocks and stockouts of TPT formulations, which has significantly affected the uptake. And, we do hope that this is something that could be resolved. Of course, there have been stockouts as well of EID reagents, and this has been mentioned by various players. And this has resulted in delayed EID testing, delayed identification, but we are happy to report that there have been supplies, and this situation seems to be resolved. Of course, I could not go without mentioning COVID-19 effects, because over and above the issues around ART and TPT and EID stocks and reagents, I think the socio-economic effects of COVID have really resulted in a lot of migration from Nairobi to other areas, and this has significantly also affected on the continuity of care for pregnant mothers, HIV-exposed infants, and even children who have been initiated on treatment and TPT. So really, those are some of the challenges that we have faced. I would really want to acknowledge all those people. Thank you very much for your time, ladies and gentlemen.
Thank you very much, Dr. John Motoku, for the elaborate presentation. We thank you for highlighting the key role we are seeing that the community has, and the part of the solutions that the community is giving to this issue we have. In terms of identification, we've seen the key role that the community healthcare workers are providing to just ensure that referrals to ANC and CWC are up to speed. Thank you for the data that you've shared that shows really how much the support has been for the community, from the community health care worker. We also note the synergistic effort when both CHWs and mentor mothers partner to support the follow-up of PMTCT mothers and their infants. So thank you very much for that elaborate presentation. We will go to the next presenter, and I am informed that it is not John, but it will be done by Philip Kimani. So Philip Kimani is a program manager at CHAI, and he will be taking us through the innovations and leadership and governance with respect to early infant diagnostic testing and access to optimal prophylaxis. If you can hear me, Philip, please go ahead. Philip, can you hear us?
Chair, if we could kindly request Philip to share with us his name on the chat so that we can be able to enable him to speak. Thank you.
Okay, so Philip, I can see he's written Philip Mushiri.
Yeah, we've given him the rights. He can go ahead.
Kindly go ahead if you can hear us. Over to you.
Okay, thank you, Maureen, and hi, team. So I'll be presenting some of the work that have been done in terms of CHAI, because as CHAI, what we look at is bringing innovation and also reducing the time from research and development to access to patient. And I'm just looking at the few things. So we'll be looking at EID and infant diagnosis and also optimization generally for ART. So the next. So back then in 2017, as a country, we were reporting about 69,000 of infants that were born of mothers of HIV. We know that within 2 to 3 months of HIV patients, they are likely to succumb to HIV if they are not diagnosed early. And some of the challenges that we were having as a country is a turnaround time, because most of the testing was happening at central laboratories. The logistical processes that were happening also led to a lot of loss to follow-up because of the turnaround time, and patients or infants and mothers could not be able to get their tests on time, with a lot of delays, even in terms of initiation of treatment in the country. So through working with the national program and taking leadership, we earmarked certain counties that we have had to reach. So next slide. From the EID utilization back in 2018, what we saw is that already about 26 counties we are still be able to achieve about 90% of coverage of initial test and leaving about 8 counties that had around 75%, between 75 to 90%, which we could term as medium coverage, and then about 13 counties which were hard to reach. Of them is the hard to reach facilities, so which are indicated in that grade. So next. So what we looked at is now looking at those counties that were had shown low coverage of EID, and what we to fix the issues that we had seen along the continuum from the initial test to 12 months of test, and what we had realized was actually about 39% of INAMs of infants had viral load test, which is quite low. So there was the desire to reduce the turnaround time for kids to be able to get their result on time, and what we were envisaging is to have it done within 14 days. So implementing so in 2018, only 12 counties had achieved this desired standard, and out of the 5 of the 12 counties were implementing POC EID. So, and among these now 21 counties had between 14 to 13 days. And while 13 counties initiated the infants on ART after 30 days, 30 days, which was quite low. So to achieve the county standard, the country, through the leadership of the MOH, now adopted use of the POC, which will help the program to initiate in a couple of counties to try and optimize also the RAB system that was already available. So next. So from there, so we realized there was some good improvement in certain counties with the implementation that. Though still we could not achieve the level that is expected in terms of patients or kids getting initiated or on ARVs on a time rate basis. So about 12 counties could be able to do within 14 days in terms of turnaround time, and they could be able to initiate infants on treatment, and this also being also a continuous process, which we still continue supporting the ministry to be able to improve the time taken for infants to get started on ARVs. So next, and what we saw with the introduction of POC, it took about 2 days, and then within some facilities, within 2 days they could be able to have the results with them. This was also increased the proportion of with the EID results, baseline of about 50% to about 95% for sites that implemented POC. So POC also reduced time for ART within 1 month of results to even less than 48 hours for supported sites. So, and even improved adherence to EID algorithm, especially for confirmatory tests for POC sites, relation remarkable improvement. So, and that also helped now reducing anxiety among mothers for waiting time to know the status of their infants. Still, suboptimal screening in high-yield areas such as malnutrition, follow-up, and clinics was still undermined the potential defecation of more HIV-infected children, and limited understanding of the demand for tests by clients, which reduced the utilization of the service and missed the opportunity even with the POC at site level. So next. Next. Okay, so the other part that I will be looking at is in terms of optimization for treatment through the leadership of the program. So looking at viral load and the kids that had shown high level of non-suppression, and particularly children who are below 4 years, we realized among this group, non-suppression was very, very high, which could be attributed more to the formulations that are available in country. So like ropinavirs, there we have about 4 formulations of ropinavirs, and we know the issues of palatability with ropinavir. And now using this, now considering that we need to optimize and ensure that our kids are able to achieve viral suppression, to achieve above 90% as with the 1990 cascade. So, and with this helped us now to start conversation in regard to introduction of DTG 10 milligram formulation into the country to try and resolve the issues that we have with the formulation that are there. So considering this, so we are bringing in DTG 10 milligram. So which we hope that the issues that have been experienced in the country with the Ropinavir formulation, probably we'll be able to address this, because now with the DTG 10 milligram, we require to only the patients required to use it once a day. So which we expect that that will make it easier for our infants. So next. So also just pictures what have happened over time, and we particularly for adults over time. We know we were in TLE, now we also moved now to TLD, and as a country and from CHI, we supported the ministry to adopt now DTG among adults, which we are also replicating the same now to children through also support from other partners that are in the space. So, and we saw this was remarkable improvement in viral suppression with the introduction of DTG in the country. So back from 2017, with the replacement of now the NNLTI-based regimens, we have seen remarkable improvements, moving from we were around 80% then, but now we are moving even above 94% current suppression rate. So next. So some of the factors to consider, even with the optimization that we is thinking through, what are the patient's visit and facility practice, viral desuppression as a rate limiting factor, and also considering that that's what we intended to achieve, but all our patients probably move even from above 95% suppression rate. So we have to think through stock status in country and even product pipeline and the manufacturers are available for this to ensure that there is commodity security in the country. So also have to think about the financing cycles, both the MOH, PEFA, and even GF, to make sure that with new innovations, they are well considered and well articulated through the funding cycles, and be able to categorize the country into new innovations. So next. So in terms of TB HIV, not much have happened, but just to mention just next. So some of the products through the ministry that are coming in, we expect that there will be now 3HP in the pipeline for children. So currently PK studies are happening for this, to see that kids can be able to consume it. We know with the current challenges with the use of isoniazid for 6 months, but now with the use of 3HP, which we expect that it will happen soon when we have enough data on safety, would be available even for kids in countries. So right now, we have already the country have adopted use of 3HP among adults above 15 years, and also contacts adults cases. So that have happened. So we expect that now in the pipeline, this is on products that this product will be available. That is single weekly doses for 12 weeks. That will probably will ease the burden of pill burden among children. So thank you. I think that's the end. Thank you.
Thank you very much, Philip, for bringing into focus the innovation around that have been able to support counties and the consumers of care in terms of testing. So we take note of the support that is really targeted to look at how county-specific performance is coming along for EID coverage and the adoption of POCs. We take note of the reduced turnaround time that comes to 2 days, which is extremely important, and ensuring that baselines for EID are at 95% within 48 hours. And you also allude that this supports a lot in reduction of anxiety of mothers, which was brought out very clearly by the speakers earlier this morning, led by Maureen Murenga. So thank you very much for that presentation, and we appreciate. We also appreciate the tolerable products that would be easily crushed in food to support TB and HIV treatment. So thank you very much. There are questions that are coming along, and because of time, we may not respond to all of them. However, we'll just highlight, and we will request that you could side chat directly to the presenters just to get more information. So there is concern that George Obala is asking to learn more about EDAP and their experiences in terms of community dots for the children under 5. So they would be more interested in just learning how EDAP succeeded in doing that. So Dr. John Mutoko, if you could respond to that, but not now because of time. The other concern is the use of abbreviations. The audience may not all be on the same page in terms of the technical jargon. So kindly let us reduce it as much as possible to make everyone comfortable with the presentations. So thank you very much. We'll go to the last but not least presenter, that is Dr. Violet Oramisi, who will be looking at the gaps in data management systems, limiting progress tracking for validation. So if you can hear me, Dr. Violet, please go ahead. Over to you. Thank you.
Thank you, Inima. Can you hear me?
Yes, we can hear you very well. Please proceed.
Right. Okay. Thank you very much, colleagues. And my name is Dr. Violet Oramisi. I'm the lead strategic information at NASCOP, monitoring and evaluation, basically. And I'll be taking us through some of the data gaps, just highlighting some of the issues that we currently have with our data. And you have been able to enjoy most of the data that's already been shared. So we'll move to the next slide. So what we just basically, yes, so the outline will be looking at what are some of the sources of the data that we have and how we are using this data, and then also just highlighting some of the data gaps that we have as we close the gaps that we currently experience, especially when it comes to pediatric data. Next slide. So as a country, we have data that comes from our facilities, and we also have data that comes from the communities. And the most important thing is that all this data, at the end of the day, we are able to visualize the data from our National Ministry of Health data repository, which is the Kenya Health Information System, for the data that we are able to collect from the health facilities that comes through, through the national reporting system, which is the Kenya Health Information System. And one thing that maybe I would like to highlight is that from the Kenya Health Information System, we get aggregate data, and from the National Data Warehouse, which is our EMR, which collects data from the various EMRs facilities that we currently have as a country, we are able to get individualized case-based data. And from the community, the data that also comes through the Kenya Health Information System is also aggregate data. Next slide. So once we get the data that we have, we are able to use it for various reasons, especially just to ensure that are we able to implement the quality improvements, especially when it comes to it. Are we able to utilize that data for routine patient care? And also, are we able to identify the gaps that are currently coming out from the system? So it's basically utilizing our data for policy at different areas of service delivery or different areas where we do implementation, right from the facility level or the community, right up to national level and even globally, for purposes of us being able to make very good decisions, as you have been able to see from the various presenters today, presenting data that we have been collecting from the various systems. And next slide. So data quality is really key for us as a country, so that whatever we are utilizing actually is work or information that we can actually use for the various reasons that we are collecting that data for. One of it, for example, being the target setting exercise, also being able to do results reporting, and also to improve the programs that we have, as well as also looking at how are we going to ensure that we are able to improve on resource management. So as we collect the data, we want to emphasize that we have quality data for use at the different areas where this data is being collected. Next. So key gaps that we have been able to identify, especially when it comes to data, and I would like to mainly highlight on the pediatric data, is one that currently as a country, we have a hybrid system of data collection, especially when you look at the EMR sites. We are still using EMR and paper-based sites. Previous slide, please. They are still using, yes, thank you. They are still using both the paper-based and the EMR sites, and the EMR to collect the data, which is a gap. And this is one structural gap that we have identified. And also for the paper-based sites, we have seen that we have gaps, especially when it comes to ensuring that all facilities actually have the required data collection and reporting tools on time. We also have human capacity gaps that we've noted, especially when it comes to healthcare providers. Quite a number of counties have employed new staff, and when it comes to capacity with regards to HIV indicators, and especially now talking about the pediatric indicators, you can see that we're having quite a number of changes. We are having new regimens coming, which are more palatable. But in terms of just being able to capacity build them to collect the information and also just know that this has been updated, we have capacity gaps. We've also had challenges when it comes to adequate multi-sectoral partnerships, so that we're able to plan and coordinate and also manage our pediatric data, where we are able to have such forums like the one we are having today, where we are actually able to utilize this data. This has been a gap, and also communicating our data for pediatric has also been coming out as a gap, and advocating for pediatric data use at different levels of service delivery. We've had it a bit, but it's still have for the pediatric program. Next slide. There's also gaps when it comes to routine HIV program monitoring, especially for the pediatric data. And one thing you will note that we have phased out some of the regimen, like for example, nevirapine. But when you look at our reports, and some of it was already highlighted in the slide that Dr. Momani shared for the regimen that the clients are taking, you'll note that we are still reporting on nevirapine. So this is a HIV program monitoring gap that we have noted, and we all need to be able to strengthen and see how we are actually able to going to put our efforts together to be able to work on this gap. We also have gaps when it comes to surveillance and surveys, especially for the pediatric population. Most of our surveys are heavily or are more heavy when it comes to adults, but when it comes to the pediatric population, then there is always a gap. And that is why we need to purpose as stakeholders when it comes to how are we going to ensure that there's surveillance. We're also able to conduct surveys that are pediatric specific, like for example, a CanFear that is specific to the pediatric population, so that we're able to actually get most of the information that is important for the pediatric population and addresses gaps and needs for this particular population. So there also we have noted a gap, and we also have a gap when it comes to a national database, because currently the data that we submit to the national database when it comes to pediatrics and children is aggregate data. Aggregate data basically meaning that for the pediatric population, we have the under ones, we have the age group 1 to 9 years, and we also have the age group 10 to 14 years. But sometimes we want to be able to just look at the under 5s, and when you look at the Kenya Health Information System, then this is a gap that we have noted that we are not able to get. One thing that I would also like to say is that the EMRs that we have, which currently host almost 80% of all the data for people living with HIV, this EMR hosts just about 36% of the data for the children who are living with HIV. So you can see that we still have a big gap in terms of just being able to get specific data that is specific to the baby or to the children that we can be able to utilize at scale and be able to, do further analysis when you want to aggregate, or you want to be able to analyze age specific, you want to analyze regimen, because the data that we have in KHIS, which is more than what we have coming from the electronic medical records or the computers that we have at the facilities, is very little. So most of the data that we have for the babies or for the children is data that is coming through the Kenya Health Information System that is paper-based collected, and it is aggregated. So we are not able to see the age disaggregations very well. And you can see that right now we really need to be able to make decisions, not only based on age, but also based on their weights. And the other thing is that we have also noted gaps, especially when it comes to auditing the data at the county level and also at the subnational level, right at the facility where data entry is being done. At times you find that a healthcare provider has entered, like for example, nevirapine and other regimens that no longer exist. And they put this information across, and at the national reporting system, you find you have regimen being reported, yet these regimens are no longer in use. So this is also a gap that if we audited frequently at the facility level, auditing our records on a daily basis, and also at the sub-county level, auditing our data weekly basis, monthly basis, through the data quality assurance that we are supposed to institute based on the national guidance that we have given as the ministry, then that will also be a way of improving that gap that we have noted. A gap that is also noted is the low demand and use of data. So the demand for data use at subnational level most of the time is very low compared to other areas. And this is one area that I think if we all put our heads together and address it, then we should be good to go, especially when it comes to use of data. And also being able to just use this data, visualization of this data using various platforms. The Ministry of Health and also the Ministry of Health, that is NAC, NASCOP, and also the larger MOH, working on various dashboards that we're currently working on. We have the integrated dashboards that we have been working on to just be able to visualize most of the data and increase the demand that we have for this data. And that is the way that we would like to go. But first of all, you can see that if we only have about 36% of the pediatric data coming through the EMRs, then it means that we have a lot of work to do so that we can also enjoy good data coming through the various dashboards that are being developed for the pediatric population. Next slide. So I just want to do a small deep dive into some of the data that we are getting through the electronic medical records. That is the Kenya EMR, the open source MRS system that we are currently using as a country, and some of the gaps that we have noted. For example, when it comes to the first 90 identification for all the children, Some from the records, we see that there's information on birth history, but when it also comes to information, like for example, above the age for EID that is above that, then we have gaps. We also have gaps when it comes to issues like, for example, what are the risks for transmission of early childhood? They have not been included in the current data collection that we have in the EMRs. And we also don't have an eligibility screening that is age appropriate. We also have gaps when it comes to reporting, especially for the children, that is not appropriate, because whatever the risk screening that we have was mainly designed for the for the adults. So the children, we still have a gap when it comes to the first 90, when it comes to the records and also the reports that are generated. Next slide. For the second 90, which is in the next slide, yes. For the second 90, we have gaps, especially when it comes to records that are being filled by the facilities. Like for example, the drug dosage. Weight is, for children, we give them dosage, or we calculate their dose based on their weight. So if we do not document the weight, then we end up giving the children sometimes the wrong regimen. So it is mandatory for us to ensure that as healthcare providers, we are able to completely compute the weight indicator or the weight variable whenever we are filling in the record. Age appropriate because their weight was not well documented. And also we have issues around drug dose adjustments over time, because you see for the children, they transition from being a child to an adult, and we need that to be able to come out. Also interventions, for example, for malnourished children, this is not well documented. We also have issues around regimen changes from when a child is transitioning from being a baby, they become now adults. So how are we documenting this? So this has also been a gap that we have noted in our data. And it needs all of us to just put our heads together and see this, including disclosure as per the Ministry of Health recommendation for the status. Next slide. For the third 90, which is on viral load suppression, the reports that we have, especially when it comes to interventions for unsuppressed children, we have also noted gaps, and also the caregiver details. They are not being well documented, especially for children who are virally non-suppressed or unsuppressed. We need very good details for the caregivers, because we have to give more services to children who are not virally suppressed. And also the component for just giving reasons why these children are not virally suppressed. So that is also a gap that we have noted in the reports. So this is just a slight deep dive into just one of the data collection points, which is the EMR, in terms of just being able to report first, second, and third 90 is with regards to children only. We have many other sources that we use to report, but this is just a summary of some of the gaps that we are noting when it comes to reporting for the children. Next slide. So in summary, I think all of us need to put emphasis in terms of how do we strengthen the gaps that we currently have when it comes to data. Remember that for data, it is very important for all of us to ensure that whatever you put in is what you get out. So if you feel or you feed into the system garbage, then rest assured that we are going to get garbage out. So when we are doing our many assignments, for example, also generating estimates for the population, because right now we do not have case-based data for all the population, then we are going to get wrong results. So the emphasis is that we have to ensure that we are able to all put emphasis on just ensuring that we have correct data to be able to monitor the impact of not only our interventions, but also just being able to monitor, are we getting to our targets? Are we getting to our goals? So it's important for all of us to just make sure that we're able to emphasize and put in efforts towards that. And for us to do this, then it means that we have to work together as stakeholders, and even right from here, when you demand for quality data, then it means that as stakeholders, we are all going to ensure that, you know, the data demand, information, and use component is actually going to be taken care of. We're also putting emphasis on ensuring that we're actually able to do capacity building for all the healthcare providers who are involved in the data entry or data collection, so that you are aware what information are we required to put in, and you're able to audit the results that you're putting in. You're able to audit your own entry, and you're not just working as a robot who is just entering data that yourself, you cannot be able to consume the same data. And I think if we all put emphasis on the fact that we need quality data and we demand for quality data, when you look at all the components of just ensuring, do we have quality data for the country? Do we have quality data so that even as we submit our global reports, is it the data that is making us not be able to achieve all the efforts that we are putting in place? So those are some of the emphasis that we are putting together, that what can we do together to just ensure that you are getting that data that is required. And for the governors, for the county officials, for the partners that we have, use the data that we are generating. And the thing that we say is that when you generate more opportunities where we can be able to share and provide more forums where we can actually be able to share data. This is just one of the forums that we have had today, and you've been able to see the wealth of data that we have. And the more we send it, the more we share it, then it means that the more the demand, then we are able to improve on the quality of data that we currently have. Next slide. So it's to just appreciate all of you for taking time to be part of this symposium today, and to task you to use the data that we are generating. And whenever you have a question, please be able to reach out, because with the demand for the data and we are able to use it, then the quality of data that we are generating right from the facility level is going to improve. So I take this opportunity to now hand it back to the moderator for the session, and thank you very much for listening to me. Back to you, Maureen.
Thank you very much, Dr. Violet Oramisi, for articulating issues around data. We acknowledge with passion that you have brought out the gaps, the data quality gaps, the capacity gaps for MND, the inadequate multi-sectoral partnerships. We need to look into advocacy and communication. And most importantly, you've mentioned that it's garbage in, garbage out. So emphasis on correct use of data so that we improve on data demand, information, and use. So thank you very much for that. And a quick question for you. I think that you could easily just give feedback. Is someone asked that you expound more on nevirapine reporting, though I saw that you were able to look at gaps per cascade. So probably in the slides, you could provide that in the chat, but you could also give feedback on a question around the data warehouse. There's a question whether the open source is available, the platform is available to CSOs and communities. Over to you very quickly, if you could respond to that.
Thank you, Maureen. You have asked about if the Kenya EMR is being an open source platform, is it available? Yes, it is available. And that is why we made it open source. We made it open source so that we are all able to benefit from it. And the good thing about it being open source is it benefits from a community of developers. It is not proprietary.
Sorry, we lost you.
Yes, can you hear me now?
Yes, we can hear you now.
Yes, so these platforms are available for us to use. And the thing is, just reach out to NASCOP and we'll always be able to discuss as the HIV program, in the Ministry of Health, how all of us are able to tap into this. So it's available for all of us as a community. For the issue of nevirapine, yes, we have phased out nevirapine, but because of the gaps that we have highlighted in the first 90, second 90, and third 90, as Maureen has said, these are some of the gaps that we are still noting, especially when it comes to reporting. And that is why we say capacity gaps that exist, that we really need to be able to address them at the various service delivery, that we work collaboratively. Partners taking up the responsibility, government taking up the responsibility, and us, all of us putting this together and ensuring that are we able to actually capacity build the healthcare provider who is feeding this information into the system, so that whatever we are doing as government is standard across board, and we're able to get standard and quality results from all the facilities or the service delivery points that are reporting to our various systems. Thanks, Maureen, and over to you.
Thank you to all the presenters of this plenary session. Thank you, Maureen, for guiding the discussions during this time. This is Dr. Wangwe Muthigani from the National AIDS Control Council. And I do want to be cognizant of our time constraints today as we move into the next breakout session, where we'll have track 1, track 2, and track 3. The first track, service delivery. The second is community response, and the third is innovations, leadership, and governance. So in each of the breakout sessions, you'll have your group moderators. And I'd like to inform the participants that you had pre-selected the breakout groups when you registered for these sessions. So for the first track, that's service delivery, your group moderators will be Francis Ndwiga and Miriam Mwangi. The second track is on community response. Your moderators are Maureen Murenga and Brian Otieno. And then for the third breakout session, your moderators are Dr. Violet Oramisi and Grace Karaoke. Our initial time is 45 minutes, but I think we can request for us to keep it short and have it at 30 minutes. Then we'd like the participants to address three key questions, and that's what are the urgent issues or concerns in this area? What actions and solutions the organization could offer in order to address such challenges? And then third, what would you need from other stakeholders present at this consultation in order to realize the actions and solutions you have proposed? So for each breakout session, you'll have your group rapporteurs. They're expected to come up with a short summary of key actions and solutions in relation to the key areas that you'll have discussed. And then you'll present them back in plenary with each group getting about 10 minutes to present. So I'll hand over to IT to allow the participants to break out into the three sessions, into the three breakout groups, and then we can meet back here at 3:30 to have the plenary session. Thank you. Over to IT.
Okay, then. We shall send different participants to their respective breakout sessions in a short while.
Hi, hi everyone. Hello. So everyone else has gone to the discussion groups. Could you please chat me the group that you'd like to join? Just send me a chat message and indicate which group you'd like me to add you, please.
Welcome back from your breakout sessions. I hope you had fruitful and open discussions around the 3 strategic areas that the groups were dealing in. I had a chance to sit in quietly in one of the breakout sessions, and I must say it was edifying. The sharing, the information, teasing out the key issues that are really plaguing the service delivery realm for pediatric HIV and TB cohorts. It was something that was eye-opening. So for now, without further ado, and given that we have time constraints, I will request the group moderators to give us, if possible, a 5-minute synopsis of what was discussed. Please be brief, just touch on the key points, then we can proceed. Thank you very much. Can we start with the group for service delivery? Thank you. Okay, allow me to ask IT to unmute Janet Muema, please.
Chair, who else from the second group do we unmute? Or who will be presenting for group 2? Maybe they can put that in the chat box so that we can unmute them in advance.
Okay, so for group 1, please unmute Janet Mwema.
Okay, thank you. I think I can proceed. I've been unmuted. We were handling the service delivery group, track 1, moderated by Dr. Lazarus Momanyi, and we were looking at the main points as shared in our program. So our first focus was about the urgent issues or concerns in the area of service delivery, including the data gaps that requires to be addressed. So the participants were able to share key important points. One is the issue of lack of diagnostic commodities. This includes DBS filter papers for EID and also inadequate determined test kits to support timely identification of mothers living with HIV. And then the other one was around a shortage of gloves and also inadequate or complete lack of dual HIV syphilis rapid dual test kits. It was stated that they are not available at all in the warehouse. What was available was distributed to some of the counties. Then the other one was around the stockouts of lopinavir syrups for pediatrics and also stockouts of TB preventive therapy, including pyridoxine. So that was under the diagnostic commodities. Then the other issue that came up was the long turnaround time for both EID and viral load. Thirdly, we had inadequate training for healthcare workers on PMTCT, contributing to missed opportunities for the in the identification of the HIV, of the mothers living with HIV, and also prophylaxis for the infants who are born to HIV positive mothers. Then the other one was a weak psychosocial support systems for our pregnant and breastfeeding mothers that were cited to contribute to poor adherence. Then the last one was around, not really the last one, but towards the last issues was around the low skill deliveries. And we also had gaps in tracking for the mother-baby pair. That is in the area surrounding the hay audits, and also the lack of audit cohort analysis tool to monitor the mother-baby pair. So having come up with those, identified those issues that needed to be addressed, the group also came up with some of the solutions that will be addressing the identified issues. One is timely and adequate forecasting and quantification for the commodities for all populations, that we don't run out of commodities. Then the other one was coming up with a work plan for distribution that is monitored for viral load and EID, just to ensure that stocks are available. Then the other one was around just for the short-term response is on effective communication from the national program, just on the availability and projection of commodities. The issue that came up is just to ensure that mothers or the facilities are made aware of when to collect samples from the children. Then the other issue that came up just to address the gaps is scaling up point of care facilities, especially to the hard to reach regions. Then introduction of new pediatric ART formulations is a long-term measure to mitigate the stockouts of pediatric clopidogrel syrup. And that includes the pediatric DTG as a long-term solution. Then the other one that came up is the national stock taking, especially for the vitamin and duo kits. The team realized that some counties might be holding large commodities of vitamin or duo kits, and which they might not really need to use in their counties or the facilities. So this stock taking would help to redistribute these commodities to the counties that are in need. Then the other key issue that came up was the inter-county referral. That includes sample networking with other counties that might be having the EID reagents, just to ensure that we don't really have reagents that are expiring, and then we have children that are not getting the service, that we have some counties that have excess of these reagents. So the other issue was just to optimize the issue of capacity building for our healthcare workers, and especially on the areas that are coming up, like something that came up was the area of TB diagnostics through nasal gastric lavage, and there was also the issue of diagnostic through stool sample that will be coming up soon. So when it comes up, it's good for the healthcare workers to be to acquire all the knowledge and capacity to ensure that they are able to offer the service. Then the other one was just to work together with the COE members, specifically for the PMTCT, so as to develop and adopt, or adopt a national hay cohort analysis tool to support the mother-baby pair audits, and together with the national program. Then the other one was the other gap that came up was the issue of skill deliveries. So the issue was just to ensure that we work together with the community systems that are in place to ensure that there is promotion of the skill deliveries from the community level, and have the mothers coming to the facility for deliveries, and also to have the infants that the infants get the prophylaxis, and that is basically the infants who are in need. Then the other issue that came up was the issue of TPT, or TB preventive therapy. So as a short-term measure, all facilities will be required to list all clients who have not received TPT, or maybe they have not completed TPT, so that once stocks are available, all facilities will be able to set aside or to prioritize these individual clients and set aside their packs, complete packs, just to ensure that all of them are able to complete the treatment course. Then the other one that came up is around the point of care for multiplexing, especially for the hard to reach areas. And we had a question. I just put it under the any other key issues arising for consultation to a larger audience. We had a question that came up around, I'll just read out the question just as it was posted. Is there legal action you can take to a mother who has had 2 kids stand positive because of negligence and presents back to the facility pregnant for a 3rd baby? So this is a question that came up and we didn't really address it, and I just posted it to the 4th key question. Thank you, and over to you, Dr. Mutigani. Dr. Mutigani? Dr. Momanyi? Hello, was I audible enough? Because I can't get our moderators. Or Maureen, Inima.
Janet, you are audible.
Okay, thank you. Thank you.
Let me try and get Dr. Momanyi on the phone.
Thank you.
I can see Dr. Wangui on the call. Is she not able to hear us? Janet.
Okay, let me just confirm.
Yeah. But in the meantime, I want to believe that perhaps it can be opened up a bit for participants on the call to make any suggestions, comments, clarifications. Yeah?
Yeah, I think we can open it up as we also wait for
the main moderators.
Yes.
Colleagues, my name is Ludfin Bunde at UNAIDS, Kenya. I'm just moderators of the session. So we've just had a presentation from the track that was dealing with services, and therefore we would like to open it up for comments, suggestions. Any hand that we can see quickly? If there's none, then Janet, we just want to say for the presentations. Oh, okay, Esther, please proceed. Unmute and proceed, Esther.
Maybe they need to be unmuted by the admin. I realize the participants can't unmute themselves. Thank you.
Yes, good afternoon. Thank you so much. There was a question which had been raised by the presenter of, there was a concern that a mother who is actually negligent or something of the sort. And I think if these people would get in touch with the CACs in their constituencies, they would help them actually to attach them to homes and even a mother, because according to the law, this is a person neglecting a child and is liable for being taken to court, and the children would be withdrawn from her and be placed in a home. We need to work together with the children offices. Thank you, and over to you.
Thank you, Esther, for that recommendation. about working with the children in our counties at the national level to ensure that the rights of the children are not violated. So for our rapporteur, you could please put that as one of the recommendations. Colleagues joining, this is service delivery. They have just given us their presentation. So we were waiting for the main moderators. I was just standing in. Dr. Wangui, are you in? Okay, do we have another hand? If we don't, then we could go to the next track and talk about community-led interventions. Maureen, are you in? You give us a brief of what has transpired.
Thanks. I'm back in. I was muted, but I think we could continue. Dr. Wangui, I don't know whether you're on. We needed to hear more from the other track sessions.
Yeah. Okay. So is that who is speaking? I was just standing in for the main moderators.
That's Maureen. Maureen Inima, one of the main moderators.
Please proceed. Proceed. This is Ludfin. Please proceed.
Thank you, Ludfin. Okay. So we still have two more tracks to hear from. Could we get feedback from the other tracks? I saw group 2, Brian. Brian, are you ready to go? Brian, can you hear us? Okay.
Maureen could actually take it up if Brian is not there.
Hi, I was waiting for the host to unmute. It's okay. So this is Brian.
Okay,
yeah,
please go ahead.
Yeah. So for group 2, we're looking at for the second breakout, we're looking at community engagement, and some of the issues that were identified among them. I'll just mention and give recommendations as I proceed. So stigma really came out strongly, especially when it comes to identification and contact tracing from the CHVs. So there was an issue of stigma attached to parents and guardians. Parents are not really coming out in especially disclosing on how the children are keeping up, especially going to the facility and at community level. The other thing was adherence. So on stigma as well, this really impacted on adherence among the caregivers. So as much as CHVs are doing the follow-ups, data capturing is a gap in the number of children that need assistance in terms of adherence. So there's still a lot or much to be captured in terms of just getting more information in terms of adherence. Then there's having the right of information to help parents with their children living in the HIV, support their children effectively. So CHVs need to just be having a full package. As they reach on the community, there's the need for them to provide adequate information on the same as they are tracing issues of adherence and laws to follow up, especially for TB. Then the other issue captured was a lack of comprehensive counseling. So this came out clearly that there's no adequate or comprehensive package in terms of counseling when for parents after testing and diagnosis for HIV. So there's need to put up a help, they can put up a system, or rather a strong counseling follow-up for mothers to move forward in taking care of the children and during the antenatal visits. So this gap was identified, especially when it comes to like just preparation after the testing and diagnosis for parents who've been tested, newly tested, or mothers who've been newly tested. So access to information was another thing that came out. Information in terms of parents lack information or pointers on how to proceed, and that's linked to the counseling. So they rely on peer reviews or community information, which at some point is mostly not accurate and it's misleading. So, and there was the issue of ignorance or lack of inadequate information on HIV and TB at the community level. So there's need to address all the issues affecting the clients, including NCDs. So in as much as we are providing information, just as we did with the corona, or COVID, it's important to just provide the adequate information and improve on systems, especially sensitization and mobilization at community level. The other thing came out clearly was a community focused response. So this was an issue that was really cutting across most of these issues, like that based on all the other issues I've mentioned, most of them were being caused by the lack of community response or focus. So there is dire need, most important need to have community interest at the forefront, especially place more attention on needs to be shifted on the community engagement, and have affected community be at the forefront of the lead in addressing responses. So there's need of having a human-centered design approach in terms of just reaching out to community and providing more feedback and initiating a feedback mechanism for the same, so that it's not a one-way form of communication engaging in the community, but there's a form that also ensures this feedback also being gotten from the community on how to respond or move further. Then the other thing was post-birth infection. So Maureen had mentioned earlier that most parents currently are getting infected, or rather being infected, newly infected after birth. And if they don't go back to the facilities, they end up infecting their children during breastfeeding, because they understand that during birth they were negative, or during the antenatal care visits they found negative. But there's need for them to go back and like get tested even after birth, because it's an issue that's really rising up and also needs to be given attention, it was identified as a gap as well from the discussion. Close to last was a role of fathers. There's still not set out clearly, especially in terms of community level, what the role of fathers are in terms of the PMTCT and the EMTCT. Yeah, so there's need to really place this out clearly, like what role are fathers playing, especially when it comes to the visits and ensuring that we reduce the infections of children, especially during the antenatal care. And the other thing was nutrition. So nutrition as an issue, especially for caregivers who are unable to provide for their families, especially the elderly and sibling-led families, where kids are on, most children are on treatment but are not able to get the proper nutrition to support their adherence, their adherence. So this is a gap identified, especially for caregivers who have children on treatment. Then the stockouts for last year, it was identified that there's an issue of stockout that really came out clearly, especially during COVID. Then industrial strike of the healthcare workers. So this increased the number of infections because there are a number of new births that took place without the interventions of the nurses, and this led to new HIV infections among children. Then lastly, there was data utilization. In as much as you're collecting data from the community, there's evidence that there's not much being used, or that data is not being really utilized in terms of providing responses or feedback in the community. As we mentioned, there's need for a feedback mechanism at the community level, so that if data is being collected, how is it being utilized? So in terms of the responses or some of the actions or solutions offered from the mentioned gaps, one was about community response. We're looking at working with the SCACs, the sub-county AIDS coordinators, and the CHVs in capturing data and indexing identification at household level, because it was noticed that these issues are at the community level, at family level. So there's just need to have a family-centered approach where working with the SCACs and CHVs just to identify these issues. Then this is identification. So community support and structural systems strengthening is critical in enhancing uptake of new generation treatment and intervention. So working with the CHVs and SCACs just to make sure that caregivers are aware of the new generation treatment, and again, just what some of the precautions to take during their visit. Then support groups. So in as much as most being done at the facility level, there's need to strengthen or establish support group systems to aid caregivers with a safe platform to share experiences, just to keep on going as caregivers. There are a lot of challenges that they face and probably go through, which may not be really captured during their clinical visits. So it's just important to strengthen or establish support group systems. This should also be a comprehensive package that also looks at their mental health, especially postpartum depression, because these are some of the neglected areas that are underlooked, especially when it comes to mothers. Then capacity building caregivers, provide adequate information and knowledge to caregivers, especially treatment literacy and support with disclosure and introduction of life skills, especially for adolescent mothers. Yeah. So just providing adequate information frequently. So this should be a continuous process, not a one-time evaluation, and then it's all done within. So it should be something that's continuous, just providing adequate information at the right time and the right place, either at community level or facility level. Then community mobilization and sensitization. So this was an issue that was brought out just through picking as a best practice from the COVID scenario, where there was mobilization and sensitization done, and currently everyone else knows what to do. So if the same approach could be picked as a best practice to provide and empower caregivers in the community with the same, this could really help the community really getting the right information and providing, so like coming up with ways of eliminating these preventions earlier, even before having the help of healthcare providers at facility level. Then peer-to-peer support, which is closely linked to support systems, support group system. So there's need to have peer-to-peer being at the forefront of identification and follow-ups, especially in cases where CHVs are not really ethical or professional in terms of disclosing the HIV status of most of their clients. So it's been an issue, especially leading to stigma in the community, where CHVs are not assuring this confidentiality when they are doing their follow-ups in the community. So for us to curb this, there's need to have a peer-to-peer support, where it's just prudent that we have peers do the follow-ups and identifications at the community level. Yeah. Then if CHVs are the ones being involved, could we have a binding and undisclosure kind of document that will help with having reduced cases of this either accidental or pre-planned disclosure that are affecting most clients in the community, and again missing out at clinical level, especially clinical visits due to the disclosures from CHVs. Then providing alternatives. So in most cases, mothers are just told that to have exclusive breastfeeding. So can they also be provided alternatives apart from breastfeeding that would help them like take care of their children? Because it's as Maureen mentioned, it was clear that there was need to have alternatives provided, just to bring this out clearly for caregivers. Then family-centered approach, as I had mentioned, this is will aid in getting the most accurate information, especially when it comes to data, in terms of the lost follow-up, issues of adherence, how many households are having issues with taking care of their children in terms of treatment access and clinical visits. So just having a family-centered approach, working with CHVs and the peers who have been identified as well, this will really help a lot, and also just bring the community closer in terms of the response. Then strengthening nutritional support. As I mentioned, most families are not able to cater for or provide for the children who are on ARVs or on ART. So it's just key that we also look back in how do we strengthen nutritional support, either at community level or the facility level, to ensure that as we are looking at adherence, we also bring in also remember that there's need for nutritional support on the same. Then partner engagement and involvement. So with this, we're looking at male involvement. This was brought out that in as much as we want to address most of the issues identified, the society is highly patriarchal. So just remembering that we need to bring in the male partners on board to also be engaged in terms of providing solutions or the response towards eliminating the mother-to-child transmission. Then giving a face to the data. This is something that has like entirely been mentioned over and over again.
Sorry, Brian, sorry to cut you short. Kindly wind up because of time. Thank you.
I'm winding up on my last points. Then there's community paralegals, just to address the issues of stigma and human rights issues, especially access to health for mothers, because most of the time they're told you can't access health without having your male partner around. Then decongesting hospitals. So this does need to have facilities be decongested and only have those who need lab access and Medicare to be in the facility, and have some services posed back to the community. So in terms of resources, we really didn't capture much, but what came out closely was working with the already existing structures and systems in the community, and strengthening community response and reporting to partners in terms of data capturing, and then support from SCACs and the county level. So I think that was it from our breakout. Yeah, back to you. Thank you.
Thank you very much, Brian and Group 2 for the comprehensive feedback. We expect that this is also written so that we put together all the actions. Thank you very much. We'll go to the last group that will be led by Peter Muriuki. Kindly be as brief as possible. I'll only give you 5 minutes. Thank you. Over, Peter.
Okay, thank you. Can you hear me?
Yes, we can hear you. Please go ahead.
Okay, thank you. I'll be very brief. On the we were dealing with innovations, leadership, and governance. And on the urgent issues or concerns in this area, we identified there is a need for multi-sectoral engagement in response to TB, more so in light of COVID interruptions, and we need to, in the light of that, something like education, transport, to lower the country from the low burden. Then the other issue was the long distance travel to facilities, the issue of food insecurity, and the issue of OVCs being a big contributor to defaulting in adherence. Then we should also prioritize the role of community and civil society innovation and leadership in pediatric HIV. And we can no longer afford to any shortages on ARVs of commodities. This should be a priority, as you know, this has been an issue of late. The other thing, there's been an established high rate of defaulting amongst faith-based persons. And this comes as a result of the faith healing teaching. So there's a lot of the defaulting from that area, and patients' adherence needs to be encouraged. And on the actions and solutions to address the challenges raised, we identify we need to have a common ground as faith communities about some faith leaders preaching the faith healing that discourage people from the conventional medicine. Then we should also scale up advocacy through engagement of religious leaders, create a safe space for HIV education on evangelical, as this subject is regarded as evil or from evil acts. Then there needs to be financing for research and development. We need to support the response through last mile of the elimination framework, which will be focused on data and help sharpen the PMTCT response in country. This is in its early stages, but in one example of how organizations can contribute to innovate approaches, and this UNICEF said can handle very well. The other thing is social protection related to food security and other social protection programs on TB and HIV. Then there needs to be need to deliberately map our stakeholders. This for better engagement. Then there needs to be health education in our learning institutions. And on the third question on what we need from the other stakeholders, or which other stakeholders we need to collaborate with, we have the private sector, the caregivers, caregivers or guardians, and the civil society. We have teachers or school administrators who interact with the children, and then they can help in sorry, let me take that again. Teachers or school administrators who interact with children living with HIV, and this can help in the stigmatization process, especially at schools. We have the guardians or the parents who have first-hand encounter with the children. We have mentor mothers living with HIV to go out to community, raise other mentor mothers that will take up the same roles. Then we have identified media as a major stakeholder, as it plays a big role in impacting the society. Then we have public health officers, mental health counselors, And then we need to empower community leaders such as chiefs and the Nyumba Kumi initiative leaders who have interaction with these people. Then also our police force was identified as one of the stakeholders. They deal directly and majorly with family matters. Then we also need to involve opinion and market leaders. And we can also engage the Council of Governors to advocate, since they have a political and technical arm. Then we also need to involve curriculum developers, mostly in the Ministry of Health, to incorporate matters of pediatric TB and HIV in the curriculum. Then last but not least, psychology counselors to deal with the trauma. Over.
All right, so thank you very much, Peter Muriuki, for that comprehensive feedback as well. Just to reiterate that was very good discussion within a very short time. Given more time, I want to believe that members would have given even more feedback. So let's not stop there. Let's keep the discussions going on, even in the chat. So at this point, based on our agenda, we needed to open it up for plenary. I'm not sure whether that would still suffice. I seek guidance from Tracy, or do we go to the next agenda, which is session 3? Dr. Momanyi, are you on?
Yeah. So we've just had a discussion with Tracy to allow, I think since most of the discussions have come along during when the presentations were done, if we can allow the next session for the presenters for the PFC section to do their presentations, but then for the plenary, if it's okay with the team that will do that for the for the track sessions for that session, we have them tomorrow morning so that we don't also keep people beyond 5. So we allow for the presenters who shall be doing the presentations. That should be Jonah, Maureen, and Dr. Eliud, if they do their presentations. And then for the track sessions, we have them first thing in the morning, because tomorrow I think we have some flexibility in terms of time. But that's subject to, I think, Teresa, you want to do some back consultations, Teresa? Sorry, Tracy? So I think we can proceed. Maureen?
Yes, I can hear you, Laz.
Yes, so I think, is there someone in the back? Tracy, are you able to just speak to what I've said? So we allow for the presenters, that is Dr. Jonah, Maureen Murenga, and Dr. Eliud to do their presentations. But then for the track sessions, we have this in the morning, so that then will allow people to ventilate on the issues and come up with clear solutions to some of the issues that have been raised, so that we don't hurry people. And of course, also, I think by the time we do the presentation, we'll be coming to 5 o'clock, and we don't want to keep people beyond 5 o'clock.
Hello, everyone. Sorry, I could not unmute. Yes, I think we can go that way so that we let our presenters present for the day, and we can start with fresh minds tomorrow. We kindly ask all participants to come in good time so that we can have long discussions and even just fruitful feedback as today. Over. Thank you.
Okay, so if that's the case, thank you. I will want to hand over this session to the next moderators. Do we allow for a break or what's the guidance? Do we still go ahead with the presenters or have a short break? Momanyi?
Maybe for the interest of time,
we continue, okay.
And just go direct to the next session so that then we just finish at once. And then now tomorrow morning, we shall have the track sessions and the discussions. So I'll propose just go ahead, yes.
So thank you. So that marks the end of session 2. I want to thank you all for your participation, really, and the engagement you've had all through. And at this moment, I want to introduce the next moderators, that is Francis Ndwiga and Cindy, who will be taking us through the session number 3. Over to you, Francis and Cindy. Thank you. Hello, you may need to unmute Francis Benson and Cindy, please. Thank you, and over.
Cindy Amaiza is already unmuted.
Okay, so is it possible for you to make Francis a co-host so that he can start, and then I will continue the rest of it.
Yeah, we could support so that we don't take a lot of time. Okay.
So we have.
Sorry, it's Francis Benson. From what I read on the wall, Francis Benson is Francis Ndwiga. Thank you. Over.
Hello.
Please go ahead. Francis, go ahead.
Yes, you can hear me, Dr. Ali. Thank you very much, team, for that opportunity you have given us. I think for us, we will take the shortest time possible because we are also behind time and we like to cover as much as possible for the day. So I'll invite my name is Francis Ndwiga. I work for Ministry of Health. Currently coordinating PMTCT program, more biased to community-based. And I have a co-moderator, CD, who will also introduce herself so that we can move very fast. And I would request that they can also be able to share immediately the PMTCT program presentation so that I can also do the same very fast. So Cindy, please, can you introduce yourself?
Thank you, Francis. My name is Cindy Amaiza, and I am the National Coordinator for Y+ Kenya, which is a youth-led network for youth-led organizations. Yeah, and I am happy to co-moderate with Francis.
Thank you very much. And I think now we can have the presentation so that we can do so. For me, I'm just discussing some of the key areas that we need to look at in terms of solutions and actions. And this in terms of the support system for mother-to-child transmission, in terms of maintaining them on continuum of care. I'll be discussing areas that are more critical for PMTCT, but more highlighting some of the key information that has already been shared by the previous presentations, but more biased to PMTCT. So the next slide. So for us, what we are looking at is we are looking at issues around what would make it to achieve the EMTCT goal for children in Kenya. That's very critical for us as program. And we like to look at issues around how we can be able to make some game changers, and also looking at issues around how we can also be able to do things differently, but do them right. So that's the key focus for this program as we look at how we refocus and reorganize program in terms of the status where we are, and also looking at how we need to improve this program and achieve the goal of EMTCT as it has been eroded and based on the commitment that the government has for PMTCT. The next slide, please. So for us, we know very well that we have been having guidelines, we have been having frameworks, we have been having we have been having very well midterm reviews. But what is now coming up is that we are not doing very well in terms of PMTCT. And we would like to look at how do we come up with a transition in terms of how we can now be able to look at this program for us to achieve the EMTCT goal. So for us now is the focus is in terms of looking at how we are going to review the framework that is heading this year. We also need to work with our stakeholders and look at issues around how do we now approach our issues on PMTCT differently so that we can achieve the goal for this year. So for us, we are looking at transition in terms of what has been happening and looking at issues that are around the basics that really matters for the change of a PMTCT approach that we're having now. The next slide, please. So for us, we know very well that we end a journey that we started in 2013. We end a vision, we end a mission around what we want to achieve. So the question that comes here is it that because we have a road, is it the driver, is it the vehicle, is it the destination, or is it the mechanic or the passengers that are along in all this journey? So beside the progress that we have and the appreciation that we have, but if you look at the target that we had in terms of elimination, we are still far from where we wanted to reach by the year 2021. So for us, we need to look at this roadmap and see in terms of the commitment that we have as a program, what is wrong. So as we review the framework for EMTCT, we really need to critically analyze where we are and also look back in terms of where we have come from. And as Dr. Masha and alluded in the morning, is that there was some time that we were doing very well. So we need to carry those lessons and be able to build in terms of what we can now be able to strategize in terms of the new approach to this program. The next slide, please. So for us, Dr. Momanyi alluded in terms of the EID, but for me, what I'm interested with is now the issue around the next one, which is the PMTCT. If you look at the PMTCT, we are now at 10.8, but we have come from 12.4 in 2019. But what is very critical is that our focus is to reach at below 5%. So we now need to look at what are these things, what are these missed opportunities, what are these promising practices, what are these game changers that we really need to focus now so that we can be able to reach there. So for us, we are interested in terms of looking at the program challenges that are there and also looking at how we can also be able to come up with and analyze the emerging issues around the program and looking at what are the causes of the new infection that we can also be able to now redirect our investments and also our interventions so that we can make a change. So for these slides, it gives us what is happening now in terms of program, where we are saying that the target is a bit high, but for us, our aim is to reach below 5%. Thank you. The next slide, please. So for us is that these slides gives us now the approach of where we are and what we didn't now need to analyze in terms of these slides is what we didn't need to do. For us, we are at 10.5. Now in 2021 and 2022, what is our focus so that now we can even have a trajectory that is going down? So for me here is that there are lessons that we need to run from 2015 and 2016. What were we doing there? And I think in the morning, our CEO, NAC, and really been able to highlight some of the key things that we were doing very well. And what happened now that those things are not there now. But we also need to recognize the issues around that the program change and the issues that are there. We really need to see how do we now come up and borrow some of the basic lessons, since this program is a mature program that is over 23 years, and we have lessons. How do we package that and give it direction in terms of the national perspective, and also redirect resources to specific areas that we feel that are also areas that we feel that are also contributing to the bigger picture of the new infections, and also in terms of the program performance. So this slide gives us now the question is beyond the 2019, what do we need to come up with? Where do we want to give this line that you now come from 2019 to 2021? How do we need to give it a perspective in terms of that? The next one, please. So if you look at the performance in terms of PMTCT, HIV testing and positivity, you can still see that there are areas that we do very well. And beside the COVID that we are really concerned with, the testing rates of PMTCT still remain stable, but more importantly, we need also to give some more injection in terms of now the acceleration of this kind of approach within the testing, and also looking at how we can also be able to reduce the reduction of infections so that we can also be able now to have a program that is stable and also looking at issues that are more better to inform the program and reduce infection within this country. The next slide, please. So this is one of the slides that is very important. If you look at it, we have the cascade that gives us the HIV coverage in terms of HIV. But what is very critical is the areas around what are the missed opportunities and what we really need to do, and also the unreached mothers. And this is where now the information comes. And I'm very happy with the way the community component has been able to present some of the key highlights in terms of the direction that we didn't need to take. So the concentration here will be like, if you look at the health sector, we have been able to do what we can up to that. But we believe that if we can also be able to invest in the community, some of the key areas around the unreached mothers and also the niche opportunities can also be some of the areas that we can really be able to live to the community or work with the community and really ensure that some of these missed opportunities and some of these unreached mothers can also be able to be reached and then improve the program. So this cascade about HIV coverage, they actually will be able to inform us in terms of now the direction of how are we going to do programming for PMTCT. The next slide. In terms of infant, it's still the same. We also need to look at areas that we have the missed opportunity and they are reached. And what we are saying here is that as we move forward, we'll also be able to look at the critical component of investing and prioritizing the infant as one of the key areas in terms of testing, in terms of ensuring that the PCR is done as scheduled in our guidelines and protocols, and also looking at how do we strengthen the areas around to approach the needs of PMTCT. So it's the same in terms of how do we reach the unreached, and also how do we ensure that the opportunities that are there, we can also be able to identify and give a direction in terms of strategies and interventions that will make us make this program better and also be able to achieve the goal of elimination. The next slide, please. In terms of infant, early infant diagnosis and initial PCR testing, this data is based on January to October last year. And what we can really be able to see is that initial PCR, the levels are a bit high, but if you look at now the positivity and beyond there, the key thing here is that how do we ensure that even the subsequent PCR testing are well achieved as we have done in the initial. So for me here would be like, what are the things that are making us not achieve the same levels as the initial in terms of early infant diagnosis. And this where now we need to refocus and reorganize the program so that also we can be able to give it the best approach in terms of ensuring that this infant are tested equally as the initial and even the subsequent testing that is required in this program. The next one, please. So what is very important for us, we use a conceptual framework, especially now that we have already been able to establish a community-based PMTCT program at NASCOP, looking at issues around how do we engage the multi-sector and looking at policies and actions that are very important for us to really be able to work with other stakeholders, even beyond the health sector. That is very critical for us, looking at that as one of the pillars that is very, very important for us to advocate for other policies and actions that can also be able to support this program. But more importantly also, as Maureen had presented in the morning and as the track on community has presented, empowering people and the community will also be very critical so that everybody can be at the center of the program. And also it can also be able to give a perspective that PMTCT is not only skewed towards health sector or medical component, but it is an approach that can also be able to be supported by everyone in terms of information, in terms of understanding the program, and also in terms of being part of the program for decision making. And that one will also be accompanied by the third pillar, which is now the primary care and essential public health functions as a co-integrated health services that will be able even to include what we have not been able to cover very well, especially the component of TB HIV as we implement the PMTCT program. So this pillar will be very important for us, putting health and well-being of the community being core to be the critical component and the pillars that will be able to guide us in terms of the conceptual framework for community-based PMTCT and even PMTCT itself. Yeah. Next one, please. So in terms of service delivery point, I will not labor on this. This is more important in terms of how do we improve the retention in care among women and people living with HIV, and women and mothers living with HIV. And more importantly, looking at how do we, in terms of systems, ensure that we have maternal HIV testing. We have issues around incision on ALT, and EID is well done in terms of HIV management and also in terms of incision on infant. But what is very important for us is to look at what can make this program success is only ensuring that we didn't maintain our, we didn't ensure that we depend on high retention for mothers and especially the mother-infant pair within the program, which we also learned in the morning. But looking also at issues around the barriers, which are very critical, moving from the component of individual, facility and community and system itself to see how do we now look at issues around those areas differently and also program very specifically to areas that live within the geographical area that can also be able to ensure that the intention is well maintained. And more importantly, also looking at how to improve our data management, especially strengthening the EMR as one of the critical components to be able to cover all the regions that and the service delivery points that are in this country. The next one, please. So in terms of the proposed service delivery solutions, one of the key things is, as I alluded, is the issue around strengthening community-based PMTCT and also looking at issues around people-centered response programming. That is very critical, putting the community at the center of programs, and also looking at how do we strengthen the integration of maternal child health and the PMTCT and even TB in terms of how do we ensure that we have a well comprehensive program which is well integrated and that can also be able to give us the best support for this program, and also strengthening the skill transfer for both the TB, HIV to our service providers, to be able even to ensure that our continuous quality improvement is within the scale that we want, so that even some issues around the delay and also quality of care is well maintained both at the service delivery point. The point of care testing is very critical for us to ensure that we maintain the retention and enhance that. Health promotion in terms of community will be very critical, and also looking at even one of the key components, periodical pregnancy and also sorry.
Maureen.
Hello.
Sorry,
Daktari, can you hear me?
Cindy.
Sorry, Daktari.
I can hear you.
Okay.
Oh, please.
Okay.
Did Daktari finish to present?
Yes, I'm almost.
Finished presenting? Okay.
Yeah.
Okay,
Slide.
you can go ahead and. Okay.
The next slide, please. Okay, so this the second last slides, and one of the key component in terms of the promising practices and the area of investment is actually looking at local ownership and coordination, which is very critical, ensuring that even from the lowest level at the community level, we really work with the leaders so that they can be able to advocate for implementation of this program and the policy directions that are there. Secondly, we also need to look at the service delivery in terms of facility and looking at PMTCT benefits. So we need to analyze what are the key benefits that comes out of PMTCT services. And also as the team and also discussed in the morning is the power of the community is very critical for us. And more importantly, looking at what are the key elements that would make a difference in terms of acceptance of this program and also support the children's space that is required. And finally is the issue of PMTCT service. We need to extend them beyond the facility and look at issues around how communities can also be able to give us the support that we require in terms of the gaps that are there within the program, and also look at how do we strengthen the capacity of both public, private, and FBOs in this level. So it will also be very important for us to look at these promising elements that are very critical for us. The next slide, please. So the future plan is to look at how do we integrate, support, strengthen the collaboration and partnership with other sectors. It's very critical for us to work with other sectors. Also look at how do we institutionalize prevention with positive program, home-based care, work and leverage within the Beyond Zero initiative, and also invest in family health models and mentor mother and father program that is very critical for us, and also see how we integrate this program within the community health strategy, looking at issues around community volunteers and also issues around working with other networks that are very important for us within the component of primary health care concept. And finally, looking at issues around how do we operationalize all these program strategies that are very critical in terms of advocacy, in terms of programming, and also in terms of looking at how do we work with the community service delivery. And finally, the issue around how do we strengthen the health systems for readiness to reach all people, including those we cannot be able to reach, and also align that and also accompany that with the financial support that is required, both from the national and also from the donors' perspective to be able to support this program to the lowest level that is required. The next slide, please. I think it's very important for us to also recognize that the program has a very good support in terms of the political will. So it's for us to make a commitment to be able to make a difference in this program. Thank you very much. And over to my moderator, Cindy. Thank you.
Thank you very much, Dr. Francis. More importantly from your presentation is that you have brought out really the power of communities in your future strategies that you are putting forward. So a really big thank you to you. And so it is my pleasure to introduce the next presenter, who is Maureen Murenga. As you have already heard, Maureen Murenga is a passionate advocate for health, development, and human rights for women and girls. Maureen's passion for advocacy is driven by her lived experience and the inequality and vulnerability of AGYW, especially in the AGYW living in her community. So in response to all these challenges, she founded Lean on Me to support access to health services for AGYW living with HIV and affected by TB in Kenya. She currently sits in a lot of global platforms, such as she's a board member at the Global Fund and also an alternate board member at the UNITAID. So Maureen Murenga will be giving us community responses and solutions and actions related to support systems to retain mother and child in HIV care and routinely investigate HIV, TB, and COVID. So Maureen Murenga, over to you.
Thank you very much, Cindy. I think this should have come before our group discussion, because the group did more justice than this presentation would do. But at the community level, we always say we don't tire in repeating, because if you forget anything, you remember that there were people who kept on saying, we need this, we need this. So next slide, please. Yeah, so like we have had, some of the challenges we have are around preventing vertical transmission to HIV. And you can see we have used the word vertical transmission, because when we call it mother to child, it has a lot of gender-related issues, because the blame tends to go to the mother. and it is the only infection that is linked to the source. For example, we don't hear about boyfriend to girlfriend transmission. We don't hear about husband to wife transmission or rapist to victim transmission. We just hear about mother to child. Yet, even the others are modes of transmission. Yeah, so that's why we try to at least release a bit of the blame from the mothers and call it vertical transmission. So we've had that data shows that most children exposed to HIV who seroconvert are children of young women living with HIV. So adolescent mothers and young women have a great challenge in terms of accessing and adhering to PMTCT, and you have had a lot of people here mention the different challenges, including that they are still dependent on others and they don't have the power to make their own decisions. And then we also know that majority of those in the rural areas do not access pre and postnatal services at the health facilities. We have the nyamreros, or the traditional birth attendants, and usually people say it's not me, that they are better off, because when you cry at the traditional birth attendants, they massage your stomach, and then after you deliver, they give you porridge. But if you cry in the hospital, they slap your thighs. So people prefer where the care is a bit more personalized and tender than where you are slapped and asked who sent you there. So we know communities can, networks of women living with HIV and young women living with HIV can take an active role in community sensitization and awareness creation. And my colleague Patricia said, it is not a selective community awareness, but done in block to create awareness to everyone in the community. And then also those who are pregnant can be linked to community-based and community-led support groups to get various supports, including dealing with stigma. We've had a lot of stigma being mentioned here. We have some of those solutions within our support groups, dealing with stigma, mental health, to advise on care during pregnancy, and to provide treatment literacy, adherence counseling, etc. during the continuum of care. Organizations working on pediatric and childhood HIV and TB should be supported to have functional drop-in centers for more personalized intervention. We have seen that we have maintained drop-in center for key populations. We have maintained drop-in centers for adolescent girls and young women. We need to have those that are children focused as well. Next, please. Then there's the care during pregnancy. For us to get a good outcome, we need women who are healthy, mothers who are healthy and who have the best care for us to get healthy babies. But when most mothers, now I'll go back to teenage, specifically teenage mothers, they struggle with the complexities that they face. They have dropped out of school due to pregnancy. They have tested positive to HIV. They are being moms who depend on others for their well-being and their children. They don't have an income. They can't look for jobs. They're underage. So it is a very, very complicated phase for them to enter into motherhood, which is made even more complex by HIV. And I quote one of them who said, "I'm almost having my baby. It's been the most stressful time in my life. I dropped out of college due to pregnancy. I tested positive for HIV, and without any form of income, I wonder how it will be for me and my child. I have been mostly indoors because people remind me that I wasted all the money my struggling mom paid in school. My boyfriend also left me." So these are not things that, for those of you who have been pregnant and the emotional needs that come with it, this is not the kind of situation anyone would want to be. And therefore, we know that community-led intervention must be strong in offering psychosocial and mental health support, as well as social protection initiatives that will support vulnerable mothers to enable them care for themselves and for their children. Next slide. Yeah, so access to services. Like we have heard from different presenters, there are some mothers who come to the health facilities very late into their pregnancies. And those in rural areas sometimes deliver through traditional birth attendants and do not attend antenatal clinics at all. So this particular mother, I've written her initials. She said, I did not attend any antenatal clinics, neither did I attend postnatal clinics. I delivered my daughter Joy in the house. I did not know we both had HIV till both Joy and I were seriously sick. We took over-the-counter drugs, and when our health deteriorated so much, my family took us to hospital, and that's how we got diagnosed. Joy was very sick, she almost died. So you can see children cannot sustain the virus for long if no intervention is made. And this is where communities come. Communities and networks of people living with HIV, specifically women living with HIV, need to do intensified community outreaches to find the missing children, those that have been missed in the PMPCT cascade. And the earlier we find them, the higher the chances of saving their lives. And there's usually that comfort in telling someone, I have been through this. I have walked this walk. I will hold your hands and help you through this. You will be fine. Your child will be fine. Mine is fine. That really makes a difference. And when we talk about other women living with HIV doing this, it's not that we just want them to get something to do, but it's because of the fact that we know the impact of this person who feels the world is coming to an end, getting someone who has walked that walk successfully, telling them it's okay, I'll hold your hand through it. Next slide. So there's that, there are those who seroconvert during pregnancy and breastfeeding. And at this point, the risk of passing infection to their children is very high, because when you seroconvert, the viral load is very high. And if you don't know and you continue breastfeeding and relating to your child without that knowledge, then chances of passing the infection is very high. So this particular one, I've just initialed their names for the purpose of confidentiality. She said that when she went for antenatal clinic and she tested negative for HIV, I delivered my child and breastfed him. We were enrolled in a program where we would be tested for HIV during every visit. So there are other facilities that are doing some research programs where they test mothers during every antenatal visit to see they're looking at when seroconversion happens mostly. So she was in one of those programs. So she says that when I was a year old, when the baby was a year old, she tested positive for HIV. So did the child and the husband. She says that I can't tell at what point I got infected. I feel so bad that I have risked the life of my child. I cry a lot about this. Like I told you, every woman expects to have a healthy child. So when a child seroconverts, it really breaks the heart of the mother. And this is where we as community members should start post-test clubs for supporting prong one, or for supporting mothers who test negative to HIV. We should also be supporting them to understand that there are prevention interventions that are women-led, because sometimes introducing the condom into the family as a woman comes with a lot of risks in terms of GBV. But we have those women-led interventions such as PrEP and the vaginal ring. And we need to support them to access those ones, and also support them to adhere to them, because if there's no adherence as well, then it doesn't help. So this should happen during pregnancy and breastfeeding for mothers who are HIV negative at the first testing. Next slide. Then we come to feeding options. And we know Kenya implements a breastfeeding policy. Women living with HIV are encouraged to breastfeed their children regardless of their viral load. There is no support for women with high viral load or other conditions that make breastfeeding risky. And we all appreciate the importance of breastfeeding. We cannot say there's a better alternative to breastfeeding. But when you hear a case such as Anne's, where she says, I was diagnosed with TB of the breast and asked not to breastfeed. This is the first time I heard about TB of the breast, and I looked at her breast and it was really swollen with a big wound and it was very painful. Everyone thought it was cancer, but later it was found to be TB. So Anne says, I live with my grandmother who depends on well-wishers for survival. I give my child cow's milk and sometimes I have to dilute it with water. And when we don't have enough, she dilutes it with water when they don't have enough. The TB drugs are strong, and when I haven't had anything to eat, I feel very dizzy. So we visited Anne and we saw how she dilutes that milk. It's very disheartening. It's nothing nutritious for the baby. So nutritional support is important for both mother and the baby. There's need for community drop-in centers to be able to screen for vulnerability and provide food items and replacement feeding for infants who cannot totally be breastfed. Mothers need to be supported with choices for infant feeding. I remember my first job in this area was at Wofak. And at Wofak, we had a drop-in center in Kariobangi and Kayole. And there we had formula milk for mothers who, after assessment, could not really breastfeed and could not afford to give their children infant formulations. So I think these are, when my friend Patricia says we go back to the basics, these are some of the basics that we need to go back to. And then next slide, please. So we have had inadequate supply of HIV infant prophylaxis. We've heard about that here. Most mothers depend on their viral suppression to prevent vertical transmission in as much as we have not been told that U is equals to U works for vertical transmission. And then we also have constant strikes by healthcare providers, making it difficult to diagnose and start HIV positive pregnant mothers on treatment. So this is a comment from a mentor mother. And this mentor mother is from Kisumu, and she says, I find it very heartbreaking when I refer mothers to health facilities and they don't get services. It breaks my heart to know that half of those children who get infected with HIV do not celebrate their second birthdays. We lose them. So the celebration of these children living longer is by everyone, including those who are providing care. So it is very heartbreaking that we can lose these children when we have solutions to save their lives. Like John Ochero said, there is no excuse for having mother-to-child transmission in this era and time with what science has revealed and the commodities available in the market. So here we need community-led monitoring and advocacy. It is very important to ensure that we identify the gaps early in time and communicate to decision makers to find timely solutions for uninterrupted service delivery. And as a good example is what we did when we had the shortages with the nevirapine syrup for prophylaxis. At Lean on Me, we went around working with the mentor mothers to find the mothers who had weaned out their children from nevirapine to bring to our office what was left in the bottle. And then we would share this among mothers who were not finding the prophylaxis in the facilities they went to. So these kind of efforts only happened because we had access to the mothers, we had access to the mentor mothers, we could persuade a mother to give us after she has weaned her child. And it's something that can be done in the community to ensure that even as we are struggling to fill the gaps, then we are also covering to ensure that no child misses services. Next slide. Adherence and retention to treatment is another challenge. And most mothers get to know their HIV status at the antenatal clinic. And option B, which we are now implementing, requires that they are immediately started on treatment. They don't get enough treatment support, including treatment literacy and adherence counseling. Most of them do not even know the names of their drugs. And when they travel without them, it's difficult for them to get the right ARVs wherever they have gone. So this particular one told us, I was given the blue pills in a white bottle. Later, then I was given the brownish ones in a blue bottle. My daughter Joy was given the white pills and a syrup. I used to put our medication in a bag and hang it next to the roof so that people who visit do not see. Later, when Joy's viral load was extremely high, I realized her medication was to be stored differently. So one, she did not know the names of the medicine they were taking. Two, she did not store the one for the Calitra. She did not store it in the right way. She was putting it in a roof in a Mabati house. So because it didn't help Joy had very high viral load. And she insisted that she was giving Joy the medication. Then when we visited and we saw where the drug was kept, we said, no wonder Joy is not getting better. The drug needs to be in a cool place. And because there are no refrigeration, they are told to put next to a pot. There are other innovative ways that they use to store the medicine. So we actually told her how to do it. And Joy's health improved slightly. So community-led treatment, literacy, and adherence support should be offered by the support groups at the community level. One, we don't tell them, oh, this is Nevirapine, Lamivudine, Zidovudine, you know, those tough names that are used. We simplify the treatment literacy session. We tell them names that they can remember for their medication. And therefore, it becomes quite interesting. We really personalize it, and then they take ownership. And a good example of personalizing treatment is when we brought treatment as prevention. And we said this is a good solution for prevention among people living with HIV. Most of the people were like, why is it our role to prevent HIV from others? Why can't everyone just abebe msalaba yake when you call it treatment as prevention? But when the same thing was later changed and called U is equals to U, and infected is equals to undetectable is equals to untransmittable, it came home to the individual, and we are like, there are benefits to treatment. So if I am undetectable, then I cannot transmit the virus to someone else, and then my life is gonna be healthy, and stuff like that. So the benefits, the U is equals to U campaign brought the benefits back to the individual more than the treatment as prevention campaign did. And so that kind of personalizing the benefits is what we used at the community level during treatment literacy. And the results are usually amazing and long lasting. Next slide. So the newer commodities we've been asking for. We know about the point of care EID and viral load that were piloted by PEPFAR and CHAI. And at some point we thought we were in heaven because a mother would be tested just when they are going to deliver and they're told your viral load is this or you are virally suppressed. And then when the baby is delivered, immediately after they can be tested so you know what you are going to face and you are carrying, and the results are timely and you just get them on point. There's no waiting time, there's no panic, you know. But that one changed again. So we are back to square, it's not even square one, we're actually back to square zero. So this ES said, when our children are tested, it takes too long to get the result. It makes one very anxious and sad, especially when you see your child's health becoming worse and nothing can be done without the PCR results. And then they fall ill. If you're lucky, they survive to get the beta drug that is hard to store, especially if you live in someone else's house. So this drug that has to be stored either under the pot or somewhere else. This particular lady who said this lives with her sister, and the sister knows that the child is on Caletra. But if the husband of the sister knew about it, she would send this girl home. She's an adolescent. She would send her away and her sister is the only surviving relative she has. So it becomes very difficult for them to store the medication next to the pot. They put it in a pot of water under the bed, and it's a one-roomed house, and they are usually panicking when the husband to the sister goes around looking for something. So these are some of the complexities that these adolescents live in, because if she's sent out, the sister has only this husband's home as the home, and she's in there with her sister. If her sister is sent away, then they don't have another existing close relative who will live with her sister. So it is really, really a challenging moment for some of these adolescents. So we need community-led advocacy and community awareness to create demand for point-of-care commodities and optimal treatment for pediatrics and children. Advocacy and research should be supported at community level to ensure evidence-based interventions. Next slide. I think it's over. Thank you.
Thank you very much, Maureen. Mainly for putting a face to the struggle, to the challenges that these mothers face, so that we do not see them as just statistics and, oh, one person was infected or one person is not adherent. So thank you very much, Maureen, for the putting out the lived experience of these mothers onto our knowledge. And so it is my pleasure to again introduce the next speaker, Dr. Eliud Mwangi, who is a medical doctor, a public health expert, and a development sector executive with over 15 years of experience. He is the current country director for EGPAF, an international organization with a mission to fight for an AIDS-free generation. Prior to his current status, he served in the senior management at ICAP. And so Eliud will be presenting on leadership and governance to support retaining mother and child into care and routinely investigate TB, HIV, and COVID. So over to you, Eliud.
Yeah, thank you, Cindy. Thank you, team. It's now it's actually 5 and we are still here. It just shows the zeal we have for our mothers and children. And I just want to take not a very long time just to share my thoughts on this topic on leadership and governance. Because listening from morning, we have the what we need to do. We even know how to do it. But the question is, maybe why are we not making the progress that we need to make at the speed that we need to make? And I just wanted to just share, thank God that a lot of slides have been covered. So I'll just be able to go straight to the ones that I really feel I need to mention. And this is the proposed solutions. Whatever I have just passed by, these are all data that the teams have shared. And I want just to take some time, and I hope some of these solutions will get into the action plan that will ultimately be followed through, because at the end of the day is how can we follow through whatever we are saying? How can we translate all these ideas we have talked about since morning to the county level where things happen, and not even to the county, to the facilities, to the community level. You have heard what Maureen has shared. And it is hard work really to translate all these to the facility, to the patient level, and ensure that we have the impact that we are looking at. Clearly, there's a lot that needs to be done. We have made progress, but sometimes you feel maybe it's not enough, the progress we have made. And I also want to challenge all of us, including myself, if for sure the biggest challenge we are having now in HIV is among children, adolescents, and mothers, PMTCT, when you go at the facility level, do we have a focused approach to our children, to our mothers, to our adolescents? Do we have this, maybe a team or a champion for our children at the facility level? Are we integrating the community initiative that Maureen has shared at that level of the facility and the community? Because that's really where things happen. Those are some of the challenges that I want us all to think about. Maybe I want to first start with the EID, early infant diagnosis. EGPAF was part of the pilot. We piloted this over 3 years. We were able to roll these in 12 counties. Very clear data showing that point of care for EID works. It was able to reduce the turnaround time from an average of 52 days. We did this in a certain sites across these counties. Actually, to one day, an average of 1 day, because people would get results the same day. Reduce the median turnaround time to 0. Reduce the percent of newly identified HIV-infected infants initiated on ALT, or increase this from 71% to 98%. And we clearly saw a lot of reduction even in mortality, because all those children who are timely identified were started on treatment in a timely manner. So my challenge to all of us today is that we know it works. We know we have a few point of care machines that are working. So from this meeting, can we have a very clear target that we need to increase the point of care for early infant diagnosis from the current, maybe the ones that are working might be less than, I had 67, but maybe the ones that are really working with the reagents might be very, very few. Can we have a target saying that this is the way to go? Then we are increasing, and this is a commitment. We are increasing to this, and maybe in 5 years, we are rolling it out to this number. And then we'll be able to monitor this, because we can come here, we know it's a good idea, but if at all we don't execute, we don't have targets, then it will just remain a good idea. And I must say that the funding has to come from the counties, from the national government, and also from other partners, implementing and developing partners. This is another one that we also did, and this is about, it's called PACE Initiative, where we're trying to identify the children. We are keeping here asking ourselves, we only have a very low ALT coverage among children. Globally, I think about 37% or so. So where are these children? And we implemented a very intensive case finding for children. That was last year. And within about 6 months, we were able to identify 134 children. And this was going very deep. You go to the facilities, look for all those mothers who have ever been infected, go back to find out about their children, go to the community and find out whether they were tested, if at all they were not tested, test them. Look at even the widows, because we know that some of those children are orphans. So if at all you have widows in the community, work with the chiefs and the administration to identify those households, send people there to test them. And in 6 months, we're able to identify about 134 children. So they are there. And this is over and above the ones we identify routinely when they come to the facilities and so on. But it requires a lot of intensified and focused attention. It requires, all of us putting our minds and saying, in this facility, we have even somebody who is championing this cause for children. I are collating and putting all these ideas together so that we can be able to have a focused and intensified attention to our children and our mothers. And we shall be able to identify these children. This is another area that is also a critical area. Children are failing treatment. They are failing even second line. And you know that we have a challenge or even third line as we speak. And I know a lot is being done to sort out this. And we went ahead and found, we really had a very intensified focus to really look at those children failing treatment, ensure we identify them, do whatever is supposed to be done. That is do the ESC, enhanced adherence counseling. The ones who still don't suppress, take them to through the NYAWEST or through the technical working group at the regional level for for discussion. Then have the DRTs, and then finally the ones who have failed treatment, put them on the right regimen. And from the 443, you can see that we were able to identify about 27 who had failed treatment due to mutation. But thank God, majority of them were due to adherence or other reasons. They did not have any mutations. And clearly within about 5-6 months, we had been able to work out all these, ensure they have the DRT, this is a drug resistance testing. And you know, it is not very easy. It's a bit difficult. We actually have found out that for a child failing second-line treatment, it takes up to 6 months, up to 1 year, actually to change them to the third-line treatment. And these are the children that are actually dying because they are on the wrong regimen. And we really need to go back and look at our counties, at our facilities. Who are these children failing treatment? Can we ensure we fast track them? Can we work on them with speed so that they get the right treatment so that we save their lives? We also went ahead and maybe analyzed a bit here, and you can see on that box that we found that those who failed treatment and had mutation, who are true failures, about 41% had both parents, about 56% were orphans, partial orphans, they only had one parent, and about 4% had one parent. But the next box is even more, enlightening to us that majority of them, 78%, are in schools. We know that we have a lot of challenges when, our children are going to school with their medication. More so even for those ones in boarding is even a bigger challenge. So most of the ones who fail treatment actually are the ones who are, in school. The ones who are not in school were much fewer. And then whether they were in OVC program or not, majority were actually in our OVC programs. Then the TB perspective, just to shed some light, we also know that over 50% of children who have TB are not diagnosed. And we went ahead and had this very, very intensified project. It's called CAP TB, just to diagnose TB for children. And it involved a lot of contact tracing at the facility, going to the community, putting in place issues of gastric aspirate, where you train the healthcare workers on the same, so they can be able to, get the aspirate or the sample from the stomach for the gene expert testing and so on. We also went ahead and supported the X-ray for these children and organized in a way that it would be interpreted by experts in Nairobi. It's a very nice, very easy way now, using the digital, there's a digital way you can just send those films and then somebody is interpreting them from wherever. That's what somebody required to increase the diagnosis for children by 53% within 1 year in Turkana County. It was a few sites, not the entire county, but you can see that the TB cases for children 0 to 14 rose from 184 to 282. And the rest, you can see the IPT also rose by 154% from 82 to 208. Successful contact tracing by over almost 400%. So what am I trying to say? These children are there dying in the communities with the TB, but it requires a lot of intensified support. I heard Joseph, I think Joseph Dai, who is the honorable CEC, in charge of all the other CECs, the caucus for CECs, saying that, these are the simple things that we need to do. And from here, all these we work with the national program. So it's something that can be rolled out because it has been tested. And we get those children who are failing treatment, who are getting TB and not being diagnosed. It's not very difficult, it's possible, but it requires very focused, intensified attention for us to be able to diagnose those children who are dying of TB and ensuring that they don't die from TB. This is Homa Bay, also similar kind of results. You see, we increase the number of TB cases among children, although the numbers are fewer by 100%, and so on and so forth. Meaning that when you see the data that we are not diagnosing more than 50% of children is true, because whatever we can double this within a very short time, then it means it's possible. And this is among the interventions we did. We'll share this slide so that you can be able to see. And if at all you need any details, we are here to support and shed more light. So what am I trying to say? I want to say that in terms of leadership and governance, it is really moving it from, the discussion level, taking it to the county level, taking it to the facility level, and having systems and structures to support pediatric HIV and TB programs both at the facility, but also at the community level. We also know that we need to ensure that we have minimal or no service disruptions. We know we have had a lot of issues with HRH, Human Resource for Health. When they go on strike, you know that our mothers don't go to facilities. They know that there's nobody to take care of them. When we have the lockdowns, the same thing, and these are the mother and the child are the most affected. And therefore, the service, the health system strengthening, the whole component of HRH service delivery commodities is so critical that all these, we ensure we maintain them. Otherwise, we might keep talking about what we are saying, but one strike causes a very big damage to our progress. Lack of commodities, I mean, within no time reverses whatever we have worked on for many, many years. Focus on identifying children earlier as possible, and the point of care that we have talked about will be critical. Optimal ALT formulation for women of reproductive age and children. Then combination prevention packages for AGYW and children. We need to integrate the PrEP and all the other prevention packages. The differentiated model of care that we have kept on talking about, especially the one that involves the community. And that's why my predecessor, that was Maureen, brought out a lot and even very emotional kind of stories in the community. This is what we need really to turn the tide. Then integration of services. And then I think finally is the community-based approaches. So that's what I had to say. And I wanted just again to challenge all of us. Can we take what we are discussing from here to the county, have system and structures at the county level, at the facility level, at the community level, have champions, and have a very intensified, focused approach for our pediatric HIV and TB programs. Otherwise, we shall still lag behind achieving whatever we need to achieve. Thank you all. God bless you.
Thank you very much, Eliud, for the presentation. It really had a lot of information that is really useful to us as even the community. And I would like to hand over this the next part to Dr. Lazarus Momanyi to close the day. As we all know that tomorrow we will start with the session on the group work. So please go ahead, Lazarus.
Thank you, Cindy. And just for me also to appreciate the presenters for this afternoon session who have stayed beyond the time just to be able to present. That is Dr. Ndwiga from NASCOP, Maureen Murenga, who also shared very touching stories from the community. And I think a lot that we've learned. And also Dr. Eliud, my former boss from ECPAF, for very good and compelling data on, and some of the interventions that has really come and challenged us that we really need to take it from this boardroom or from these discussions and take it to the ground, the facilities and the counties. So thank you so much. And you'll agree with me that today, it has been quite revealing, very informative sessions, very eye-opening remarks and presentations. And I think even from some of the track sessions that we had, we've been able to identify very clear issues that need to be addressed. So this session is not yet complete because we still need to go back to the track sessions tomorrow morning, the respective track sessions now to single out some of the things that have been said. For example, from Ndwiga's presentation, there were clear issues. From Maureen's presentation, there were clear issues around community and how best we can support mothers who are having the struggles that she mentioned. From Dr. Eliud's presentation, there are also very clear issues around what needs to be done around like the point of care, around diagnosis of TB in children, around supporting children who are failing treatment, who need to be transitioned to optimal regimens and their adherence. So we shall have that session tomorrow so that people are fresh enough, and also because those are very critical issues that need to be discussed. We don't have to be hurried discussions. And also knowing that people have sat through the day for, long hours, so they also need to take a break. So tomorrow, the session starts at 9. We shall meet for a short plenary, just to have some quick reflections for 15 minutes. And then after that, people will be assigned to the groups for the track sessions for discussing these issues around PMTCT, basically from this session 3. So the meeting should be at 9, and we really want to thank everyone who has been here. I don't know whether we have any, Tracy, do you have any other announcement you want to make, or from the IT team?
Not from my end.
All right.
Not from the IT team either.
Okay, but Tracy, remember you had made a request to the organizing, the committee, the specific people, just to meet and reflect. How do you intend them to meet? Tracy? Okay. So meanwhile, then I think we'll meet tomorrow at 9. Do we have any volunteer who can pray for us as we end the day?
Let's pray. This is Janet.
All right.
Father, in the name of Jesus, we want to thank you because of the wonderful and successful day that you have made for us since morning when we started this meeting. And now it has come to an end, the first day and the first session. Jehovah, we really give you thanks. Our hearts are filled with gratitude for the success that you have accorded to the meeting the day of today. And now, Lord, we want to commit ourselves unto thee, even as we break out for this day 1 and commit the following day, tomorrow, before you, that, Lord, you shall go ahead of us, make everything a success, oh God. Be with us, Jehovah, and every plan, every intervention that you are coming up with, oh God, we pray that it shall be a success to our country. In Jesus' name we pray. Amen.
Amen. Thank you, John. See you all tomorrow, and have a restful evening.
Thanks, Dr. Laz. Thank you.